Hardik, let us know when we are starting.
Just 30 seconds, ma'am. We are almost ready.
Okay, is this the function that is put up in Mahatma Gandhi Hall, this program for the delegates?
Yes.
मुझे वहां से एक बॉटल दे दो ना पानी का. Dr. Samir Dani, can you unmute and your video also, if you can just be visible?
Yeah.
Okay, because we'll start in 30 seconds now. And I see Dr. Prafulla Kerkar, Dr. Dharmendra Goyal, everybody has joined, Dr. Altamash. We welcome all of you. We'll be starting our inauguration, so I won't get a chance to talk to you right now. We have with us Dr. Pratap Reddy already. He's chairman of our Apollo groups. So Hardik, give us a cue. Looking smart, Prafulla. You're muted.
No, dress for the occasion.
Thank you. Yes, yes. Yes, Hardik, please tell us.
Yes, ma'am. Just 5 seconds.
5 seconds ही कर रहे हैं. Getting worried. This, you know, is my.
Yes, ma'am. Yes, ma'am.
Are we live?
We are
live.
We are live now. We will start. Just 5 seconds.
Good afternoon, everybody, and I welcome you all to the Global Cardiometabolic Conclave. This is Dr. Rucha Mehta, and I'm coming to you digitally and live from Ahmedabad, and it gives me great pleasure to have all of you with us today. I would like to invite Dr. Samir Dani, who is head of our cardiology services at Apollo Hospital CVHF in Ahmedabad, to please give a welcome address.
Can't hear you.
So you need to unmute yourself, Dr. Dani.
Good afternoon, all of you, and a warm welcome to Global Cardiometabolic Conclave. Thank you, Rucha. We know that globally, diabetes and cardiovascular diseases have been on rise, and obesity and metabolic syndrome have been the strongest reasons why they are on rise. And we as a cardiologist have been treating cardiac diseases, especially coronary artery disease and cardiac complications of diabetes since long, with disease modifying therapies to improve quality of life and to improve survival, but long after disease has already developed. We know now with more surety that the strategies of primordial risk prevention and primary prevention, where you prevent the development of the risk factors and prevent the development of the disease by curtailing the risk factors, works better than treating the disease once it has developed. It is always better to develop an approach which is patient-centric and not disease-centric. And that's why we believe that partnership between cardiologists, diabetologists, endocrinologists, general physicians, nutritionists, and even physiotherapists, all, when they come together, it will work to reduce acute events associated with cardiometabolic risk factors and disease, particularly among those who are at higher risk. So with this, I give the mic back to Dr. Rucha to introduce our first guest of honor.
Thank you very much, sir. And for this purpose, we all know that in the past several months, we have been suffering from a great disaster that has not only just struck the country, but also the world as a whole. And this is, of course, the COVID-19 crisis. So we have with us today to just give a few words of wisdom and pearls about COVID and how things will work in the digital era. And I welcome Mr. Shivanand Jha, who is the Director General of Police, the DGP of Police, Gujarat. And I would like to ask Hardik to please play his video that he has sent to us. Unfortunately, duty calls and he was unable to join us himself, but he has sent a recording and we will be playing it for all of you today. Over to our event manager.
Greetings to all. The Indian Police, as a frontline agency, is striving at multiple levels of service delivery, living up to an ever-expanding list of job roles as health-related crisis due to COVID-19 spreads across the country. The enforcement of lockdowns have been one of the most challenging of the responsibilities of the police and the other governmental agencies face in this most populated democracy of the world. The pandemic-related job role of the police extends to the utilization of the police domain experience of crowd control, public order management, investigation of criminal acts, deterrence of law-breaking behaviors, and intelligence collection of antisocial activities. The acts of not obeying quarantine requirements, defying home stay or hospital stay rules, and concealing the contact history of those who catch the infection have invoked essentially public health measures which require actions related to the domain of police expertise. The activities of enforcing a rule-compliant behavior and contact tracing of infected people are activities which are related to the skill sets in which police have a domain experience. As the lockdowns progressed, the role of the police in the pandemic extended to another huge area of state responsibility, and that is assistance of the crisis-stricken vulnerable, the poor and the helpless, who required urgent help in transportation to hospitals, supply of essential commodities, food and relief resources. The police now stands at the center stage of this health-related crisis, placing the police staff next only to the health workers as important agents to render services for mitigating crisis amidst high levels of expectation from them in wake of widespread fear and insecurity in the society. An insistence on an exercise regime, yoga, to boost the body immunity was also advised. Video conference was done on a daily basis and events of the day were discussed, analyzed, and where required, corrections and solutions were found. We worked as a united team and it helped us in getting public acclaim for our duties on the front lines. Thank you very much.
And with that, I would like to thank Mr. Shivanand Jha for his wonderful message. He's truly right that there have been lots of frontline warriors. Even though as healthcare professionals, we would like to think we are along the front line, we must certainly not forget the other services that have stood side by side. And I don't believe without their help, this could be, achieved, what we have been able to achieve or we still need to achieve. Secondly, Mr. Jha, also, I really thank you for supporting our digital conclave. Keeping in mind the government guidelines, we have planned this digital conference, which has truly enabled us to bring not just one expert, but experts from all over the world in their fields that we need to use textbooks about as students, and we can do this. And Mr. Jha is himself a big believer in fitness and health, and as he mentioned to you, yoga as well. So I really thank Mr. Jha for this. I will now ask Dr. Sameer Dani to introduce our next guest of honor. Dr. Sameer Dani, over to you.
Thank you, Dr. Rucha. And who doesn't know our Dr. Pratap Reddy? In India, everyone connected to healthcare knows Dr. Pratap Reddy's name. He, after the age of 50, having an established, successful as a doctor, he decided that something must be done as far as healthcare in India was concerned. And he was the first one to establish a corporate healthcare chain in India. And he's been responsible for all these years in establishing and in striving for international standards of healthcare in India. He has been awarded Padma Bhushan and then Padma Vibhushan, which is the
Hello, Dr. Dani.
Hello.
Yes, sir, you are audible.
Yeah, I lost audio in between. Dr. Pratap Reddy, in short, is a legend amongst all healthcare professionals, everyone connected to healthcare field and even otherwise. He is very well known nationally, and he has been listed consistently and in the top 50 most powerful persons in India. I invite Dr. Pratap Reddy to say a few words of wisdom.
Namaste and thank you. First, my congratulations to Dr. Sameer Dani and Ruchita for bringing the first time into the country global cardiometabolic conclave through Zoom. I think it's very important that we need to learn, we need to give, we need to bring things for the welfare of people all over. I think I must congratulate the Director General of Police, Dr. Shivanand Jha, for the great work that the police is doing along with the healthcare people in this critical pandemic situation. Sometimes, whenever I see them on the road stopping people and preventing all sorts of mischief, I think it's commendable the work that they are doing around the clock. Thank you, Shivanand. And through you, I thank all the police force across the country for able to maintain this discipline while we are fighting with this pandemic. The global metabolic conclave coming to India is a very important thing, and I think we need it because India is now not the diabetic capital of the world, but is almost there. We're second best next to China. But if you look at the obesity, even in obesity, we are not number one by percentage, but if you take by numbers, we're still very high. I remember just recently, I got into a lift and 2 or 3 others joined, a husband, wife, and daughter. The lift wouldn't take off. Then I got down. Still the lift won't go up. Then the daughter got down, then only it went up. So I think this is what this is India. And this is what we are seeing more and more. And now to see this in schools is very, very sad. So I'm happy that you have brought this conference and talk to people about saying prevention of diabetes, control of diabetes, and the factors associated with it, like obesity, will make a very significant impact. As far as cardiology is concerned, Samir has shown that part of the world that what cardiology can make a significant impact in people, especially the Asian heart disease we know occurs at least 3 decades earlier. We're getting people at a university who had 20 people who had acute MI. So this is what, and these are all below 40. So I think even for this, we need to understand what are the various risk factors, how the metabolic syndrome will aggravate or bring the disease on fairly early. I think it will make a significant impact. We should talk about prevention of NCDs. On the NCDs, the diabetes as well as the heart disease take a very, very prominent role, and especially in countries like India. So I'm very happy that today you are bringing all this together. Ruchita, hearty congratulations for organizing this. Samir, you've always been on the forefront. But I must thank the international faculty. I see who is who we're going through, but I see Ralph here and Steve. And I also see somebody from my old Harvard, Dr. Akshay Desai from, I was at Mass General. So it's nice to see a Harvard graduate. I'm happy. The international faculty, a large number of them are participating in this. This is what makes us. If I have made a difference in healthcare in the last 30, 40 years, yes, it is the wish of people. But if the medical profession, if they could do it, because we continuously strive saying what more we can do, how can we do things better, how can we coordinate with each other. This, I think, is a very typical example of what you have done. I congratulate Samir and Ruchita for this wonderful conference. God bless all of you. And this should make a very big difference now, because most of the people are afraid of staying at home. So they are more or less neglecting the other problems or aggravating the other problems. Probably eating and not doing enough exercise because they're afraid to go outside. So I think, I hope that this conference will make an impact in reducing these incidents and making us a healthy and a happy world. Because the happy, today, the word happy, I think sometimes says, what are you saying? In this pandemic, when people are in panic, you are saying happy, but we will do it. And the doctors have always stood up for it. I'm sure in this too, doctors and the scientists and the other supporting staff and the government will all help to see that we get over this crisis. God bless all of you. Again, my good wishes for all the participants and my special thanks for the faculty who have come from across the world. Thank you.
Thank you, sir, for very wise words and for encouraging us. I'm sure with your blessings, this conference will be a great success.
Thank you.
Dr. Rucha, over to you for lamp lighting ceremony.
Thank you, Dr. Reddy, for such wonderful words. And as Dr. Dani said, we are truly encouraged. And now I believe we should light the lamp and let's observe a moment of silence for all those who may have lost near and dear ones in the past 4 months or are suffering due to this COVID crisis and otherwise. So may we please observe a moment of silence for the lamp lighting.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीप दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you so much. And now if we can play the national anthem, please.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Once again, I thank everybody for being here, and we will just go ahead and start our program with a small welcome video that will take you into this galaxy of science and knowledge that we have promised. And we have brought you all the stars from all over the world. And hence we have named this the Global Cardiometabolic Conclave. Once we saw all the faculty who so willingly and without hesitation agreed to go ahead and participate in this. So may I now please play a small inaugural video, after which we will start our ceremonies and our programs right on time at 2 o'clock for our first speaker. and I hope you all enjoyed this video. And with this, may I now please invite our chairpersons for the first session today. So can I please invite, can we please have the first slide for the chairpersons? Yeah. So I now have the pleasure to invite Dr. Purvi Chawla, who's a senior diabetologist at Leena Diabetes Care Center, and she also is the director of research over there in Mumbai. And I also have the great pleasure of inviting my colleague and my partner in crime at Apollo Hospitals. He's the head of Department of Endocrinology, Dr. Ramesh Goyal, and a senior consultant endocrinologist. Over to both of you to please be our opening chairpersons for our sessions today, and we wish all of us a great academic feast this weekend. Dr. Ramesh Goyal, I will hand it over to you. May we have the first slide, please, for the speaker?
Yes, ma'am. Just one second.
Thank you, Dr. Rucha, and I wish you all the very best, you and Dr. Sameer Dani, for this fantastic global cardiometabolic conclave that's arranged. Dr. Ramesh Goyal? Sir, you are on mute.
Good afternoon, friends. At the outset, my thanks to Dr. Rucha and Dr. Sameer Dani for giving me this opportunity. And I also thank them for Dr. Anup Mishra. And Dr. Anup Mishra was my professor at the All India Institute of Medical Science during my DM residency days. So it would be my privilege and it would be my honor to be a chairperson in his symposium. So Dr. Purvi, can you please introduce Dr. Anup Mishra?
Yes, sir. My pleasure and my absolute honor. Dr. Professor Anup Mishra is, can we have this slide? Yeah. Executive Chairman, Fortis CDOC Hospital for Diabetes and Allied Sciences, Director of National Diabetes, Obesity and Cholesterol Foundation, and President of Diabetes Foundation. Sir is respectively the Editor-in-Chief for Diabetes and Metabolic Syndrome, Clinical Research and Reviews, also Associate Editor of Journal of Diabetes, European Journal of Clinical Nutrition, and an esteemed member of the Academic Board of British Medical Journal. Sir has his keen interest in diabetes, obesity, and nutrition, and has been bestowed with Padma Shri in 2007, the 4th highest civilian award in India, and also the Dr. B.C. Roy Award in 2006. Nobody better can deal with this topic in India as Professor Dr. Anup Mishra, cardiometabolic syndrome and its ramifications. Welcome, sir. We humbly welcome you.
Thank you, Purvi. Thank you, Ramesha. First of all, let me thank Rucha and Dr. Dani for putting together this wonderful program. It's not easy, I know. Getting all the stalwarts from all over the world is one of the most difficult jobs and to coordinate. And so it's wonderful, something which I'm seeing for the first time. And I must congratulate all of you once more. My job of an opening batsman is very clear to give you the ramification of the cardiometabolic syndrome. And since my work over the last 25 years or so has been on this syndrome and obesity in the Indian population, I have slightly diverted this topic to Indian population or South Asians overall, and I will give you recourse to some of my research or our group's research to make a point. Now, this is what Muhammad Ali said in 1966, different strokes for different folks. And so this is our frontline paper, which has been quoted more than 1,000, cited more than 1,000 times, obesity and metabolic syndrome in developing countries in 2009 in Journal of Clinical Endocrinology and Metabolism, where we put together the knowledge then of this syndrome. But then since then, many other things have developed, and I will try to summarize some of those findings in the subsequent lecture. This is the throwback in 1980s, and where Gerald Reaven and others defined the insulin resistance as a cellular concept, resistance to insulin-mediated glucose uptake at the cellular level. And they also defined that it may occur in normal people, but more likely to occur in obese people. Then became in 1990s, this was slightly changed to insulin resistance syndrome to have a little bit more clinical focus to this insulin resistance, and their number of linked conditions were defined, that these conditions are linked to insulin resistance, and I'll come to that a little later. And then Scott Grundy, with whom I had fortune of working for 3 years, defined the metabolic syndrome, which is primarily for clinicians and based on the lipids, blood glucose, abdominal obesity, and so on. I'll show in this next slide. But he also defined that this is a forerunner to diabetes and coronary artery disease. This is the clinical importance of metabolic syndrome. Now, this is the, in general, the plethora of or the expanse of insulin resistance and related conditions. And also within that is metabolic syndrome. So insulin resistance, which is identified by hyperinsulinemia in the simple terms, is linked to glucose intolerance, increased triglyceride, decreased HDL cholesterol, hypertension, endothelial dysfunction, and somewhere there are a small dense LDL. I'm not going to pathophysiology of it, and hypercoagulable state. But central to all this is abdominal obesity, which is particularly important for Indian population, and all this leads to diabetes and atherosclerotic cardiovascular disease. The number of conditions which have been subsequently linked to this is subclinical inflammation, intramyocellular triglyceride, hepatic steatosis, and HIV-associated lipodystrophy. Now, some of these I will dwell in my lecture. This is our seminal paper on base circumference cutoff point for Indian population in 2006 in International Journal of Obesity, which led to revision of the definition for the waist circumference for defining abdominal obesity in Asian population. This is the sort of a relationship between obesity, non-obesity, type 2 diabetes, metabolic syndrome, and cardiovascular disease. And to particular importance in this session will be non-obese people. Non-obese people can also have insulin resistance. They can become obese, and with the risk factor, they develop metabolic syndrome. On the other hand, non-obese people who are insulin resistant may also have associated risk factors and may develop metabolic syndrome, which in both cases may go on to develop type 2 diabetes mellitus or cardiovascular disease. So in short, this is the relationship. Now, this is a very good study, which Dr. Gujral from USA had put together. This shows that Indian population or South Asian and USA a little different from the rest of the population. And look at this, the number of ethnicities that they have compared, the whites, the Chinese, African, Hispanic, and last is South Asians here. These are normal weight people, overweight, and obese people. And this is the metabolic, the abnormalities. And if you see, the Asian Indians have highest metabolically abnormal phenotype even when they are normal weight. Look at this, look at this. And they have metabolic normal is the least and metabolic abnormal is highest. And in fact, it's very interesting that this sort of a phenomena is not very well seen in overweight or obese people. So whatever is happening at upper limits of normal weight and or normal weight individuals. And why is this occurring? I'll come to in a minute. Now, when it is occurring at a BMI which is very, very low, 19.6 BMI, the metabolic abnormalities are increasing at a rapid pace here. Look at this graph. The slope is so acute and versus the rest of the other ethnicities. So it is occurring fairly early in the normal BMI or even low normal BMI range. And similar thing has been shown by others. You see here, when does diabetes develop? At a lower BMI level in Indian population as compared to Chinese and blacks. And combined together, these data plus our initial data on BMI led to rethinking of the BMI cutoff for definition of obesity in the worldwide South Asian population, and also when we should screen for diabetes at a lower BMI level for South Asians. Now, this is a very good study which was done by Jaspal Kuner in 2001. 20 years have gone by. There is nobody to surpass this particular study. They used a hyperinsulinic euglycemic clamp to define insulin resistance or insulin sensitivity, whichever you want, way you want it. On the top is the most insulin sensitive people, and at the bottom are the most insulin insensitive or resistant people, and that is Asian Indians with myocardial infarction. Now, very interestingly, British people with myocardial infarction had same insulin sensitivity as Asian Indians who did not develop myocardial infarction. So our insulin resistance level is so high as to other ethnicity already having a heart problem. And then let's come to the second part. And George Orwell in 1950 said, "I'm fat, but I'm thin inside, but there is a thin man inside every fat man." I think for Indian population, it is the other way around. We are thin, but there is a fat man inside. Look at the comparative data between European, Chinese, and South Asian. Again, old data, 13 years old, but very good study. They compared the body fat, total abdominal fat, subcutaneous abdominal fat, and visceral abdominal tissue in these three populations. And look at what they found. They found that body fat is very high as far as South Asians concerned, a fact which has been shown by us and others also. But more importantly, it is the subcutaneous abdominal fat which is very high, 309 versus 221 here and 265 in Europeans. Is actually that this difference is the highest. But everybody says intra-abdominal fat is very high in Indians and so on. It was not very high. It is similar to Chinese and European. It was the subcutaneous abdominal fat which showed a stark difference as far as South Asian versus the other ethnicities. And subsequently in India, we using multiple modeling techniques showed that it is the subcutaneous abdominal fat here on the top, as compared to intra-abdominal adipose tissue, which is also called visceral adipose tissue, was more related to metabolic syndrome. We did a number of statistical modeling to prove that. We almost a decade when we published that. Now, it is subcutaneous abdominal tissue which is important, but there are layers in subcutaneous abdominal tissue. And look at this, the superficial layer here and the deep layer here. In between, there is a fascia. And you can, using a software, we delineated this, and on the right side, you can see the deep adipose tissue. What is the significance of deep adipose tissue? Deep adipose tissue is much higher in Indian population. It is also different. Deep adipose tissue is structurally and physiologically different. And this is possibly the culprit in the subcutaneous adipose tissue, because others have shown that this produces more inflammation and is structurally different. Look at this big adipose tissue cells here versus the big in the superficial and smaller in the deep adipose tissue. And apart from that, number of other abnormalities also are there as far as this adipose tissue. For example, genes for adipokines and fatty acid metabolism are different in deep adipose tissue as compared to the superficial adipose tissue. What we saw in non-obese people, because this is our focus of research somewhere in 2015, 2016, where we took non-obese type 2 diabetes patients versus non-diabetes control and compare their whole body composition using magnetic resonance imaging, and found that intra-abdominal fat in these diabetic patients is much higher than non-diabetic control. They were same BMI, same waist circumference. Diabetic patients or newly diagnosed diabetic patient, but also we found that the liver was swollen in these people. And we think that the subcutaneous tissue, liver, and intra-abdominal tissue all are at fault as far as metabolism of Indians are concerned. And so further weight loss may be okay even if patient is not having normal BMI, to decrease this intra-abdominal fat and liver span. This has been shown by others that in non-obese, non-diabetic Indian population as compared to Caucasians, same age, BMI, non-obese, the number of factors which indicate inflammation like adiponectin, leptin, etc. are much higher. So even before developing diabetes stage, in lean people, non-obese people, Indian population, they're already inflamed as far as inside tissues are concerned. Let's come to the liver, and I'm sure somebody's covering this, and Dr. Kenneth Pusey and others, but this is only in relation to South Asians that I'll be talking about. Is life worth living depends on the liver. William James in 1950. We know that once we are taking increased caloric intake and reduce energy expenditure and certain conditions like lipodystrophy with a positive net balance, the triglyceride deposits in the various ectopic sites, which is muscle, liver, and heart. It is muscle and liver which is focus of our research. If you see this is the normal liver, and the span is approximately 11 centimeter. And if you see this is a fatty liver, a span is 20.5 centimeter. This is often we see, and this is a span has been measured by using an ultrasound. And we also sometime back published that liver span cutoff of 15.6 actually predicts diabetes risk. And this liver is packed with triglyceride. This particular study, a comparative data between Indian population versus Caucasian, this is one of the finest studies comparing livers in Indians versus the Western people, showed that we had 2.6 times more hepatic fat than the Caucasians. And at the same time, our insulin resistance was high. So our livers are totally packed with fat, and that is impacting our metabolism. And look at this. This is our recent data. In diabetic patients, 250 diabetic patients, the grade 3 fatty liver, we found in 85% of the people. And we also did MRI-based protein fat fraction, but that's not been shown here. At the same time, we did fibroscan and found that only 39% of the patients had no fibrosis and 18% severe fibrosis. So these data show that our liver is hugely impacted, and they are going bad once the diabetes occurs. Let's come to the third part of the lecture, and that is muscle. Feel these muscles and understand how they boast the truth. And that is 1980 Arakawa's quote. Muscles are terribly important and often forgotten as a part of the metabolic syndrome. And look at this. This is the Jamar dynamometer, which measures hand grip strength. This is one of our patients where hand grip strength is being measured. The 60-year-old female, 13-year diabetes, A1C 9%, serum creatinine high, and grip strength only 3, which is far too low. And we found in unpublished data that 69% of the males and 95% of the females are the grip strength is below the cutoff. That means they are sarcopenic. This has been found by others also, and this is a very good study which was published 3 years back. South Asians had almost 6 point lower grip strength than blacks and white. This is comparative data. And also, which is of very high importance, is that for 1 kg per kg body weight hand grip, South Asians had 12 times more prevalence of diabetes. That means sarcopenia alone is correlated with diabetes, independent of body fat and multiple other risk factors, which these authors have adjusted in their analysis. So our muscles have to be stronger to beat diabetes. It is not only decreasing body fat or abdominal fat or liver fat. Now, what is the problem with the muscle? Apart from maybe functional decline, there is increased deposition of the triglyceride in the muscle, intramyocellular triglyceride. This is the patient with diabetes, and this is non-diabetic subject. And this is what we found quite some time back, around 15 years back, using a proton spectroscopy, magnetic resonance spectroscopy. We found high IMCL content in our diabetic patient. And others have shown that IMCL is high both in Indians as well as Caucasians in UK, but only in Caucasian it is related to insulin sensitivity. So what is it doing? Sitting there in the muscle, not related to insulin sensitivity? This is what has been shown in the recent study. It shows that if we give a high-fat diet, the intramyocellular triglyceride in Caucasians and South Asian increases in the similar manner. But it is the metabolism of this fat which is impaired in Indian population, and this is because of problem with the perilipid PLN 1 to 5 family, which is a major triglyceride lipase enzyme in the muscle. And this is not actually being affected by insulin. So our muscle metabolism is impaired. So what is the overall finding till now? Whatever I have told, a composite of negatives. In other people, other than South Asians, many other ethnicities, if we take excess energy, there is adipocyte hyperplasia, which is deposited mostly in the superficial subcutaneous tissue, does not go into visceral adipose tissue, and there is no free fatty acid flux to the liver. In Indian population, excess energy causes adipocyte hypertrophy, which causes asphyxia and low adiponectin, increase in the visceral fat, increase in the deep adipose tissue, and which increases fatty acid flux and which causes a fatty liver. This is the composite of negatives. Now, this is the last part of my lecture. My lifestyle is a consequence of my wounds. I am son of my history. So this is what actually preceding the ramifications, and that is accelerated development of diabetes in Indian population. All this which I have told you, composite of negatives, progression of diabetes is so much more faster in Indian. And you could see this Naveed Sattar study in 2015, faster progression of diabetes from pre-diabetes and difficult to come back to normal. If we apply the same lifestyle to South Asians and Caucasians, it is easier for Caucasians to come back to normal glucose regulation than South Asians. And increase in the coronary artery disease all over the country. And in comparative data, white, black, Latino, Chinese, South Asian, the coronary artery calcium is highest in South Asian men. So these are something which are consequences, sin, whatever you can say, the previous, from birth onwards, the scars which have been left by various dysmetabolic phenotypes. And if you see, as far as the diabetic outcomes are concerned, same things are working in an advanced manner in diabetic patient. And if you look at this, there's comparative data, Africans, Chinese, Japanese, Filipinos, etc. Highest myocardial infarction, highest congestive heart failure, highest stroke, and highest end-stage renal disease, except amputations. Rest of all complications highest. So with that, I finish my lecture. There's so many more things which we have done, lot of more research, but I thought I'll crystallize this for this important conference and tell you what is the summary. Phenotype of Asian Indians is metabolically averse, lending markedly high predisposition to cardiometabolic syndrome. Not only abdominal obesity, but insulin resistance, sarcopenia, and yet not fully defined metabolic factors are key contributors to dysmetabolic state or hyperglycemic state. And such early cardiometabolic syndrome increases risk for diabetes and CVD more in Indian population than other ethnic groups. Thank you.
Okay. Thank you, Professor Mishra, for a very enlightening talk. And we have very few interesting questions in the chat box. One of the question is Professor Mishra, that is this cardiometabolic syndrome, which is more prevalent in we South Asians, is genetically determined, or it's a consequence of our lifestyle? So what do you think is responsible for this high prevalence of cardiometabolic syndrome in our population?
It's very difficult to say that only one factor is responsible. It is like obesity. If you see obesity in general, not talking of South Asians, what causes obesity? It is the diet, it is the lifestyle, and in small percentage of people, it is genetics, or there may be polygenic influence also. So similarly, if you look at the cardiometabolic syndrome, I think we have a phenotype which is influenced by centuries of starvation and protein deprivation, which has weakened our muscles and increased our fat everywhere to store energy in a dense form. So, like tomorrow there is something is going to happen to the world, and you want to store money, you will store in 1,000 rupees note rather than 1 rupee coin. This is what body has done over a period of time. All we are doing is making it worse. Now, behind that is somewhere there is genetics. Surely there is no doubt about it. But if you want me to say there is a single gene involved, there is no single gene. It is multiple genes, and there is a gene environment, gene diet, and gene exercise interplay, which is at role here.
So there is Dr. Bhuvi, please.
Just taking that question forward, so do you recommend any panel of genetic markers that we should do for our patients?
For cardiometabolic syndrome, for diabetes, or obesity, which one?
For cardiometabolic syndrome.
Many people have tried to sell this to me. We have this panel for cancer, we have this panel for diabetes, and we have this panel for this. I'm against any genetic panel. Why not simple waist circumference and a BMI and simple history? Till now, nobody actually has bettered this. Now you can only add on to this a body fat, and you can add on to this a liver fat, and so on, only to refine in a better center, in a good center, in a research center. But for a general practitioner, this is enough. And no, even in advanced center, I will probably next decade also, I will not be taking recourse to any genetic marker.
So there's another question, that if we take this concept of cardiometabolic syndrome being more frequent in South Asians forward clinically, our population is more prone to develop diabetes earlier and cardiovascular complication also at an earlier age. So as far as anti-diabetic choice is concerned, should we start with GLP-1 RAs and SGLT2 inhibitors early in our patients rather than using sulfonylureas and DPP-4 inhibitors?
Ramesh, you know the answer of this question very well. We are going toward that. We are taking that route now. That every day we are wiser that SGLT2 inhibitors or GLP-1 analog are actually hitting at the multiple things that we have wrong here in the body. And now, for one example is the liver fat, for example. And liver fat is a real problem. And there are some studies also, those who have higher liver fat, there is a greater problem in controlling their diabetes. So how do we decrease this liver fat? Of course, besides diet and exercise. The drugs, as far as drugs are concerned, there is emerging evidence for SGLT2 inhibitors. There's emerging evidence for GLP-1 analogs. And these we are carrying out some studies. These decrease liver fat, they decrease overall fat and abdominal fat, and also protect heart and kidney. Then there's something which is absolutely desirable for Indian population who are going to suffer for all these problems. So we'll await for more trials, Ramesh, but we are increasingly using these drugs.
So what are your thoughts on metformin in pre-diabetes? Do you recommend that? I know the data exists, but do you recommend that personally, or you would encourage the patients to just follow a healthy lifestyle?
So there are two types of patient, Purvi. One is that those who will follow you, and those who don't follow you. It's simple. Now, somebody who can run 5 kilometers a day and are following our diet, metformin is not my choice in pre-diabetes. Somebody who has a knee osteoarthritis or it cannot control his diet, is non-compliant, metformin could be the choice. And especially in those people, there are more categories of people. Those who have a BMI more than 35, those who have history of polycystic ovary disease, and those who are less than 60 years of age. Now, this is the ADA advisory, and I'm sure this works well as far as the Indian population is concerned. But you're right. Maybe in Indian population, it is needed early and slightly higher dose than what has been shown by Ramachandran, because our conversion from pre-diabetes to diabetes is very, very fast.
Very fast. True, sir. So any ideas about catching the non-obese insulin resistant?
Yeah, that's a good question. Non-obese, insulin-resistant people, how to catch them? First, phenotype. Now, phenotype, it may be that a person is has a BMI of 22.5, which is normal, upper limit of normal, but waist circumference of 94, 95. So around 25 to 30% of non-obese by BMI have a high waist circumference. These people is likely to be insulin resistant. Number two, if you go on to see their body, and if you find acanthosis nigricans or xanthelasmas or skin tags, and if you feel their liver, which is enlarged, then they are likely to have. So clinical profiling is very, very important. I for one, and there is a question here that would you like to do HOMA IR in these patients? I don't do HOMA IR. I clinically profile them. I profile their lifestyle, and I can tell you 95% I'm going to be absolutely correct in my profiling that this person is either today insulin resistant or going to be insulin resistant in near future. This is where I should intervene.
Fantastic. So one, and that too coming from such a fantastic background of bench and clinical research. I think you giving us tips on the clinical aspect of it is very reassuring. Sir, also because cardiometabolic syndrome is a cluster of abnormalities, so is there one particular abnormality that you stress on much more than the others, or do you think there is a driver amongst these, or do we give equal weightage to all of them?
No, driver is the weight and driver is the abdominal circumference, abdominal obesity. These are two baseline drivers. And if you see my second slide, I put that right in the middle, and rest all surrounding. So it's like a sun and the stars around that. This is what we should target in every person. And I said, and that's for clinician, that even if a BMI is normal at a 22.5, I tell them that you must lose further weight. And a BMI, you should keep it around 21, 21.5 or 22. This is what a good BMI is. At the same time, you strengthen your muscles. So both things go simultaneously. If you achieve both, you're likely to be from insulin resistant to insulin sensitive in some time.
So does the Mediterranean diet work in the Indian population, and do you recommend that personally?
Sorry, say it again. I couldn't.
So does the Mediterranean diet work in the Indian population as well as the data shows in the other populations?
Purvi, I have no data to show you. I can tell you there are practical difficulties in Mediterranean diet in Indian population because of the olive oil, etc. is certainly costly, and our Indian, generally the middle class which is being affected will not be able to afford that, and the compliance of diet is always a problem. I feel for Indian diet, and we have published that, those data I have not shown you here, the higher protein content, and we increase the protein content in a vegetarian diet to 29% energy. That's what highest we could go in the vegetarian diet, and that led to resolution of number of abnormalities of metabolic syndrome. So I think this achieves two things. One, it probably is ameliorating metabolic syndrome as such, and also it combined with resistance exercise, it is energizing your muscles and decreasing sarcopenia. So high protein diet is something which is required. And people, even vegetarian people, can increase protein intake, and leucine-based protein content are what is required, and which is in masoor, in kabuli chana, and things like that, and which can be afforded by most of the people.
So that was a very, very amazing tip, because this is what we need to take back to our patients. So with that, another sort of question related to research, with all the extensive biomarkers that you have studied, so do you recommend any inflammatory biomarkers that we should incorporate in our regular screening?
There's always a talk of including HSCRP as a marker, but long time back, in fact 10 years back, we published data from Indian population and found that CRP is so high in many people, and whether it is just a noise, it is something which is wrong. We thought so. Why? Now the Indian population have a lot of infections. They have helminthic infection, they have recurrent upper respiratory infection, diarrhea, etc. Often gingivitis. Any of these will increase HSCRP. Now, whether we should consider this HSCRP as a marker in a general population, very difficult to say. But if somebody who's who doesn't have any infection, you carefully rule it out and HSCRP is high, possibly it will indicate increased risk for atherosclerotic cardiovascular disease, but we are not taking that as a routine marker.
Thank you, sir.
And sir, how about the use of the anti-obesity agents in patients with metabolic syndrome?
Oh, sure. I'm looking for one. Give me one anti-obesity agent. Not ban them. But going back, we have now so many agents, and Ramesh, you have used many of them. It is one agent which stood out, which was banned, and that is rimonabant. Okay. Rimonabant, the CB1 blocker, at that time blocked whole metabolic syndrome. The propensity to develop metabolic syndrome, decrease weight, as well as decrease smoking. So rimonabant was one of the best drugs, and people, when it was banned, people actually hoarded rimonabant patients, and they kept it at their home because government said no rimonabant, and they said this is such a good drug, I want to take it further. So I'm looking for a good anti-obesity drug. Lorcaserin was not so good when it came. I'm sure there'll be others in the future. Till that time, we are only relying on SGLT2 inhibitors and GLP-1 analogs, and sometimes orlistat, which is not a powerful agent.
Sir, I wish all good things didn't have to end, and such an elegant talk and a fantastic discussion after that. We learned so much, and I'm sure the audience enjoyed it too. Loved the quotes that were presented with the data, very beautifully intricated. And I'm sure that after this session, we all are going to be reciting cardiometabolic syndrome on and off from now on. So thank you for that. Thank you very much, sir.
Thank you, sir.
Thank you. Thank you.
We hand over to Dr. Rucha Mehta.
Well,
Dr.
thank you all.
Gandhi, yes.
Yeah. Dr. Rucha is busy in the other hall. So the duty is on my shoulder to introduce the next session. We will move after having heard Dr. Anup Mishra, his great hello, can you hear me?
Sure.
Yeah. So I will invite the chairpersons for the next session. Dr. Satyavan Sharma. Is he there?
Sir, Dr. Satyavan is facing some technical issue. He is joining in 2-3 minutes. So meanwhile, you can start.
Okay. So with me, Dr. Satyavan Sharma will be there. He was a professor and head of the department, cardiology department of Sion Hospital when I was a student. And then he is now professor and head of the department at cardiology department, Bombay Hospital. He's past president of Cardiology Society of India. Been a teacher to many of us, and we all hold him in very high esteem. He will be joining shortly as a chairperson, and until then, let me have the speakers. The first speaker today in this session of atherosclerotic cardiovascular disease and hypertension, we have none other than Dr. P.P. Mohanan, the president-elect of CSI. Can I have Hardik? Yeah. Dr. P.P. Mohanan is the president-elect, Cardiological Society of India. He is director and head of Department of Cardiology in Westford High Tech Hospital in Thrissur, Kerala. He has held many prestigious posts in past, and he was a past national convener for the coronary and non-coronary registry for Cardiology Society of India. He has recently published the largest acute coronary syndrome registry from India. He also did the largest randomized study in cardiovascular science from India, improvement study in acute coronary syndrome, ACS Quick. He also did the first quality improvement study in chronic heart failure in India. He has so many publications to his credit. He is also a recipient of the famous Dronacharya Award. Over to you, Dr. P.P. Mohanan, for your talk on atherosclerotic cardiovascular disease in young Indians.
Thank you, Samir. Can you quit the screen? Yeah. Hopefully you can see the screen.
Yes, we can.
Okay, thank you. Thanks for the opportunity, and distinguished chairperson and dear friends. Atherosclerotic cardiovascular disease is the highest ranking cause for premature death. If you look at the number of years lost. And my idea in the next few minutes will be to discuss with you the problems of ASCVD in young Indians, and whatever is the data available, which are not very many, but then what possibly we can do to tide over this impending doom. We know the causes of death in India, and the alarming proportion by which the proportion of ASCVD is increasing. And it's imperative that we do something to curtail this malady. Now, if we look at the oldest of the coronary heart disease study, the Framingham data, you could see that the younger patients, mind you, the definitions are not uniform. Now we have very many. My objective will be to discuss with you some of those data that has come from India, and you could see the variability in the definitions of young. But then generally it is presumed that the younger patients with the ASCVD will account for about 2 to 6% of, that was this Framingham data, and much water has flown after that. This could be the first report of young MI from India by none other than Professor R.S. Vadia and Gulati from Pune, when they were replying to an article published in British Heart Journal sometime in 1975, when they said that we had at least 90 patients with coronary heart disease below 40 years. But then there were no records of that. It was only a letter to the BMJ. That was report of young MI from India. Of course, we know about the CREATE registry, and that was the first of its kind, which published more than 22,000 patients with acute coronary syndrome. And what I wanted you to pay attention is, look at this. So they have calculated, differentiated into 3 groups, one less than 50 years, then 50 to 70, and then more than 70. So they have possibly considered 50 as the cutoff line for younger MI. And you could see that at least 1/3 of the ACS patients in India belong to patients who falls less than 50 years. When come to our own data, this was our own, possibly the largest ACS registry till now. And here again, we tried to follow suit. We were in the formative years, and we also tried to look at that particular data and look at that. So the lesson, if you term the young MI as less than 50 years, that will come to about 22 to, up to maybe about, the CREATE showed about 30%. So about 22% was the percentage of young MI, if you take 50 years as the definition of MI. The Himachal Pradesh, it was a smaller data. Now you could see that it's about only 2,600 patients. But then they looked at a little younger than the previous CREATE and the Kerala ACS. And you could see that if you look at 40 years as the cutoff point, then less than 40 years is about less than 5%, and 41 to 50, it amounts to almost 21 or 22%, as we have seen in the Kerala ACS registry. Of course, we don't have this is the only data from India which is dedicated to a young coronary artery disease, the CADI registry from Bangalore, basically, and also associated with some other places, Chennai and Delhi. You could see that now premature coronary artery disease in the young Indians, and look at the mean age. The mean age here also is, of course, they have few percentage of much younger people, but the mean young age here also is about 49, which is almost similar to the previous 2 large registries that we have seen. Of course, we have the really young group from, now this is again from Andhra Pradesh, which was published recently, but then they were more concentrating on they didn't do much of an epidemiological workup with these patients, but then they were mainly looking at the coronary angiogram part, and of course its correlation with the risk factors, which we will come in a minute. And here now you could see the difference between the below 40 group and the above 40 group, and you could see that there are more, the angiography wise, you could see that there are more in the younger group. We will come to that in a stage. We did a study in about 5 years ago, looking at the age-adjusted prevalence of coronary artery disease by age group. And you could see here, this is the larger spectra. And you could see that the percentage is not too great. But if you look at the 40-49, that will come to about 14%. 30-39, about 8%, and less than that, about 5%. So definitely what the information that we had from these about around 6,000 patient data was that coronary artery disease is definitely increasing in Kerala, at least. And the risk factors in the young are almost similar to whatever we are discussing in the older group. So basically, the differences in risk factors are not much different, even if you take the young MI and compared it with the older MI group. So that's what, see, the high blood pressure and the suboptimal blood control. Of course, you could see that the tobacco is much higher in the younger group. Definitely the alcohol use also compared to this is more of a data from the elderly group. It is not the young group. If you look at the CADI study, which from the doctors from the Bangalore, Iyengar and his group showed, you could see the difference. See, this is the younger, this is CADI, and the Y is missing, sorry. So you could see diabetes seems to be definitely higher percentage, at least in these groups of data from generated from South India. So hypertension is almost similar to the other registry data. Mind you, this was in comparison with the CREATE registry and the Kerala registry, which took an amalgamation of the entire group. So this green is young and the red and blue are combined together. And obesity, definitely obesity, smoking, these are, even though we say
Dani, can we have some questions? Meanwhile, Dr. Mohan seems to have lost his connection.
Is it okay now? Is it okay now?
Yes, yes.
We can't see you.
Yes.
No. I have muted my video. Okay.
Okay.
But then you can see the presentation.
We can see the presentation now.
Okay. You don't need to see me. Okay, right. So in comparison with the older group of MI patient, the only differences that one may see is the increased prevalence of diabetes, smoking, hypertension, and the other 4 or 5 risk factors may not be very significantly different. No, this is basically the difference. This is a comparison, but at least from the Indians' perspective, look at, then you could see possibly you have multiple risk factor in the elderly group, but dyslipidemia, smoking, hypertension, diabetes, and they're all similar. As we discussed earlier, you may have more single vessel diseases in the younger patients. There are only possibly this is on one of the data where they have looked at the ASCVD in the young woman, and where again they have seen that again surprisingly you could see here that the proportion of young women who has ASCVD seems to be having a huge percentage of dyslipidemia, hypertension, and diabetes. If you look at coming from the risk factors, we move to the mortality. Is there any difference between the mortality? Here again, we are not very wiser, but then this is the mortality data from our own studies, CREATE, Kerala ACS. This is a Kerala study from Kottayam Medical College, about 1,800 patients. This is our own study. And Himachal registry, then the Eastern Indian registry, and this is from outside India. You could see here there is a huge difference between the mortality from the European registry. We have in hospital, Kerala ACS registry in hospital mortality was something to the tune of 8.9%. So we can explain the pathophysiology by the preponderance of the conventional risk factors. And if you look at the angiographic profile, as we have discussed, you could see that we see more single vessel disease, and the proportion of severe left ventricular dysfunction is lesser in the younger people. The coronary pathobiology may be a little different. You may see lesser amount of ruptured atheromatous plaques here. You may see more coronary span, coronary and even normal coronaries. The normal coronaries proportion is definitely a higher, as you can see in this particular study from Himachal. Again, you could see that the proportion of normal coronaries definitely is higher. The particular data, see, the single vessel disease in about 53 patients, 53%, and mostly it is confined to LAD. The about 31% seems to be having a not significant obstructive disease, possibly related to the higher amount of smoking and thrombus getting into the, and when you treat them, the thrombus get lysed. That may be the reason. And absolutely pure, pristine coronary artery is seen in about 7%. This is something, as we discussed, this is not from our own data, I mean, from the Indian data. This is a outside data, basically from the Europe data, where again, you can see that plaque erosion is more common than plaque rupture. We don't have an Indian data on that. If you look at what are the newer risk factors, this cardiometabolic syndrome definitely will be much more interested to look at the newer risk factors, and we don't have much data from the insulin resistance incidences or the adipokines linked to the insulin resistance in the young MI in our patient group. And I mean, even though we have more data coming up, at least from Delhi, which shows that at least 10% of our 1 in 10 young MI may have a familiar hypercholesteremia, and it is time that we pay attention to familial hypercholesterolemia. What about LPA? You know, we had heard a lot of LPA saga from Inas, this gentleman, but then it died down because we didn't have any drug which can combat LPA. Now we have better drugs. We have PCSK9, we have the next generation mRNA antagonist. So we may come to a stage where the importance of LPA will be re-emphasized because we have a newer mode of therapy. LPA has been involved in young MIs all through these years. See, now all these risk enhancing factors becomes important in young MIs. Basically, we can see that now, if you compare the mortality of a younger MI, it is not much different from the elderly group, even though the in-hospital mortality, while the older patients have about 8.9%, the younger MI in hospital mortality and the 30-day mortality seems to be something hovering around 7%. Now, in the prevention part, this is something I just wanted to spend on a little bit of maybe about a couple of minutes. If I hope I have the time for that. It is increasingly seen that the importance of coronary calcium with the coronary artery detection. And I think we have the data from this cohort data, which showed that a CTA-based risk stratification will definitely help us in detecting these high-risk patients who are going in for so we definitely will be going to see those data. And this is some data from the GB Pant Hospital, I mean, who again has shown that mostly our young MI are linked to the smokers. They were just confining to the smoking part. We got management of myocardial infarction recently. This in June, we have the publication from the World Heart Federation, the PHFI, and the ICMR combined together giving us an idea about this is not confined to a young MI management. This is confined to basically to the all lower and middle income countries, how to manage, and the pharmaco-invasive management, which we are all familiar, is taking in shape, and the ICMR, PHFI, and the World Health Federation believes that now, rather than spending too much of time by traveling, if you have a thrombolytic center nearby, you do the thrombolysis and then subject them to a pharmaco-invasive strategy. But I just want to show our data also. This pharmaco-invasive strategy may be needed for every part of I don't think Delhi or Ahmedabad will possibly need a pharmaco-invasive approach. In Kerala, at least, we could see that the population has access to reperfusion services in most of the district. Only the red one, these are the hilly districts, only about maybe 15%, about 75% or more has some access to reperfusion, and about 60% has access for catheter-based reperfusion. Every state possibly can do some GPS-based system so that people are more comfortable and able to know which is the best and which hospital available for reperfusion. What can we do apart from thrombolysis to improve the status of young MI? We can definitely do a quality improvement intervention, just like what we have shown here. This is about 22,000 patient data, which we did about a couple of years ago, and showed that we could improve reperfusion, we could improve the investigation. Mind you, when we started Kerala ACS registry in 2012, only 12% were the group who received primary PCI. Look at 2017, 52% of people received a primary PCI. So we can definitely improve the things. I will shorten it to 1 minute. So definitely we have also showed that the quality of the symptoms can be improved by implementing the guideline-based care. One has to know that we in India faces a peculiar situation of increasing MIs, and we have to have a better system of management of these young people with ASCVD. Thank you for your kind attention. And sorry.
Can you hear me?
I can.
Okay, great. So thanks, Dr. Mohan, for a great talk. We'll come back to you at the end of the session for some questions. I see a lot of questions in the chat box. You can answer some of them, and we can ask some questions once we have finished with all the 3 talks. So next speaker is Dr. Venkata Ram. He's a globally recognized expert in the treatment of hypertension, and he's extremely well known, not only nationally, but globally. He has dedicated his entire life for diagnosis and treatment of hypertension. He's the director of World Hypertension League, and he's a professor of medicine at the University of Texas Southwestern Medical School, Dallas, USA. And he has a lot of publications and papers. He's a Padma Shri awardee. So over to you, Dr. Venkataram.
Okay, thank you very much. Ladies and gentlemen, good afternoon and greetings to all of you. Dr. Dani called me about 6 weeks ago and asked me to block this weekend. And then he suggested something that could be of great use to community at large. And then obviously one of the things that comes to our mind from public health point of view is the blood pressure along with other risk factors. So my responsibility is to simplify the goals for the treatment of hypertension as of today. There is no need for any confusion about the goals for blood pressure treatment, and there is no need to lose sleep about the goals for blood pressure. It's very, very easy. If somebody can, okay, I'll share the screen shortly. The confusion was the different definitions of hypertension before. Now what has happened is, however you define hypertension, the blood pressure goal appears to be the same. So it does not matter how you define high blood pressure, as long as you have a goal blood pressure that's very similar for all the guidelines. So let me start the discussion.
I think everybody else has to mute their mic.
I hope you can see the screen.
We can't see your screen. We can see only you.
Oh.
You have to share the screen, please.
Okay. What do you want me to do? You want me to?
There's a green button.
Share screen at the bottom.
Yeah, there is a button. Which button?
Share screen.
Oh, I did. That's what, when I shared the screen, this is what came.
Just click on share screen at the bottom.
Actually, I'm sharing the screen.
Share screen. Green color button. सर वो मैडम ने बोला ना 3 मिनट जब बाकी
Once you press the share screen button, a screen will open up, and then you have to again press the share button.
Okay, let me see. I'm trying to log in again. Just bear with me. It never happened before. It is always a first time.
So what happens when you click on the share screen button?
Yeah. No, I'm trying to. That's what I did. Just hold on 1 second. I think it is resuming.
Hi, Venkat.
Hello there. Something. I'm trying to relog so that you can see it.
So meanwhile, I will speak to Dr. Venkat sir on phone. Meanwhile, you can take a couple of questions with Dr.
Yeah.
Mohan.
Okay. Yeah.
So I welcome Dr. Satyavan Sharma, who has joined us. Sir, welcome. Please unmute yourself.
Samir, I am also here, Dr. Kaul.
Yeah, Dr. Kaul, welcome, sir. Your talk is immediately after Dr.
Yeah, I know.
Ram.
I know.
So, are you seeing that the Zoom window in front of you?
All right. In the meantime, while he's sorting out his computer, Dr. Mohanan, can we have you back?
No problem, Samir, go ahead.
Yeah, we can. We have some questions. We can talk.
Sure.
Yeah.
Till
So,
Dr. Ram is ready.
Yes. So as you said, the risk factors are similar in older and younger age group. Then what additional risk factors are there which can result into faster progression in these individuals, and how can we identify them? One, you said LP little a. What else? What other risk factors are there which causes these risk factors to progress faster into disease? The conventional ones.
The most of the data from the young, at least the CADI and the other group, has shown diabetes and smoking are more, cardiometabolic risk factors are more in these particular youngsters. So that apart from that, all the other fancy risk factors, the inflammatory, the whole lot of inflammatory markers has been attributed in that. But I don't think they are not much of important. Basically, it's smoking and the importance of young, especially younger, with the anxiety, the stresses, which is possibly causing more all these risk factors coming into play.
Right. Dr. Ram is back with us. So you have to unmute yourself.
Now, if you look at the screen, the medical literature.
એક એબિડલ ગ્રંથિ કિડની જે ઉપરના ભાગમાં હોય છે અને કિડની જોડે લેવા દેવા નથી હોતું તો એ જગ્યા કિડનીના ઉપરના ભાગમાં હોય છે એમાંથી હોર્મોન્સ થોડા વધારે બને છે.
Can we mute everybody else, please? Hardik, please mute people from your end.
Okay, I think Samir, we are okay now. One of the things that we usually neglect and we forget is that when you treat hypertension, you actually improve the cognitive function. A number of studies have shown that you can actually prevent the onset and progression of dementia when you treat high blood pressure aggressively. This is a study, CISTURE, where the cognitive function in the first bar, 27.1, before control of hypertension, and when you control the blood pressure aggressively, there is an improvement in cognitive function. Very important for people to know. We only think about myocardial infarction, CKD, stroke, but a major benefit out of treating hypertension is improvement in cognitive function. Very, very important. Now, although I'm going to talk about the guidelines for blood pressure definition, all number of studies have shown that any non-pharmacological approach you take, this is effect of weight loss on blood pressure, and this is effect of salt restriction on blood pressure, and this is the effect of aerobic exercise. All these modalities have shown that non-pharmacological approaches, if they can be sustained, they lower the blood pressure. The problem is in the free ambient society, many of the non-pharmacological approaches cannot be sustained, but time and again, 8 to 10 millimeters of systolic blood pressure goes down with regular non-pharmacological treatment. Now, this is probably the most important slide of this presentation, because if not for this study, we will not be treating hypertension at the present time. This is a study called Veterans Administration Cooperative Study done in late 60s and early 70s. It was a very simple study. They took patients with hypertension, they treated some, and they did not treat the others. And at the conclusion of the study, they have shown when they actively treated hypertension, there was a significant reduction in cardiovascular mortality. For the first time in the modern history, it was shown that untreated hypertension causes cardiovascular mortality, but when you treat hypertension, the cardiovascular mortality goes down. And by the way, because of this, the Joint National Committee, JNC1, was formed to give guidelines on the treatment of hypertension. Now, one thing that all of us have to keep in mind when we treat hypertension, somehow, however you do it, once a day treatment or twice a day does not matter, you must always control the morning rise in blood pressure. Because if the morning rise in blood pressure is not controlled, there is a high risk of cerebrovascular disease in the future. As you can see in this slide, those patients who had a morning rise in blood pressure, they had a future high incidence of stroke. Now, let us look at the topic that Dr. Samir Dane asked me to address is the blood pressure goals and the new definition. You will notice, at least in the center slide, that the definition of hypertension has been downgraded by US guidelines. In fact, US guidelines have suggested the previous pre-hypertension as stage 1 hypertension. So according to US guidelines, a blood pressure of 130 to 139 or 80 to 89 diastolic is considered stage 1 hypertension. So basically, ladies and gentlemen, the previous category of pre-hypertension has been now substituted by stage 1 hypertension. And where is the evidence? Ladies and gentlemen, this is the European definition of hypertension. Europeans have not changed the definition of hypertension. They still have considered 140 or 90 as the definition of hypertension. So here we have two new guidelines, one suggesting 130 by 80, other suggesting 140 or 90. But let me tell you, it does not matter. It does not matter because they suggest the same goal blood pressure, namely to reduce it to less than 130 or 80. Now, if you can see the screen, on the vertical line is the blood pressure of 130. Anything to the left is lower than 130. Anything to the right is greater than 130. You will notice every complication of hypertension is significantly decreased with the blood pressure less than 130. So ladies and gentlemen, repeated meta-analysis have shown that when you reduce the blood pressure to less than 130, you reduce all cardiovascular complications that occur with hypertension. Now, this is a slide. If you look at 120 by 80 as a standard, now if you increase the blood pressure to 120 to 130, there is increase in cardiovascular mortality. If you increase it from 130 to 140, there is further increase in cardiovascular mortality. Myocardial infarction, actually, if you take the blood pressure from 120 to 130 and higher, the myocardial infarction increases by 100%. So ladies and gentlemen, the blood pressure that you thought was okay between 130 to 140, 80 to 90 is associated with very high degree of acute myocardial infarction. These are the two levels of blood pressure: European blood pressure 140 or 90, American blood pressure 130 or 80, but both of them suggest a goal blood pressure of less than 130 or 80. So ladies and gentlemen, it does not matter what definition of hypertension you follow, you should try to reach the blood pressure 130 by 80. Now, the European guidelines have identified South Asians, namely Indians, as a high risk category. At any level of blood pressure, your risk increases by 40% if you are a South Asian. So ladies and gentlemen, if your blood pressure is 130, if you're European, your standard risk is 1. But if you're an Indian, your risk has increased by 40% at the same level of blood pressure. Now, recently, American College of Cardiology, American Heart Association have again identified Asians as being higher risk at a given level of blood pressure. So by being of South Asian descent, you have earned a higher risk at any level of blood pressure. And in India, the main reason for cardiovascular disease is chronic hypertension, both in men and women. You will see in that circle, the main driver for cardiovascular disease in India appears to be chronic hypertension. Now, this is a sad part of it. An analysis by Public Health Foundation of India has suggested that our hypertension prevalence will increase total to more than 200 million in the next 4 years, unless we really control hypertension aggressively at the present time. So at the moment, ladies and gentlemen, majority of patients with hypertension, both in rural and urban areas, the blood pressure tends to be uncontrolled. No matter what, their blood pressure tends to be uncontrolled. Now, what about the level of blood pressure and cardiovascular risk among Indians? And this is from a Mumbai cohort study looking at the blood pressure of 120 systolic and see what happens if you increase the systolic to 120 to 130. The mortality increases by 16%. And if you increase it to 130 to 140, there is increase in mortality from 19%. So ladies and gentlemen, even among the Indian cohort, the blood pressure that is greater than 120 and 130 is accompanied by very high risk of premature mortality. This is a study that we completed recently. It is under consideration by a major journal at the present time. This is a prospective study of acute stroke in India, and we have concluded that the main reason for acute stroke in India is hypertension, followed by diabetes, followed by tobacco consumption. Now, in India, diabetes is very common. I don't have to tell this audience, but if you combine diabetes with hypertension, the risk is further compounded. So the highest cardiovascular risk of any population appears to be a combination of diabetes and hypertension. That is the reason why we in India have to treat hypertension and diabetes aggressively, because the combination of these risk factors causes tremendous increase in cardiovascular disease. A very important slide to demonstrate that majority of cardiovascular events occur under the blood pressure of 140 over 90. We're not talking about 180 or 110. We're not talking about 200 or 120. But any time the blood pressure, the most cardiovascular complications occur at blood pressure less than 140 over 90. What does it mean? That means anybody whose blood pressure is between 130 and 140 or between 80 and 90 is the highest risk. Majority of cardiovascular complications occur between systolic blood pressure 130 to 140 and diastolic blood pressure 80 to 90. So that is the catchment area that you have to concentrate in order to control cardiovascular complications. All over the world, cardiovascular disease is declining except in South Asia. By South Asia, mostly it is India. You will notice that in South Asia, the cardiovascular disease is increasing in contradistinction to the rest of the world. So let me talk about one more guidelines and then I'll conclude. Last month, International Society of Hypertension has come up with its guidelines, and they have graded hypertension into two stages, 140 or 90 and higher, or 160 or 100 and higher. So they have graded hypertension slightly different than European guidelines or American guidelines. But don't worry about it. You don't have to worry about it, because they also recommend a blood pressure goal that is close to 130 or 80. So ladies and gentlemen, if you're looking at Indian guidelines, if you're looking at European guidelines, if you're looking at American guidelines, if you're looking at international guidelines, all of them recommend a blood pressure goal close to 130 or 80, irrespective of how you define. Now, again, International Society of Hypertension has characterized South Asian population as having high cardiovascular risk. So in terms of the treatment, ladies and gentlemen, besides non-pharmacological treatment, please forget about monotherapy. Please, you must say goodbye to monotherapy for hypertension. Start with combination therapy. The era of monotherapy is gone. And now you have to start the treatment with appropriate combination of dual or triple drug therapy. And you should try to reduce the blood pressure within 3 to 6 months of the diagnosis. And this is from the SHEP study, CISTURE study, showing that if you reduce the blood pressure within 6 months of diagnosis, you reduce the risk of stroke by 30%. So don't wait for too long to reach the goal levels of blood pressure. The more rapidly you reduce the blood pressure, greater is the benefit. And this is from the VALUE trial, again, showing that all cardiovascular complications are significantly reduced when you lower the blood pressure within 6 months of the diagnosis. So ladies and gentlemen, when you diagnose hypertension, please try to achieve the goal within 3 to 6 months, because otherwise you are prolonging the duration of hypertension. You don't want to prolong the duration of hypertension. You want to decrease the duration of hypertension and prolong the duration of normal blood pressure. And the importance of combination therapy is shown on this slide. If you look at 24-hour blood pressure monitoring, and if you look at the central curves, which is orange and green, these are two antihypertensive drugs. Let us say telmisartan and amlodipine, they lower the blood pressure. But when you combine them, the blood pressure is actually lower than what you get with monotherapy. So ladies and gentlemen, that is the reason why you must combine antihypertensive drugs right from the beginning in order to achieve the goal level of blood pressure. Now I'm almost done in the next minute. So in conclusion, ladies and gentlemen, if you look at the slide, there are three definitions of hypertension: European Society of Hypertension, European Society of Cardiology, American College of Cardiology, American Heart Association, International Society of Hypertension, global guidelines. They all define hypertension in a different manner, but they have the common goal. You see, the goal in every classification is to achieve 130 or 80. So please don't start arguing with me or anybody about the definition of hypertension. There's no point in arguing, because the winner is the goal blood pressure, not the definition of hypertension. So in conclusion then, Mr. Chairman, Samir Dani, Dr. Ruchi Mehta, and the scientific committee of this wonderful meeting, let me conclude by suggesting that the new goal for the treatment of hypertension is 130 by 80, based upon global evidence of the last 50 years. For the last 50 years, the evidence suggests that you are better off in having a blood pressure of 130 or 80. Don't settle for 139 by 89, because that is where the highest cardiovascular mortality. Now, when you want to start treatment, please start treatment early, because the longer you wait, you're prolonging the duration of hypertension. But if you start the treatment early, you actually decrease the progression of hypertension, and the patients are prevented from having high blood pressure for too long. In other words, to apply the current term that is in vogue now in public health, you want to plateau the curve. You want to plateau the curve earlier on so that there is no further rise in blood pressure. So ladies and gentlemen, with the time that was allocated to me, I hope that I have given you some pathway from complexity to simplicity in terms of the treatment of hypertension and the goals for blood pressure treatment. And most importantly, I hope that I have provided you the scientific evidence to the new therapeutic goals, which are most applicable to India among all the countries in the world. Samir, your colleagues, Ruchi and others who have worked so hard on this conference, let me offer my salutations and respects, and I'll conclude with these remarks. Thank you very much.
Thank you, Dr. Venkatram. Great talk, as usual. And in the interest of time, I would ask you to stay on in the session, and I would quickly go to Dr. Upendra Kaul, who is going to give us the next.
I will.
Thank you. Adi, can we have Dr. Upendra Kaul's bio slide, please, quickly? Dr. Upendra Kaul is very well known all across the country. He's been past president of Cardiological Society of India and SARC Cardiac Society. He's Padma Shri awardee, and he's also received Dr. B.C. Roy Award. He's one of the pioneers of interventional cardiology in India. And I'll hand over the mic now to Dr. Upendra Kaul to talk about India Heart Study and its clinical implications.
Can I share my screen? I'm not able to share the screen. Okay, is the slide visible?
Yes, sir.
Great. So it was wonderful coming into this meeting, and Samir and your team needs congratulations for all the hard work during these days, you know, when we're busy with fighting something else also. And it's again wonderful seeing Venkat preceding my talk and giving us a holistic view of hypertension, general principles of treatment, how we should treat it, start it early, the goal. There is no goal. If you are at 120, it's much better than 130. If you are at 110, it's much better than that. Well, I am going to talk about something. Can you mute other? Lot of noise coming.
Hardik, lot of noise. Can we please mute everybody else?
So I'm going to talk about hypertension is hypertension, but is it different in Indians? And that is India Heart Study and its clinical implications. And we have heard of Peter Drucker, who was the person who brought in consultancy and management, who died only in 2005. He said that what gets measured gets managed. So I, on behalf of, more than 1,400 investigators of India Heart Study, am privileged to present the data. What was the need for this study, and what's the objective? What was the objective of this study? First of all, the office blood pressure measurement and blood pressure measurement during one visit, whether you record it once or twice, is it enough for diagnosing hypertension? Then white coat hypertension, all of us know that blood pressure measured in the office sometimes, quite often, is higher. It crosses the definition of hypertension, and when you measure at home, it's not. And masked hypertension, that means in the office your blood pressure is normal, within quotes, and when you go home, it is high. And what is its prevalence in Indian subjects? Then the blood pressure method, we know it's very important. The setting and the device can influence the diagnosis of hypertension, office versus home. And what I think is very important, the diurnal variation of blood pressure and average heart rate in Indians. Because as Venkat also was telling that, morning surge, morning blood pressure being higher, which we have been taught for, umpteen number of years. Is it true in our Indian population also? Now, the inclusion criteria of this study were, males and females above the consent giving age. And they should have been all drug naive, and they were not basically labeled hypertensive. They're just coming to a physician for, just any checkup, and the blood pressure recording had to be between 100 and 180 systolic and 60 to 100 diastolic. And we excluded the patients who could not record the blood pressure at home, were not willing, because we gave them a BP instrument, were not willing to consent. And the blood pressure, if it is higher than 180, obviously we don't wait for weeks together, so forget about it, they get treated. Secondary hypertension and patients on antihypertensive medication irregularly or regularly were not a part of the study. Now, what was actually done? At the first office visit with the practitioner, he would record the blood pressure, whatever way he's recording. Sphygmomanometer, oscillometric method, which was not very common, and the dial kind of a BP instrument. After that, and whatever way he records, whether he records 3 times, 4 times, 2 times, it's up to him. Usual, we're not telling him how to record it. Then the subject is given this a BP instrument called Watch Blood Pressure Home A, made by Microlife. And Microlife was one of the co-sponsors of the study also. And home blood pressure measured for 7 days. He was told to measure the blood pressure, and we'll talk about a little bit more about how it was measured, for 7 days, and discarding the first day's reading, because white coat hypertension comes there also. And after those 7 days, he would return this machine to the physician who gave him, and the physician again records the blood pressure the way he wants to record, the way he had recorded it. And there were no readings, digital readings coming to the person while recording it in order to alarm him, and they were all recorded inside. And once the machine is given, you log in and you get the 1 week's complete data. Now, the study had more than 1,200 investigators, so as not to put burden on them, 14 to 15 cases per investigator. It was done in 15 states of India, 355 cities. We screened up more than 23,000 patients, but analysis could be done only in about 18,900 patients, because either the data was inadequate in about 1,100 patients, and the data could not be uploaded from the machine which had been given in more than 3,000 patients. So that was excluded. Now the participation, as you see, is more or less all over India. I can't say all the states, but then as I told you, several states. Tamil Nadu was the champion, and Gujarat was close at number 2. So significant contribution from all the people. Many of them who are sitting there or watching this would be possibly the investigators. Well, we know that mercury manometers have been outdated. Since 2017 December, they've been banned in India. But in spite of that, 70% of doctors still used mercury BP instrument at their clinic measurement. And 22% use the aneroid BP measuring device, which also needs regular calibration, as we know. And we know that from January 2020, the BP measuring machines have been actually relegated, regulated as a device, as per the Drug Controller of India. Now, what is this Watch BP Home A machine? It is a nice accredited machine. It is a device also complying the European and the British standards. It is validated for BP measurement in 11 different conditions. And has a dedicated diagnostic mode for home measurements. That means it would record pressures only between 6 and 10 a.m. in the morning and 6 and 10 p.m. in the evening. And person was requested and advised, measure it at around the same time in the morning and evening. And device is blinded for subject to avoid any white coat hypertension. He cannot see the reading, he or she. And then, this validation is universally acknowledged and done. Like they say that it has to be larger the number of subjects, the more statistically significant, and depends on the population of the place where you are validating. Like European Society says, it should be validated in at least 33 subjects. The British Hypertensive Society and Association of Advancement of Medical Instrumentation says 85 to 86 subjects, and across Germany about 96 subjects. Now, these are the parameters of validation. You can see that end-stage renal disease, diabetics, elderly, dialysis, preeclampsia, pregnancy, patients, people who have hypotension, children, obesity, wide cuff, wide range, atrial fibrillation. So these are the conditions where theoretically and scientifically the machine should be validated. And as you can see, MicroLife scores the maximum, followed by Omron, and then there are several other machines. And this is from, the website which displays all these things. Now, the blood pressure values, as you can see, what did we record? We recorded that the systolic blood pressure in the first office reading and the second office reading in the blue, you see there's a difference. The first time when he came and after a week when he comes, there is a blood pressure. Second time the blood pressure is lower. But in the home blood pressure measurements of 1 week, when Monday is taken off, it is significantly lower. The home blood pressure average of morning and evening is 128. Numbers appear small, but when you have a large study, they're all very significant. Likewise, in diastolic blood pressure, you would see that the home blood pressure is significantly lower than the office blood pressure, and first visit is higher than the second visit. Now, one measurement in the office is not enough, we know that, but multiple readings in the office also are not. And as you can see, as per office blood pressure measurements, the results of 2 office blood pressure measurements also, there would be a discrepancy in about 1/3 of the persons in calling them hypertensive. So that is the very important, message. As we know that the guidelines say that BP can be highly variable, and a single office visit should not be sufficient. So taking that also between 1 and 2, 1 week difference, and home blood pressure, there's a difference. Home blood pressure being lower. Then the other thing which we found, and we're surprised, that the evening pressure in these, about 14,000 patients, 14,000 subjects, was higher as compared to the morning blood pressure. And if you look at the home blood pressure monitoring, here systolic and diastolic, you will see that the evening blood pressures are higher, and I'll amplify this further. that is even the home blood pressure measurement when the person is relaxed, the evening blood pressure is significantly higher than the morning blood pressure. And WHO, as rightly said by Venkat also, that Public Heart Health Foundation as well as WHO estimates that 60 to 65% of cardiovascular disease burden is going to be shouldered by Indians, and hypertension is one of the most important risk factors besides diabetes. The other important finding which we have seen is the average heart rate. The average heart rate, whether it is recorded in the office or recorded at home, this is the morning, this is the evening, and this is average, is close to 80. Whereas, we know that we've been taught that it should be 70 or average of 70. So that is the other thing. Is it again a sympathetic overdrive? Well, the study population, it was elevated in all the way, both the sexes, which to many of us suggest a sympathetic overdrive among us. White coat hypertension and mass hypertension is an issue even at the second visit. As you can see, in the first visit, white coat hypertension was present in 24%. In the second visit, although less, but it is still present in 13% of cases, which is significant. But masked hypertension remains unchanged, possibly a little higher in the second visit, 18% and 20%. So this again, I think, is a very important finding. And it was seen that females were more prone to white coat hypertension, whereas males were more prone to masked hypertension. Now, if we look at the comparison of white coat hypertension and masked hypertension with some other large studies, you would see that India Heart Study shows it is higher, white coat hypertension significantly higher, masked hypertension also marginally higher. So the importance of white coat hypertension and masked hypertension, was it important? White coat hypertension would be meaning that unnecessarily treating these people with pharmacological agents, it is not necessary. If one only does an office blood pressure measurement, that means misdiagnosis. Masked hypertension is again a dangerous thing. It would not be treated if one only does an office blood pressure measurement. And clearly, unless one also does home blood pressure measurement, one may miss the diagnosis or may misdiagnose, both of which can be of clinical significance. Now, these are the lessons which we have learned. First of all, high prevalence of white coat hypertension and masked hypertension. Number two, which we have found consistently, evening systolic blood pressure being higher than the morning systolic blood pressure, and elevated resting heart rate by at least 10 beats. So based upon these findings, we feel that Indian hypertensives are different, and should Indian hypertensives be treated differently. And these are the clinical implications. And we know, from this particular paper that sustained hypertension has the maximum chance of having events, more than 1.44 times. Masked hypertension, 0.78 folds. White coat hypertension only 0.35 folds. So these are the hazard ratios. We know sustained hypertension is the worst. White coat hypertension and masked hypertension may not be so bad, but sustained hypertension is important. The other thing is the high evening systolic blood pressure. This has consistently been seen in both the home blood pressure measurements as well as the office blood pressure measurement. You can see morning, evening here. You can see morning, evening here. So is it that we need to have an altered chronobiology which leads to these distinct disease patterns? And we came across a recent paper about chronotherapy. What is chronotherapy? It means individualizing the antihypertensive treatment according to the circadian profile of blood pressure. And in this very large study of more than, more than 40,000 persons, it's not an Asian study, European study, which shows that cardiovascular events in 19,000 patients, it's 19,000 patients with hypertension with a follow-up of 6.3 years, if the person takes all the blood pressure or more than one drug at the bedtime versus taking first thing in the morning, which I also used to take about till 6 months ago. I've changed my pattern of taking medicines. There's a 40% reduction in the cardiovascular events and event-free survival. And if we take 1 minus cumulative survival, this persists. And this is again 18,000 patients. Now, the best thing is to have a 24-hour BP control. So improving the management of hypertension and organ protection towards achieving very low cardiovascular events in our population, we need to have a strict 24-hour BP control, including the night blood pressures, the nocturnal dip. If the nocturnal dip is not there, we should have a treatment where the nocturnal blood pressures are, better than, in the morning therapy. And once again, the elevated resting heart rate, is it important or we can just ignore it? Well, we have a lot of data from our own country that sympathetic overactivity is a universal phenomena. And this particular study, in which Samir Dani is also one of the co-authors, showed that sympathetic overactivity in newly diagnosed hypertensives was more than 60%, as if they are on a treadmill or being chased by a snake. And you can see the increase of cardiovascular risk with baseline heart rate. This we know from many, many decades. Lower your heart rate, lower is the mortality. 60 to 70 versus around 80.
You will have to conclude now.
I'm just going to finish. This is the BEAT survey, which again shows the same from Dayasagar Rao, that heart rate more than 10 has been found by them, and that is of prognostic importance. And once again, in 3 different countries, you will see that the lowest rate in Finland, lowest mortality, longest lifespan, Japan in between, and India comes there. So antihypertensive agents like calcium blockers also, if they are of a particular variety which reduce the heart rate, would be better, like cilindipine or benedipine. Antihypertensives acting on sympathetic overactivity, like the beta blockers, beta-1 selective blockers, because beta blockers like atenolol and others have been into disrepute. So nebivolol and bisoprolol may be better. So this is my take-home message, that blood pressure needs to be measured at home and in the clinic with clinically validated, accurate oscillometric devices. And they become very important today. With physical distancing, you have to measure it yourself. Indians, both normotensive and hypertensive, seem to have a sympathetic overactivity, elevated heart rate, evening systolic blood pressure, and relatively higher heart rate, morning, evening being higher. Nocturnal, non-dipping, higher heart rate is prevalent, and this we have also confirmed by our ambulatory BP monitoring study. White coat hypertension is prevalent, widely prevalent. Chronotherapy might determine timing of the dosing of antihypertensive drug. And for Indian hypertensives, the choice of antihypertensive drug should be based upon our guidelines, which could be, looked into by a number of people, including Venkat and Wander and Samir Dani and so many other people. Thank you very much.
Thank you very much, Dr. Kaul. We have, I think, Dr. Satyavan Sharma is there. Sir, can you unmute yourself? Dr. Satyavan?
Yeah, am I audible?
Yes, sir, you are audible. We can't see you though. Yes, sir.
Yeah.
Sir, your comments on...
Can I ask a very quick question to Monan? Is he
yes, sir.
there?
Please, sir. Please, sir. Please, sir.
Yeah, Monan, it was a great talk. I just wanted to know whether you have analyzed your data about the women, whether what type of infarcts they are getting, and also the premenopausal women, because in real world we do see a lot of premature infarcts in women who are in their premenstrual period. So have you analyzed your data in that direction?
Sir, we have analyzed the Kerala ACS registry and published one paper in the Indian Heart Journal maybe about 4 or 5 years ago, done by one of our residents. And that showed surprisingly, there was no difference in the management pattern of men and women, which is unlike the Western data, I should admit.
And risk factor profile?
Also near similar. But then it could be the women percentage was 21 and 89. I mean, the 79 was men. So it could be a skewed data. We can't be very certain about that.
Right. That's great. And is Venkat there?
Yes.
Yeah, Venkat, of course, it was as always a very educative talk. You made a statement that the days of monotherapy are gone and we should always give combination therapy. There are many clinical scenarios where a person is having a blood pressure of 140 by 90 or 130 by 90. You have exhausted all the lifestyle modifications. So do you begin in every person with a combination therapy, or there is scope for monotherapy in some of the individuals?
Yeah, this is a question that should come up when there is always a scope for monotherapy, but monotherapy has not served us well in the last 40, 50 years. People who are very fragile, very elderly, those who have postural hypotension, diabetic neuropathy, obviously you don't want to drop their blood pressure too drastically. But if you look at majority of people who are in the middle of the bell-shaped curve, they should be able to tolerate initial monotherapy, initial combination therapy very easily, and you achieve the blood pressure much faster. Otherwise, monotherapy, what happens is 2 months of this monotherapy, 2 months of that, you lose a lot of time and then the patients lose interest. So another important facet of combination therapy, you achieve the blood pressure goals very quickly, like making a patient with fever, you make them afebrile quickly. So very similarly, there is a role for monotherapy. In some people, you want to try it, sure. But I think all the guidelines suggest a combination therapy because the cost of combination therapy per unit dose is very similar to monotherapy, and you'll gain time.
So are we moving towards combining two drugs in smaller doses?
Yes.
Okay.
Yes. In fact, many of the regulatory agencies, including DCGI, have been approached not to approve single molecules for hypertension anymore, but approve combination molecules. It can be old combinations, doesn't matter, but it will be easier for people to use combination therapy, especially if it is fixed dose combination.
Thank you.
Thank you. We can have one quick question, otherwise we'll just conclude because we have run a little over time. But sir, you want to make any more comment?
Mohanan, for women with coronary acute event, I mean, I'm not an expert. I heard they probably have more coronary dissection than men. Is that true? They have more coronary dissection?
They have more plaque erosion, sir. At least we don't have any definite data, but whatever the Western data says, erosion and then rupture.
Coronary dissection is also one of the types of coronary artery disease more common in women in relation to pregnancy.
Absolutely, sir.
Okay. My sincere thanks and gratitude to all the three speakers. We had a wonderful time and a very great discourse on the topic. Thank you very much, Dr. Mohanan, Dr. Venkataram, and Dr. Kaul. And Dr. Satyavan Sharma, thank you very much, sir, for joining us. Can we have Hiti, are you there to introduce the next chairperson?
Yes. Thank you so much, speakers. We would now move on to our next symposium, that is the Heart Failure Symposium. I would like to warmly welcome our chairpersons, Dr. Amit Vora, EP and heart failure specialist, also the Vice President of Heart Rhythm Society, Dr. Rajiv Chawla, who is Senior Consultant Diabetologist and Honorary Professor at the Jaipur National University, and Dr. Parag Shah, who is Senior Consultant Endocrinologist and the Director of Gujarat Endocrine Center at Ahmedabad. Would you please now invite the speakers?
Dr. Amit, you can take the lead, or Dr. Rajiv.
Samir, shall I start?
Yeah, we can start with Dr. Rajiv Chawla or Dr. Parag Shah. We have Dr. Yehuda's talk first. So please welcome all of you chairpersons. Lovely to see you.
Thank you. Good afternoon. Thank you, Dr. Rucha, Dr. Samir, for this opportunity. It's a pleasure to chair this heart failure symposium, which is today one of the most important topic, as is very rightly said, heart failure, which is something like we never realized it could be so important, and it is something like an elephant sitting in your room or in your bedroom. And we know that heart failure management has evolved over last 1 decade at least. So from earlier days to treatment, now talking about the prevention of heart failure, both in diabetics as well as non-diabetics. And so has the management between diabetologists and cardiologists as far as heart failure is concerned, irrespective whether it is diabetic or non-diabetic today. And I'm sure we all know DAPA heart failure, which has been a sort of momentous victory against heart failure in type 2 diabetes. And based on the data, both DCGI and US FDA have already approved dapagliflozin in management of heart failure as a standard care, irrespective whether you are a diabetic or diabetic, non-diabetic. So to address these two issues, we have a wonderful galaxy of speakers amongst us. The first one being a cardiodiabetologist, Dr. Handelsman, he's a medical director and principal investigator, Metabolic Institute of America, chair and program director of annual World Congress on Insulin Resistant Diabetes and CVD and the Heart in Diabetes Medical Congress. He's chair and founder of the International Lipid Forum, has been past president, American College of Endocrinology and American Association of Clinical Endocrinologists, past president, Pacific Lipid Association, has been on board of director, American Association for Preventive Cardiology, has been a program chair and director, Fourth Heart in Diabetes live online, and is still actively practicing endocrinology, diabetes, and metabolism at California. So this forum is open for you, sir. And let's hear from you, management of heart failure, shuttling between diabetologist and an endocrinologist. Dr. Hanselman, it's open for you. Can you hear me, sir?
We
Yeah,
have
so-
Dr. Chawla.
Do we have Dr. Hanselman already online?
Yeah, Dr. Chawla, due to some personal reasons, he was unable to join us, but he has sent us his recorded talk. So we are going to play that and we will
Please, yeah, you may
summarize
play
the
that.
questions with the
Perfect,
chairperson.
perfect,
So
perfect.
Hardik, over to you.
Yeah. Dr. Amit and Parag, we will conclude later on. Yeah, you may run the video.
In practice in Los Angeles, California. I'd like to thank Dr. Daniel Mehta and Defonso for asking me to participate in this global cardiometabolic conclave, very impressive international meeting, and be a part of the Heart Failure Symposium. My lecture is going to be on heart failure and diabetes, the role of the diabetologist and cardiologist in prevention and management. I am also the medical director and principal investigator of the Metabolic Institute of America. I'm involved in a couple large educational initiatives on heart and diabetes and insulin resistance. But primarily, I'm a clinician in my own solo practice of endocrinology. These are my disclosures. I research, I'm a consultant, and I do speak. Just a reminder that having diabetes by itself already gives us a bad prognosis. In fact, people with diabetes would live 6 years less than people with no diabetes. And if they had a heart attack, they will live 12 years less. So that's a bad prognosis to have to begin with. And in fact, that's what we used to look at. We looked at the cardiovascular aspect of diabetes. We looked at MI and strokes and kidney disease, peripheral disease. That's where our focus has been for years. However, it is interesting to know that by some estimation, congestive heart failure is more prevalent in people with diabetes than is myocardial infarction or peripheral vascular disease. I know some other studies would show MI above congestive heart failure, but be it as it may, heart failure is a very bad disease and it quite prevails with diabetes. In fact, about 40% of people that have heart failure already have diabetes. And diabetes is a severe risk factor for the development of heart failure. And those people with diabetes have a poor prognosis. In fact, you can look that by 3-4 years, there can be up to 75% mortality in this population based on this 5 years analysis published by Bertoni in 2004. And it's like this magic circle. Heart failure causes worsening of kidney failure, and kidney failure causes worsening of heart failure. So this cardiorenal concept is something that we are going to see much more, and we believe one fits the others and one is contributing to their dire outcome of the other. And the relationship to diabetes, most likely through insulin resistance, and Ralph DeFronzo is here and he can discuss it further. However, we are looking at that relationship between hyperglycemia and insulin resistance, and we know that that is causing worsening of the myocardium. In fact, there were trials in the past with medications that improve insulin sensitivity to show that they improve actually heart failure. Problem is the TZDs that we used to try, they also cause fluid overload, and that can be a different issues. But this relationship, insulin resistance, hyperglycemia, and heart failure, this is a very bad relationship. And diabetes, as you can see, is the most predictive of heart failure risk, more than MI, obesity, hypertension, hyperglycemia. The worse the hyperglycemia, the more incidence of heart failure we are going to witness, and the worse would be the outcome. And in fact, look how early it starts. You can see here that at an A1C from 5 till 6, there's already a lot of development of the risk of heart failure. And that may explain when we see here, we see the incidence and prevalence of heart failure by age. It doesn't matter if you look at the incidence or prevalence. What's important is that in the gray line, we clearly see that heart failure is disease of the aging. The older the person, the more heart failure we will see. We can see that it would start at age 65, 70, and the graph will get steeper only by age 75 or so. But people that have diabetes, this all changes. We already are going to see heart failure start at age 45, if not earlier. And we see that there is a steep curve going all the way forward. Diabetes changes the natural history of heart failure in the population. And as such, we are going to see that people that have diabetes will be hospitalized that much more than people with diabetes. Well, hospitalization for heart failure. I used to look at that and say, oh, it's only hospitalization. Does not mean much. But the person who walks into the hospital with exacerbation of heart failure does not come out the same. And in fact, those who came in with heart failure, 60% of them will be re-hospitalized that year again with heart failure. And further, the number one reason for re-hospitalization for 30 days. So look at this very interesting graph, and you can see those colors go next to another. But 2 hospitalization for heart failure increases death by 20%, 3 by 32, 4 by near 50%. And this is the people that already have a grave prediction of their future. So trying to prevent hospitalization of heart failure, trying to prevent exacerbation of heart failure is of prime importance when we are dealing with population. So looking at the task that I was asked to put together, what would be the role of the diabetologist and the cardiologist? Well, prevention seems to be what we can do, endocrinologists, diabetologists, internal medicine, primary care, while management, that will end up at the end of the cardiologists, perhaps those that are heart failure specialists. And if I can do anything, and one of the reasons that I agreed to come on this call is really to kind and try to make a call for action, ask you, diabetologists, endocrinologists, primary care physicians, nurses, people that are involved in the team, in the care of people with diabetes, try to identify the patient at risk. Try to prevent heart failure before it happens. But once you recognize there is heart failure, please, by all means, refer the patient to the heart failure. How can we identify heart failure? Symptoms are quite general. Dyspnea, tired, sometimes dry cough, insomnia. Clearly, they get edema and pulmonary edema and so on. Yes, then we know more. Ascites, we know more. Swelling of the feet and the ankles. But often, all it takes is for a patient with diabetes to come and say, hey, I get short of breath and I don't understand why. And we can do an EKG and we don't see any problem, no chest pain, no issue. And the person say, hey, I can't walk up anymore 2 flights of stairs or 1 flight of stairs. And I recall I had a patient with type 1 diabetes, young, energetic, and athlete, all of a sudden was unable to walk up flight of stairs, and we could not diagnose him with heart failure, which he most likely. So what can we do today when we are looking at heart failure? Well, we can measure NT-proBNP. If we see it goes up, even by 25 points, from 100 to 125, let's put the patient in a mortality risk. And if they're obese, the NT-proBNP even should be lower at the 50. Very simple. You add a blood test, and when you check lipids or kidney function or liver function, there's a simple campaign. Just add BNP, or better yet, NT-proBNP. Very simple test. Elevated, now you can perhaps send to the cardiologist to further evaluation, or you can maybe evaluate further. What can we do in the clinic? Here the test. Now, 6 minutes walk. Very simple test. A lot of the cardiologists, the heart failure cardiologists are doing that. We just walk for 6 minutes. Average walk should be 500-600, maybe 700 meters. But people that have heart failure with preserved ejection fraction, even those with, definitely those with reduced ejection fraction, they will walk much less, and those with diabetes even further less. So the 6-minute walk, if your patient can't walk 300 meters in 6 minutes, tells you they have a bad condition. A simple clinical tool. Your nurse can do it for you. And once you suspect, either by the lab test or you suspect by the 6 minutes walk, do an echo. I have an echo in my office. I order echoes for my patients. If I don't have, I can send the patient to a cardiologist to do an echo. Often we have to tell the cardiologist to look for heart failure. Many sometimes can miss heart failure with preserved ejection fraction. Yeah, reduced is much worse. But those that have preserved ejection fraction, we often don't diagnose them well and on time, and we should. So our job is to try to identify the patient based on simple characteristics. As I said, short of breath, cough, not sleeping well, definitely edema. Do the NT-proBNP, maybe do the 6 minutes walk test, or order an echo. In the echo, we used to look at something called diastolic dysfunction. We don't go into that much. I know that Dr. McMurray is going to speak just after me, and he actually may tell you a bit more about how we are looking today at HFpEF and how it's been changed from the time we looked at just diastolic in our patients. What are major risk factors for heart failure? Well, we've known them for years: hypertension, obesity, clearly age, I mentioned that, lipid disorders, chronic kidney disease, coronary heart disease. We mentioned all of it, and all of them are associated also with. So when we look at heart failure here, we see that there are two modes to developing heart failure. From the top, what we call the traditional mode, ischemic heart failure, which can cause increase with coronary disease, also high blood pressure, peripheral vascular disease. All these can impact development of heart failure. Or the direct effect of the myocardium, this atherosclerotic independent mechanism, whether it's an autoimmune disease perhaps in people with type 1 diabetes, maybe this diabetes cardiomyopathy. They are both leading into heart failure. So when we look, this is a study from Sweden. We're controlling 5 risk factors like high glucose and LDL and blood pressure, albuminuria, stop smoking. You can see by controlling all of them, didn't matter what was the age, they were able to reduce progression to cardiovascular disease. However, when you look at heart failure in young people, where the main reason is most likely cardiomyopathy and not ischemic heart disease, it was much harder to control and reduce heart failure just by controlling risks for cardiovascular disease. So the recommendation is, yes, there are areas we cannot change age. We may not be able to change diabetes cardiomyopathy, but we clearly change the rest of the risk factors that we have, whether it's diabetes or hypertension or valvular disease, obesity for sure. We can change all of that to improve our patient outcome. And that's our role of doctors of prevention. We don't want to manage heart failure. It's tough. John McMurray will tell you, it's very tough to manage people that already have heart failure, whether it is with reduced function or even preserved function. And I'm sure he'll go into that than I do. I want to mention the SGLT2 inhibitors' role in reduced hospitalization. Again, I have no doubt that Dr. McMurray will tell you some more, especially in the studies that I'll mention called DAPA-HF that he was involved with. And even though he's addressing preserved heart failure, I know that he will touch upon that for sure. And what we are seeing from studies like EMPA-REG, Canvas, Declare, but it didn't matter whether they had heart failure in baseline or not. Giving SGLT2 inhibitor prevented more heart failure hospitalization. And when we look at another analysis, people that had atherosclerotic cardiovascular disease at baseline, like in EMPA-REG and Canvas and Declare, even at Vertis, at the new trial, Credence, we could see reduction in heart failure hospitalization. So we can prevent it from happening, but not only in those that already had an event. We could see in Declare, we could see in Credence that those people who did not have established cardiovascular disease, just risk for that, also were able to prevent hospitalization for heart failure. When I mentioned DAPA-HF, and it really is the world of John McMurray, but the issue here is we saw that the impact of SGLT2 inhibitors was in prevent events also in people with no diabetes. I mentioned that for you to realize that this impact is independent on its glucose effect. So we are looking at two aspects. High glucose is bad. We need to control glucose because no long-term high glucose will worsen heart failure, as I showed you originally. However, on the immediate aspect, SGLT2 inhibitors will reduce hospitalization independent of glycemia, and therefore, I believe that this medication should be part of standard of care of going forward. And I'll show you some guidelines looking at that. Remember, I mentioned the anti-proBNP. So again, at DAPA-HF, we saw that giving the SGLT2 dapagliflozin did reduce anti-proBNP in this population. I don't know what it means, and maybe John wants to tell you if he knows, but to me it says if a high level is risky, a lower level is better. Maybe it's a sign it is doing better. Many guidelines have incorporated SGLT2 inhibitors into their recommendation for practice, ADA, ACE, American Heart Association, the Society of Heart Failure, American College of Cardiology, and also we saw the ERA EDTA, that's nephrology. The new 2019 European Society of Cardiology said it is class 1 to give an SGLT2 to lower risk for heart failure hospitalization. The ADA and ASD say anybody who has risk, if they have diabetes, on top of metformin, should be given SGLT2 inhibitor if they can, if not a GLP-1, to prevent heart failure and MACE. In fact, in 2020, the ADA now joins the recommendation by ACE, the American Association of Clinical Endocrinologists, and for full disclosure, some of you may know that I am one of the writers of these recommendations, and we are actually saying it's independent of glucose. Doesn't matter what is glycemia. Newly diagnosed type 2 person, even not on metformin, only lifestyle and exercise, A1C 6.4, have high risk for heart disease, you have to give SGLT2 inhibitor or GLP-1 receptor agonist, whatever you prefer, but maybe the SGLT2 inhibitor to prevent the next event of heart failure or hospitalization for cardiovascular disease. And this is the ACE recommendation for practice, which in one slide shows you both. Shows you the need to control hyperglycemia, traditionally metformin, GLP-1, SGLT2, do 2 drugs, 3 drugs, whatever is needed to do here. However, to prevent the next heart failure hospitalization, you give an SGLT2 inhibitors independent of glycemia. And that's what you see in those green boxes in the bar. Okay, the last couple of minutes, I want to touch upon, again, the question, who should meet or who should manage those patients that have diabetes and cardiovascular disease and heart failure. And so, again, some of you may know that I'm involved in this program called Heart and Diabetes. I show you some data from 2018. We also had a meeting in October 2019. This year it will be virtual, just like this meeting. And we wanted to look who should be the expert. So we got a group of endocrinologists, cardiologists, people that work for industry, and we said, who should be the specialists who manage these patients on this interaction of diabetes and heart disease? So some people said, oh, it should be people, we call them cardiabetologists, or I call myself sometimes endocardiologist. But the majority of people say, hey, how about we will just keep referring to the experts, which I keep doing. But then a couple people that are preventive cardiologists, I mentioned here Sergio Fazio, Michael Shapiro, they say, hey, it's all in the hand of the preventive cardiologist. Many of you may know of Robert Eckel. Bob is the president of the American Diabetes Association, and he actually suggests that there should be a cardiometabolic medicine fellowship. Grand idea if it comes out. And he described how to do it to go forward with that fellowship. And I will also tell you that there are now some places where they've got multidisciplinary centers where they've got an endocrinologist and cardiologist and nephrologist and a primary care physician and obesity specialist, maybe exercise person, a dietitian, a whole team to manage the patient. So in conclusion, when we are looking at the heart failure and diabetes, at the role of the diabetologist in green for prevention, the cardiologist in red for management, heart failure is becoming the most common complication of type 2 diabetes. Heart failure, both HFrEF, worse, or HFpEF, is associated with poor prognosis. Hyperglycemia worsens heart failure. However, glucose control by itself has minimal immediate impact and does not seem to lead to improved heart failure outcome. Again, I said immediate, not long term. Identifying patients at risk and prevent heart failure leads to improved outcome. And the role of the diabetologist, endocrinologist, and primary care physician is to identify, prevent, and refer to the cardiologist when needed for management. SGLT2 inhibitors in both randomized clinical trials and real-world studies show that they can prevent heart failure and reduce heart failure hospitalization, morbidity, and mortality across a severe risk continuum, both primary and secondary prevention, and, as I said before, even in people with no diabetes, perhaps prediabetes or obesity. Contemporary guidelines do recommend SGLT2 for type 2 diabetes with established or high risk for cardiovascular disease independent of glycemic control. And creating a new cardiometabolic specialty may take years, if at all. And until such a time, perhaps the multidisciplinary centers that will develop will be a good answer to managing this population. And with this, I am thanking you for your attention.
Thank you, Professor Handelsman, for a very.
By my wife, and next after me, I believe.
Thank you, Professor Handelsman, for a very enlightening talk on heart failure management and diabetes. Diabetologist or endocrinologist and cardiologist to play together. Very rightly said, it is one of the most common complication, and prognosis in type 2 diabetes with heart failure may be as bad as is any malignancy at 5 years. And we need to have a multidisciplinary approach towards management of heart failure. I think question answer we'll have after the next session. So Dr. Bora
Yes.
and Dr. Shah, you may take over. Prab Shah, you may take over. And toward the end, we will have discussion.
Can we have Dr. Vora to please introduce Dr. McMurray?
Sure. It's indeed a privilege to have Dr. McMurray with us in this conclave. While this ongoing pandemic of COVID-19, we should not forget about the chronic epidemic of heart failure. And in terms of heart failure with reduced ejection fraction, I think we have learned a lot and we are doing better. But heart failure with preserved ejection fraction, I would think, has become a child of a lesser god, so to say. Despite having known this for 20 years, we probably are still not the clinician is still not very clear how to manage it and how to effectively control it, despite 50% of heart failure patients being heart failure with preserved ejection fraction. And we have none other than Professor John McMurray to enlighten us about heart failure with preserved ejection fraction. Dr. McMurray, all of us know, is the immediate past president of the Heart Failure Association of the European Society of Cardiology, and currently is the Deputy Director of Cardiovascular and Medical Sciences at Glasgow. Over to you, Dr. McMurray.
Thank you very much. So I'll just need somebody to let me share my screen. Thank you very much. So let me set myself up here. Okay, so thank you. Just getting my pointer and everything sorted out. So yes, it's my pleasure to talk to you for a few minutes about heart failure with preserved ejection fraction. I'm not sure how enlightening this will be because I think, as everybody's hinted, we haven't really made as much progress in this heart failure phenotype as we have with heart failure with reduced ejection fraction, which you've just heard about. And in fact, I think the best thing we can say about heart failure with preserved ejection fraction today is that we should try and prevent it if at all possible. And you just heard one of the approaches that we can take to preventing this with SGLT2 inhibitors. Of course, control of hypertension is the other pivotal intervention that reduces the risk of this type of heart failure. So these are my disclosures. I do lots of clinical trials, and my employer, which is Glasgow University, has paid for my taking part in those studies. So this is what I want to go through quickly with you. So I want to talk about the terminology we use to talk about heart failure. Then I'll mention heart failure with reduced ejection fraction. That might be surprising, but actually to understand heart failure with preserved ejection fraction, you have to know about heart failure with reduced ejection fraction. Then I'll say a little bit about how these two syndromes differ, and they do differ strikingly. And then I'll come on to treatment, including treatments that are in the pipeline. So the terminology has been very confusing, and I think Yehuda just really alluded to that. And for example, until recently, people sometimes talked about diastolic heart failure, but we don't do that anymore for reasons I'll come back to. Actually, when I started in this area, the most common description of these patients was heart failure with normal ejection fraction, but we don't call them that either for reasons that I'll allude to in a moment. But we do talk about ejection fraction, and I know many of you, of course, will be very familiar with what an ejection fraction is, but maybe not everybody is. So just to remind you, when we talk about ejection fraction, of course, we're talking about left ventricular ejection fraction generally, and left ventricular ejection fraction simply, as the name suggests, is the fraction of the volume of blood in the left ventricle when it's relaxed and filled that is ejected when the left ventricle contracts. So it's a measure of left ventricular contractility, some people would call systolic function. And a normal ejection fraction, a mean normal ejection fraction in the man is around 62%. In a woman, it is a little bit higher, but significantly so. So women have a slightly different ejection fraction range than men, which is important. And here you see the 2 standard deviation range around the mean values given in this international guidance document. So what about heart failure with reduced ejection fraction? Well, I think a lot of people have forgotten that the very first trial showing a benefit of any treatment on mortality in heart failure, the consensus trial, or consensus 1 studies we would now call it, did not mention ejection fraction. Patients were enrolled on the basis of having the clinical symptom of what in those days we described as congestive heart failure. So they had symptoms, signs, the clinical syndrome. They did have to have an increased heart size and chest x-ray, but of course you can get that with either of the 2 heart failure phenotypes. And in fact, it was only in 1991, which is not that long ago, that the description heart failure with reduced ejection fraction was first used. So this syndrome did not exist before 1991. And it was described in 1991, of course, in the second seminal study to show improvement in survival, again with enalapril, this time in a much larger study, in fact, 10 times as large, in a much broader spectrum of patients with both mild, moderate, and severe symptoms. And this trial, called the SOLVE treatment trial, enrolled patients with an ejection fraction of 35% or less. And in the title of this paper, these patients were described as having reduced left ventricular ejection fraction. And that is where the name HFrEF was first invented and has been used since. So these patients in the SOLVE treatment trial looked like this. They had dilated, poorly contracting left ventricles, very large end diastolic volume, and a considerably reduced ejection fraction. Remember, normal around 60%. And that's where we were in our understanding of heart failure and heart failure phenotypes until 2003. There were more studies with beta blockers principally, but also one with a mineralocorticoid receptor antagonist, spironolactone, identifying benefit in this population. And one of those beta blocker trials actually extended that upper limit of ejection fraction from 35% to 40% in a subset of patients who qualified for enrollment if they had additional criteria identifying functional limitation. So sort of HFrEF was described as probably an ejection fraction of 40% or less. But what happened in 2003? Why did things change in 2003? Well, things changed in 2003 because then we published the results of a program of 3 trials, which was called the CHARM program. And when we were designing the CHARM program, we had 2 trials in patients with heart failure and reduced ejection fraction using candesartan compared to placebo. But a very famous son of India, who was on our little executive committee, came up with the brilliant idea, Salim Yusuf, of course, came up with the brilliant idea that we should include all of those additional patients with heart failure who would be screened to identify the ones with reduced ejection fraction. We should enroll them as well. And we should put them in a 3rd arm to this program, a 3rd trial. And we had to come up with a name for this trial. And we had to think about what to call these patients because they didn't really have a name. So we decided to call them heart failure with preserved ejection fraction. And we used that word very deliberately because we knew that they didn't have a normal ejection fraction, which would be up here. We knew that they didn't have a clearly reduced ejection fraction, but we had to call them something. And this became known as the CHARM Preserve trial. And in fact, it was from then that the whole literature describing this syndrome took off. So that's how the term heart failure with preserved ejection fraction was invented. And it simply describes those patients who have the syndrome, the clinical syndrome of heart failure with all those symptoms and signs that Yehuda mentioned, but who have an ejection fraction above 40% as used in the original definition. So who are these patients? What do they look like? And how do they differ from patients with heart failure and reduced ejection fraction? Well, they differ a lot. They're much older on average. You can see here getting close to a decade older in age, obviously a much larger proportion therefore who could be described as elderly. Very different background, so largely a hypertensive background, much less commonly known to have coronary artery disease or certainly to have had a myocardial infarction. And although everybody says that patients with HFpEF have much more comorbidity, including more diabetes, in fact, the evidence for that is not really very strong. Yes, there probably is a bit more, but it's not that striking a difference. Obviously, by definition, the ejection fractions are different in these patients. But what's also very different is NT-proBNP or natriuretic peptides more generally, much lower in patients with heart failure and preserved ejection fraction compared to patients with heart failure and reduced ejection fraction. And of course, because of their largely hypertensive background, then even though they've developed heart failure, many of them continue to have a high blood pressure, and the average systolic blood pressure in these patients is considerably higher than in patients with heart failure and reduced ejection fraction. So there are other important differences as well. So here you see signs and symptoms, so the typical symptoms and signs that we know about. In blue are patients with heart failure and reduced ejection fraction, in red those with preserved ejection fraction. And it may surprise you, but actually generally patients with heart failure and preserved ejection fraction have more symptoms and more signs of congestion than patients with heart failure and reduced ejection fraction. In fact, the only thing that's different and is in the opposite direction is a third heart sound, as you would expect. And then maybe very importantly, patients with heart failure and preserved ejection fraction, shown again in red, have much worse quality of life than patients with heart failure and reduced ejection fraction. This is one of our favorite ways of getting patients to describe their symptoms and quality of life using a patient-reported instrument questionnaire, the Kansas City Cardiomyopathy Questionnaire. The maximum score is 100. If the score is below 100, that means reduced quality of life and worse symptoms. And you can see here that whichever one of these scores we use from this instrument, patients with HFpEF have a greater reduction in quality of life than patients with HFrEF. What about other outcomes in these two syndromes? Here is heart failure hospitalization first, and now all admissions, so first and recurrent or repeat admissions, HFrEF again in blue, HFpEF in red. And you can see that HFpEF maybe is a slightly lower risk of heart failure hospitalization, but not markedly so. And that's the same if you take into account repeat admissions. So really the two syndromes are very similar in terms of morbidity measured as hospital admission and of course the economic impact of that for healthcare systems. And I mentioned not just first but recurrent or repeat admissions, and of course we all know that patients with heart failure suffer multiple admissions. Again, perhaps a bit more of a problem in patients with HFpEF than patients with HFrEF, but you'll see in a moment why this is, because there is a competing risk of death. And this is one of the most striking and most interesting differences between these two syndromes, because patients with HFpEF have a much lower risk of death from any cause, and in particular, a much lower risk of cardiovascular death. And you can see here that the risk of cardiovascular death in patients with HFpEF is actually about half that of the risk of cardiovascular death in patients with HFrEF. So this syndrome is very different in terms of mortality, and that's a striking difference from what you've just seen for heart failure hospitalization. And it gets, of course, more interesting when you look into this in more detail. So here you see the annualized death rate per 100 person years in the CHARM program, where, of course, in our 3 trials, we incorporated the whole spectrum of ejection fraction. So, of course, patients with very low ejection fractions, very high annualized mortality, much higher than patients with a relatively normal ejection fraction. But what you also see, of course, is that the proportion of deaths that are non-cardiovascular, so due to things like cancer, infection, accidents, and other things, is much greater in HFpEF than in HFrEF. And remember, we would regard non-cardiovascular death, for example, from cancer, as death that is very difficult to modify with the interventions that we would use in patients with heart failure. We can, of course, hopefully reduce heart failure death and sudden death in patients with HFrEF. We know we can do that. But of course, these are much less common proportionately as a cause of death in patients with preserved ejection fraction. So realistically, our targets for therapeutic intervention in HFrEF are much more focused on symptoms, quality of life, and heart failure hospitalization. It's going to be a real challenge to reduce certainly all-cause mortality and even cardiovascular death. So what about treatment? I've just mentioned treatment, and I'm afraid this is where the story is really quite depressing, because here we see all the treatments we've got for HFrEF. Yehuda mentioned dapagliflozin. We've even got another drug since dapagliflozin for HFrEF. We've got a wealth of drug and device therapies for HFpEF. We have no approved treatment. It's not that we haven't tried. So here are the 4 large morbidity mortality trials that have been completed to date. I've had the pleasure of leading 3 of these, and it's very, very depressing when you don't have a clear success, as we've had repeatedly in HFrEF. Each of these has had some suggestion of benefit, certainly in CHARM preserved, definitely a TopCat. Spironolactone may well be beneficial in patients, but there were problems with the conduct of this trial in parts of Eastern Europe and Russia, and the overall result was not statistically significant. And our most recent effort was the Paragon heart failure trial. This was a sister study to our successful Paradigm trial, using a drug that is a treatment that is a combination of an angiotensin receptor blocker and an neprilysin inhibitor. And in this trial, we compared sacubitril valsartan, which is those 2 different interventions, to valsartan. The reason that we had a valsartan control arm is that most of these patients with HFpEF, for one reason or another, do get a renin-angiotensin system blocker, even if it's never been demonstrated to be a benefit beyond doubt, but they're often getting these drugs for treatment of hypertension, maybe diabetes and kidney disease, and so on. So what we were testing in that trial was neprilysin inhibition, doing that to boost, to augment, to increase natriuretic peptides, the body's endogenous defense against pressure and volume overload. And this again was a large global study. It included patients from India, but unfortunately, yet again, was not statistically significantly, did not show statistically significant benefit of sacubitril valsartan over valsartan. We came very close. The p-value was 0.059. The ratio was below 1, but the upper 95% confidence interval, as you can see here, was just above 1. So this was not statistically significant using conventional thresholds for significance. Here are the 2 components of the primary endpoint. And again, if you look at the valsartan group, this is the control group. If you look here, cardiovascular death rate was much lower than the heart failure hospitalization rate, again emphasizing the difficulty really of demonstrating an impact in cardiovascular death in this heart failure phenotype. You would need a huge trial to show a modest significant difference when you have an event rate this low. There was clearly no difference in cardiovascular mortality with an neprilysin inhibitor added to renin-angiotensin system blockade, but there was again a strong suggestion of some benefit for heart failure hospitalization. Has a rate ratio, of 0.85, with again a very borderline p-value. So a sort of strong suggestion that there might be some benefit, but not quite making it. And then these were our pre-specified secondary endpoints. And again, suggestion here in terms of Kansas City, cardiomyopathy questionnaire, certainly in terms of NYHA class, more patients improving with sacubitril valsartan compared to valsartan, so more patients improving with neprilysin inhibition, fewer patients deteriorating, statistically significant benefit here, statistically significant reduction in the primary composite renal endpoint. So again, strong suggestion of that neprilysin inhibition was doing something good, but again, not quite making it for the primary endpoint. And then to make life more complicated, when we did the usual subgroup analysis, we saw two interactions, but I'm going to talk about one of them, and that was the interaction looking at left ventricular ejection fraction, so back to ejection fraction. And we had predetermined that we would look at ejection fraction cut at the median, and the median ejection fraction was 57%. And you can see here that patients who had an ejection fraction at or below the median value seem to get benefit from sacubitril valsartan, or certainly more benefit than patients with an ejection fraction above the median. If this is true, if this interaction is credible and valid, then the rate ratio here was 0.78, suggesting a 22% relative risk reduction in the primary composite endpoint in patients with an ejection fraction at or below the median value of 57%. Now, is that credible? Well, here you see it shown in a slightly different way. This is now showing ejection fraction as a continuous measure along the x-axis at the bottom of the slide. The y-axis is the rate ratio. One is unity, in other words, indicating no difference between valsartan and sacubitril valsartan. The solid blue line is a continuous rate ratio, so that's like a hazard ratio. And you can see here that that rate ratio seems to be consistently below 1, in other words, indicating benefit of sacubitril valsartan, up to an ejection fraction of about 60%. So is this credible? Is it plausible that this subgroup analysis is a valid finding? Well, there are sort of rules that have been written, including by people like Salim Yusuf, about how we should go about interpreting subgroups. But one of the most important rules of subgroup interpretation is trying to find external data that validate the finding, because they're much more credible if you can see a consistent finding in another data set. And of course, it's important also that the subgroup interaction is biologically plausible. Well, in parallel to our conducting the Paragon heart failure trial, the European Society of Cardiology Guidelines Committee, which reported in 2016, had sort of recognized that these patients in the lower end of the heart failure with preserved ejection fraction range probably different than those in the upper part of the range, that they probably share a lot of similarity with patients with heart failure and clearly reduced ejection fraction. And in fact, the guideline committee went to the extent of actually redefining a third category of heart failure and suggested that these patients be described as heart failure patients with mid-range ejection fraction. So just to make life even more confusing, we're now talking about 3 phenotypes with this group of patients carved out of the original HFpEF ejection fraction range and described as something different. I would have actually preferred to have renamed this group, still called HFpEF, as HFnEF, patients with normal ejection fraction. But anyway, well, why was that important? Why am I pointing that out to you? Well, because of that interrogation and understanding of the data, we went back and a colleague from Sweden, Lars Lund, asked us if he could look at the CHARM data set and look at these individuals with heart failure and mid-range ejection fraction shown in these 3 panels as this blue bar. So this is a similar figure to the type that I showed you before. So along the x-axis is a ejection fraction as a continuous variable. The y-axis is the rate ratio, the treatment effect. The green horizontal line is a rate ratio 1, indicating unity, no difference. And the solid black line is a continuous rate ratio. This is for, of course, in CHARM, candesartan versus placebo. And what you can see here is that the rate ratio is below 1. The rate ratio for candesartan compared to placebo is consistently below 1, up to an ejection fraction again of around 60%. Maybe slightly different for heart failure hospitalization and for cardiovascular death, but clearly candesartan is apparently beneficial well beyond the traditional cut point of 40% for heart failure with reduced ejection fraction. So this is external validation of this idea that these patients with a not normal ejection fraction, but not clearly reduced, may be getting benefit from treatments that we know work in HFrEF. So that was the CHARM program, but then other colleagues, Scott Solomon and friends from Boston, looked at the TopCat trial with spironolactone. And again, same sort of figure here. And what you can see once again is that in terms of the continuous rate ratio for spironolactone compared to placebo, always below 1, up to an ejection fraction cut point of about 60%. So we now have 3 sets of data using 3 different drugs in 3 different trials, all suggesting that these patients, defined in 2016 as having heart failure with mid-range ejection fraction, seem to behave more like HFrEF patients, seem to get benefit from drugs that we know work in HFrEF. These patients with heart failure mid-range ejection fraction seem to have some reduction in systolic function. They seem to get some of the benefit that we see in HFrEF. And in fact, there's now a proposal that this category of patients will be renamed in the next guidelines, or should be renamed in the next guidelines, as patients not with mid-range, but with mildly reduced ejection fraction, to recognize the fact that they behave more like these patients. So that's where I think the debate has got to in 2020 about definitions and diagnosis of heart failure and the different phenotypes based around ejection fraction. Now, there are many more complexities to this, and the biggest one is should there be a single left ventricular ejection fraction cut point, or in fact, should it be age, sex, and race specific? We might be able to come back to that in the discussion. But to be honest with you, we can slice and dice all of these data whatever way we like. But ultimately, I believe this syndrome, these other patients with heart failure, will be described as having a condition that will be defined by the first positive clinical trial in these patients. Because, and this is the real reason that I walked you through the story of heart failure with reduced ejection fraction. That was really a syndrome that was decided by an arbitrary left ventricular ejection fraction cut point and the results of the SOLVE treatment trial. And once that trial showed a mortality benefit of a treatment, we started to call patients with an ejection fraction below 40% patients with HFrEF, and that name stuck. And I think we will do exactly the same when eventually we get a positive trial in the other remaining patients with heart failure who have an ejection fraction above 40%. So to finish with, I'm going to look ahead, and I'm going to look at the ongoing morbidity mortality trials. And the two that I think we're going to hear about first, in fact, the two I know we will hear about first, are two trials with SGLT2 inhibitors. You heard a lot about those in the last talk, and the definite benefit of at least dapagliflozin in patients with heart failure and reduced ejection fraction. We're conducting a sister trial called DELIVER with DAPA in patients with an ejection fraction above 40%, and again, patients with and without type 2 diabetes. And our colleagues, colleagues of ours, friends of ours, are running the Emperor Preserved trial with empagliflozin, another SGLT2 inhibitor. Their trial is fully recruited. Ours got a little bit held up by the COVID-19 pandemic, but we should hear about the results of these two trials in the next 18 months. So very interesting conceptually, because of course these drugs are targeting very different things than we've targeted with all the other drugs that we've used before. Because a lot of people believe TOPCAT probably would have been a positive trial if it hadn't been for the problems in Russia and Georgia and the enrollment of patients who didn't have heart failure and the very poor adherence to treatment in those countries. There are more studies being conducted with spironolactone. These studies being conducted in Europe, and there is one being funded by the National Institutes of Health in the US that is being run in Sweden and the United States. They're not very large studies, so it may be that they will have to be combined in order to give a clear result. But I think much more exciting is the very recent announcement that we will be doing a new trial with a different type of mineralocorticoid receptor antagonist, a so-called non-steroidal mineralocorticoid receptor antagonist, one that we hope, finerenone, we hope will have fewer renal side effects, less likely to cause hyperkalemia. And this trial is called Fine Arts HF. This is the name. You can see here the design. I'm not going to read through that in detail, but it is a placebo-controlled trial with another MRA that will give us a chance to hopefully convincingly demonstrate that this approach is of benefit in these patients. You'll note that the color scheme here fits with both the Irish flag, which is why I love it, and the Indian flag. So we're going to fill in a gap here. Again, we're going to have another trial in our spectrum of trials covering both HFrEF and HFpEF. And again, please note that all of these new trials, Emperor Preserve, DELIVER, and Fine Arts, are now all going back to using an ejection fraction cut point of 40%, will include both heart failure with mid-range or mildly reduced ejection fraction and the remainder of these patients. And the reason I said this was so exciting was because just a few days ago, July the 9th, we got this press release from Bayer talking about a study in patients with diabetes and chronic kidney disease, Fidelio, where compared to placebo, finerenone, this non-steroidal mineralocorticoid receptor antagonist, has reduced the primary endpoint, which was progression of chronic kidney disease and renal death. But if you read this press release very carefully, you'll see at the bottom that finerenone also reduced the risk of a composite cardiovascular outcome, including CV death, MI, stroke, and heart failure. So we're really looking forward to seeing the results of this. This is fantastic proof of concept that this drug works and can be used safely. Remember, these were diabetes patients with chronic kidney disease, and this gives us, I think, great hope that this treatment could be effective in HFpEF. But we have to remember that, you know, maybe we're making a mistake. Maybe we're making a mistake of still trying to use the drugs that work in HFrEF and HFpEF. HFpEF may have completely different pathophysiology, or at least some of the patients may have. Could be inflammation, for example, rather than involving neurohumoral pathways. So we have to keep an open mind, and we have to think about whether we need to think in a completely different way therapeutically. I suppose we've done that to some extent with SGLT2 inhibitors, but we may need to do more of it. And of course, there are other approaches. My interest is in pharmacology, but there are interventional approaches, including this device that essentially depressurizes the left atrium into the right atrium. This is, you make a hole in the left atrium, put in this little valve that allows the left atrium to decompress into the right side of the heart. So to summarize and conclude, I have to say that perhaps our use of the term HFpEF was a well-intentioned mistake, because I think it's been misunderstood and misused. We always meant it to mean that some of the patients had left ventricular systolic dysfunction, did not have a normal ejection fraction. I think we're now getting the impression that some of these people do benefit from drugs that work in HFrEF. We maybe need to think about better ways, in fact, to measure systolic function. Maybe we should have focused always on biomarkers and not measurements of echocardiographic measurements. I think there's still a very big question about who are the patients at the upper end of the ejection fraction range, those who have what is truly a normal ejection fraction. Are we missing other diseases hidden in this group of patients, for example, TTR amyloidosis? And of course, as I've just mentioned, we need to think about whether the pathophysiology, particularly in these patients, might be completely different. So I'll finish with this statement to remind us why what we talked about is so important, because Joe Hill, many of you will know, is the editor of Circulation, and you can see here that he, I believe, quite rightly said that heart failure with preserved ejection fraction is now the single greatest unmet need in cardiology, because we've so far not had a significant therapeutic breakthrough. Thank you very much.
Thank you so much, Dr. John McMurray. I would really like now Dr. Parag Shah sir to lead and the Q&A session. Do we have Parag sir here?
Yeah. Thank you, sir, for your nice celebration. I have some 2 or 3 quick questions because we are running short of time.
I think, Dr. Parag, you're audible, though somebody else is there.
I'm waiting for the question.
Dr. Vora, do you want to lead? Yeah, we can barely hear you, Dr. Shah. So maybe Dr. Vora wants to start with a question, or Dr. Chawla.
Dr. Parag, are you ready with the question?
I don't have questions on the
audience. Okay, so Dr. McMurray, let me ask you this. Though you ended in a little depressing note that we know little in terms of managing heart failure with preserved ejection fraction, but for the clinician at the moment, it seems that control of prevention is probably the right way to go. Control of hypertension, control of diabetes, control of atrial fibrillation, all these things are much more important and relevant. In this regard, do you have any specific antihypertensive that should be considered in patients who have heart failure with preserved ejection fraction to prevent their morbidity, or is it the guideline directed therapy for hypertension, diabetes, and atrial fibrillation?
Well, I think we know that there are two treatments that are, so all antihypertensive treatment reduce the risk of developing heart failure, but there are two treatments that seem to be relatively more effective in reducing the development of heart failure in patients with hypertension. Of course, those two treatments are a thiazide diuretic, in particular chlorothalidone, and a renin-angiotensin system blocker, and there are two very large meta-analyses that both support that view. So I think those are your two options. Most people with hypertension need two drugs, and therefore undoubtedly I think those would be the two agents that you would use. I think if you had a patient with resistant hypertension, then I think today obviously we believe that spironolactone would be the next agent to add. And again, I personally have a very low threshold for adding spironolactone, certainly in patients who've displayed any evidence of fluid retention, and I think maybe are developing HFpEF, because I think probably the TopCat trial was positive, but we can't prove that because of all the problems I mentioned with its conduct. But you know, I find it very easy to have an excuse to use spironolactone in these patients, so both to prevent and to treat.
Professor McMurray, you very rightly said that preserved ejection fraction heart failure was either intentionally or non-intentionally not classified early days when we talked of only reduced ejection fraction heart failure. If I ask you today, when we are talking about mid-range heart failure, you think in terms of pathophysiology and treatment, will it go towards reduced ejection heart failure, or it will be in terms of pathophysiology and drugs will be addressed to for mid-range like preserved ejection fraction? Which way it will finally fall?
So, I mean, as you probably know, we've written and others have written, and I think the guideline committees will probably follow. I don't know, obviously, but I think we're going to rename heart failure with mid-range, as I said, heart failure with mildly reduced. And that is to reflect the belief that many of those patients do have systolic dysfunction and do benefit from the drugs that work in heart failure with reduced ejection fraction. The treatment of effect size may not be quite as large, but there does seem to be some reduction. So that's what I think. Now, will the guidelines say that? That's very difficult if you think about it. We probably never recommended a treatment based on a retrospective subgroup analysis. So that's a big challenge in terms of how we use evidence to take the huge step of putting something in a guideline. So I don't know if the guidelines can do that, but I have to admit that as somebody normally extremely skeptical of subgroup analyses, it's hard to ignore a finding that you see with 3 separate drugs in 3 different trials. Such a consistent finding. And if you remember, the very bottom of my list of criteria for validation of subgroup findings was biological plausibility. Well, it is biologically plausible that if you've got an ejection fraction of 50%, it's not normal. You probably do have systolic dysfunction, and therefore it's maybe quite biologically plausible that you would benefit from a RAS blocker and an MRA. So I think it's probably true, but there's a big step between thinking it's probably true and making it a recommended treatment in a guideline. So it's going to be a very interesting next few months as the guideline committees deliberate on all of this new information.
So mid-range could be because their ejection fraction still could be something like 45 or 50, but they actually fall in the category of reduced ejection fraction because of systolic heart failure component, and you feel that drugs which are now standard care for reduced ejection fraction could be helpful even in mid-range, because preserved heart failure possibly could be absolutely totally different entity.
The only thing I would maybe disagree a little bit with you about is that I probably would no longer call those people who have an ejection fraction above 55 or above 60%, I would not call those preserved anymore. I would call those normal. Preserved was the word that we invented to use to describe a mix of people with not massively reduced, but not normal. And it was never intended to mean people with a completely normal ejection fraction. So if I was able to change the terminology, I would keep that mid-range, mildly reduced group, but I would also think about having a new name for the remainder who have essentially a normal ejection fraction. I would probably call it what we used to call it back in the 1990s, heart failure with normal ejection fraction.
Professor McMurray, do you, in your clinical practice, do you differentiate in evaluation of the patients with heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction as far as clinical evaluation and the lab evaluation goes?
Do I, sorry about that, do I differentiate between what?
Do you differentiate between the half-PEF and half-REF patients in terms of evaluation in your clinical practice?
I'm not altogether sure what you mean by that, but let me try and answer it. So if you mean by further investigations, then yes, to some extent. So for example, you might be more likely to look for coronary artery disease in patients with HFrEF because you're more likely to find it. And there may be an indication in some HFrEF patients for surgical revascularization for prognostic reasons. So that might be one example of what you would do a little bit differently. Whereas in patients with HFpEF, so for example, people with completely normal ejection fractions, if they've got a very hypertrophied looking, very thickened left ventricle, then you might go on to look for cardiac amyloidosis. So you do think a little bit differently once you put people into the two broad REF-PEF categories. But many of the other things are exactly the same. You know, natriuretic peptides, we would always screen for iron deficiency and treat patients with intravenous iron, irrespective of their heart failure phenotype. If they've got atrial fibrillation, we'll treat them in the same way. If they've got diabetes, we'll treat them in the same way. So a lot of the treatments are similar, and a lot of the investigations are similar, but there are differences. I hope I've answered your question.
So all in all, you are saying that since even though the management is similar in terms of assessment, evaluation, and the treatment, the prognosis and the response to the treatment differs.
So the prognosis is obviously very different. I highlighted that, particularly mortality. Heart failure hospitalization, not so different, as I showed you. And the effective treatment, well, it depends. So if we talk about, again, we go back to that ejection fraction segment, maybe it's 40 to 55, maybe it's 40 to 60, I don't know, it might be different men and women. But those people, probably they are getting benefit from RAS, find an excuse to use those drugs. Usually when we first see those patients, they're on a RAS blocker anyway. And if they've got fluid, I'm very easy to use on the lap. If they've got atrial fibrillation, if they're in that lower end of the HFpEF ejection fraction range. So it's maybe a little bit different in people with a very nurses and so on. I might prepare and then to use a rate limiting calcium channel blocker to control the ventricular rate. So there are little differences, and it does depend a lot on ejection fraction. But yes, many of the treatments do overlap. And of course, fundamentally important in all types of heart failure are diuretics to control the volume overload that gives them their characteristic symptoms.
Thank you.
Thank you, Dr. McMurray. It was really enjoyable to interact with you, and the heart failure sessions always overshoot in terms of time because there is so much to know, learn, and new data keeps on coming. Thank you very much for being with us.
Thank you, Professor McMurray. We really enjoyed your session. Thank you.
Thank you, Dr.
Thank you so much.
Bye-bye.
Thank you.
Over to you, Heti, now. I think the evening is getting better and better with all the speakers. With this, we will like to move to our next symposium, that is the spectrum of NAFLD and NASH, and how and what our primary care physicians, diabetologists, and cardiologists should know. I would like to invite Dr. Manish Bhatnagar, who is a senior gastroenterologist and also the HOD of Icon Hospital, Ahmedabad, and Dr. Altama Sheikh, who is senior consultant endocrinologist at the Sefi hospitals.
Thank you so much, Dr. Manish.
Thank you. Thank you, Altamash. How are you?
I'm good. How are you doing? Over to you, sir. Yeah.
Yeah. So we are basically going to be discussing the spectrum of NAFLD and NASH and what the primary care clinician, diabetologist, and cardiologist should know at this point in time. We have a very, very distinguished speaker to be talking to us. And without further ado, I think we should get started on this. We all know that today NAFLD and NASH is not in the ambit only of the gastroenterologist. We will be having this discussion with Dr. Amalia very soon, but I'm sure this is a particular session which will be of great interest to all physicians, clinicians, diabetologists, and cardiologists. And obviously, me as a hepatologist, I'm going to be very, very keenly clued into what the cardiologists and the diabetologists have to say about this. So with that, can I have this slide for Dr. Amalia? Yeah. I'd like to introduce Dr. Amalia Gestaldelli, who's the Director of Research at the Cardiometabolic Risk Laboratory in the University of Pisa. She is the chair of the NAFLD study group of the EASL since 2018 and is part of multiple study groups and has been the past director of the European chapter of the ECACN. And she's a clinical adjunct professor at the University of Texas Health Sciences, San Antonio. She has a vast and rich clinical experience of leading national and international scientific projects. So can we have Dr. Amalia for this very, very interesting session? Dr. Amalia, please.
Thank you, Dr. Manish. And I'd like to thank Dr. Rucha Mehta, Dr. Samir Dani for inviting me today. Let me just share my screen. Okay. Do you see it?
Yes, we do.
Okay, perfect. So today, the title of my talk is From NASH to Diabetes and From Diabetes to NASH. And the idea is to try to show you what are the links between these two metabolic diseases, that they are so close to each other, especially because the liver is one of the forgotten organ, but you know, it's very important for both diabetes and of course for NAFLD and NASH. Just go ahead. These are my conflict of interest disclosure. So we all know that the prevalence and incidence of diabetes is growing fast, especially in your country, Southeast Asia. You see here that are expected a 74% increase. And this is important not only because of diabetes, and we know the harmful of diabetes as a pathology and also as a cost for the health system, but also because it is related to several other comorbidities and including NAFLD. NAFLD is also very prevalent. The latest studies are showing that in the general population is approximately 25% of the population, they have fatty liver. And fatty liver is defined as a fat infiltration greater than 5% with or without mild inflammation or fibrosis. So having fatty liver is just a mild accumulation of a liver fat that could be staying like this, or it can progress. And of course, if the subjects are obese or they have type 2 diabetes, actually the prevalence is increasing and is expected in those with diabetes to grow up to 80% of the patients. And the progression of NAFLD is occurring usually in 40 to 70% of the subjects, depending on comorbidities. For example, in diabetes, diabetes is a risk factor to progress from fatty liver to NASH. NASH is defined as a contemporary presence of steatosis, necroinflammation, and so it's like inflammation and ballooning, and with or without fibrosis. So fibrosis is not right now by the guidelines a criteria for NASH, but of course fibrosis is very important because the stage of 5-4 is cirrhosis, and the NASH can progress to cirrhosis. They can have a high risk of hepatocellular carcinoma that before it was expected to occur only in those with cirrhosis, but now we know that also people with NASH, they can go to have hepatocellular carcinoma even if they do not progress to cirrhosis, so even if they have relatively mild or less severe fibrosis. And of course, it's a major risk factor for liver transplantation. So the NAFLD is one of the major risk factors for diabetes. As we see here, this is a meta-analysis that was published a couple of years ago on diabetes care, where NAFLD increases the risk of insulin diabetes. And these are 16 studies put it together. And of course, you see here NAFLD, both the one is diagnosed by ultrasound or also liver fibrosis score. Of course, having fibrosis, it's increasing the risk of developing the diabetes. So now, in the natural history of diabetes, we know that two are the main components to develop hyperglycemia and type 2 diabetes. That is insulin resistance and insulin secretion. And these two are important for NAFLD as well. So let's start with the insulin resistance. So we know that insulin resistance, insulin is acting at the level of several organs, not only at the level of the muscle to promote glucose disposal, especially after a meal, but also the level of the liver, where there is liver glucose production, especially during fasting, and glycogen accumulation in postprandial state, and insulin is acting to stop and to decrease glucose production. But if we have hepatic insulin resistance, glucose production is high, and so it's contributing to hyperglycemia. So these are studies that we have published a few years ago, where we look at non-diabetic and type 2 diabetic, and this is the hepatic insulin resistance index that is calculated, measuring glucose production in vivo using tracers multiplied by insulin. And you see here that this hepatic insulin resistance index, it's increased almost double in NAFLD without diabetes, and this is similar to diabetic without NAFLD. But if you have diabetes and NAFLD, the hepatic insulin resistance index is even higher. And if we look at peripheral insulin sensitivity, we see that there is a decrease in muscle insulin sensitivity. Of course, we all know that type 2 diabetics, they have a very high insulin resistance, so independent of the presence of obese. But in non-diabetics, you see that having NAFLD independently if you are obese or non-obese is decreasing insulin sensitivity. Of course, if you are obese, NAFLD, you are more resistant than the lean NAFLD. Another important organ is the fat, because the adipose tissue, because we know it's releasing anti-inflammatory adipokines or inflammatory adipokines. So in presence of adipose tissue insulin resistance, we have a decrease in adiponectin and an increase in leptin secretion. The adipose tissue, it's very sensitive to insulin because insulin is suppressing lipolysis and is promoting triglyceride accumulation accumulation. So in the presence of insulin resistance in liver and muscle, we also find insulin resistance in the adipose tissue. And this is also associated with the activation of pro-inflammatory pathways and release of pro-inflammatory cytokines. So it's also known that when we have adipose tissue insulin lipolysis, insulin resistant, we have increased lipolysis. This excess of FFA, they go to the liver where they do accumulate as triglycerides, so promoting fatty liver. And it's known from a previous study, actually this is a study by Donnelly published in the Elizabeth Group of Elizabeth Parks in the JCI, that in the hepatic triglycerides, the sources are only 15% comes from the diet, while 59% they come from the adipose tissue, free fatty acids, and 26% comes as de novo lipogenesis. And we also have shown, this is a study I've done when me and Ken Cusi were working together in San Antonio, when we were looking at FFA suppression during the OGTT. You see here that subjects with NASH, they have higher fasting FFA, and also their suppression is impaired. At least, you know, their level of FFA was always higher compared to the controls. So also it's possible to calculate the adipose tissue insulin resistance. So with Ralph DeFronto that will speak later today, we look at a new index, the AdipoER. It's a sort of OMA-ER of the adipose tissue, and is measured by, instead of glucose times insulin, you multiply FFA times insulin. So insulin sensitive subjects, they are staying like in this curve. So as insulin concentration increases, you have a decrease in FFA concentration, while in insulin resistance or diabetic subject, you have, for the same level of insulin, you have much higher FFA concentration, so much less suppression. The insulin is acting less on the adipose tissue that is resistant. And you see here the adipose tissue IR in the NGT lean, and is like half of those in NGT obese. Of course, it's much higher in NGT, and is even higher in type 2 diabetics. And these are different cutoff for fasting hyperglycemia. Of course, these are the more, those with much higher fasting hyperglycemia. Ken has also published this nice study in hepatology, where he showed that during the clamp, the suppression of FFA was much less as subject had higher intrahepatic triglycerides. So there was like a sort of linear decrease as the intrahepatic triglyceride was increasing. But what was also very interesting is also that the white bars that indicates the non subject, they will have impairment in FFA suppression. So you just need a little bit of FFA accumulation, triglyceride accumulation in the liver to have impaired impaired adipocyte insulin resistance. And this is the study where we look in the NASH compared to the controls, and we actually were able to show that the NASH, they have like 6 times higher AdipoER compared to the normal controls. Also, the quality of fatty acids is important. We know that saturated fatty acids are more harmful, and this is because saturated fatty acids, they decrease PPAR alpha expression. So actually, they do not promote the fatty acid oxidation. So in presence of high FFA, you know, if FFA are oxidized by the liver, then they are not accumulated as triglycerides. But if somehow the PPAR alpha and the oxidative pathway is inhibited, then we have an accumulation. And moreover, they activate the JNK P38 kinase, and so they promote lipotoxicity, hepatic insulin resistance, apoptosis, necrosis, and inflammation. And this is not true on unsaturated fatty acids. So these are studies in mice where they showed also that the liver weight was much higher for saturated fatty acid compared to polyunsaturated fatty acid. You see also the histology was very different for saturated versus unsaturated fatty acids. But also in humans, this is true. And this is a study that I've done in collaboration with Dr. Hanneleiki Järvinen a couple of years ago. And this is 3 groups of subjects. They had overfeeding 1 100,000 calories, either with saturated fat, unsaturated fat, or simple sugars. You see here the composition that between saturated changes in free fatty acid composition towards the saturated fatty acids for during the saturated in the group that have a more saturated fat intake, and also in the one that had a high carb, because carb are also substrate that will promote de novo lipogenesis. And indeed, when we look at de novo lipogenesis that is hepatic, we see that those that have high carb intake, they had a much higher lipogenesis. And this is true because the other one, since there was already a high intake of fatty acids, actually de novo lipogenesis was less stimulated. But at the same time, those with that had a higher intake of saturated fatty acid, for the same extra calories, they have a much higher, you see here the delta, much higher change in hepatic triglycerides. So was more than 2% change in the saturated, was less than 1% in unsaturated, and in the middle we see the one with the carb intake, high calorie, high carb. So it's very important, not only the extra calories, but also how these extra calories are the composition of the extra calories. So saturated fatty acids, and especially the ones that are contained in triacylglycerols, are also associated with insulin-resistant inflammation, hepatic fat. These are unpublished data that we had in our Horizon 2020 study that was just concluded, the Apple study. And you see here that in red, they are desaturated fatty acids, and in blue on this part, the unsaturated fatty acid. You can note here that the saturated fatty acids inside, the free fatty acid or the triglycerides, they are all positively associated with the hepatic fat, the novel lipogenesis index, the saturation index, MCP1, that is a marker of inflammation, adipose tissue insulin resistant, hepatic insulin resistant, OMIR. For the same positive correlation, we found the same negative correlation for the triglyceride that contain 3 double bonds, so they are unsaturated. And another interesting finding from this study is that when we look what happened in NAFLD that had a BMI below 30 or BMI above 30, we saw that those non-obese NAFLD had more saturated triglycerides than the obese NAFLD. So actually, that being lean and non-obese NAFLD and having NAFLD is really associated with a harmful phenotype. And indeed, we know now that lean NAFLD has also have a higher risk of severe liver disease, but also of they also, since they have a decreased capacity of storing fat in the subcutaneous adipose tissue, and they are a sort of lipodystrophic phenotype that is not lipodystrophic, but very similar, they do have increased de novo lipogenesis. They do usually have reduced mitochondrial function, and they also are high risk also for cardiovascular disease, much more than the NAFLD with a BMI greater than 30. And as I said, the adipose tissue is really important. And you see here that also the fibrosis in subjects with the higher fibrosis in the liver are those that have a higher adipose tissue insulin resistance. That means that an increase of FFA and cytokines due to adipose tissue insulin resistance to the liver is probably associated with the greater damage of the liver itself. So now, if we go to look at the adipose tissue, we see here that in the presence of insulin resistance, we have increased lipolysis, increased FFA, increased lipotoxicity, and this is associated with insulin resistance at the levels and pro-inflammatory pathway. And the different types of NAFLD, the sort of lipodystrophic that is mainly leptin deficient, or the very obese that has NAFLD and high visceral fat and is more leptin resistance, are both two interesting two interesting example of NAFLD and phenotype. And I think now there are a lot of studies that are trying to focus to understand these two phenotypes in humans. And There is also an impact of the visceral fat, not only of the liver fat. If we look at the liver fat, this is again the study by Ken, we saw that even subjects without NAFLD, they have an impaired suppression of glucose production during the clamp, that is liver insulin resistance, and they have already a decrease in skeletal muscle insulin resistance. And these were, the great majority of these were non-diabetic. And all these relationships were independent of glucose concentration and hyperglycemia, because they all had the same fasting glycemia. And we instead look at how was the impact of visceral fat. So we divided in 4 groups: low hepatic triglyceride with low visceral fat or high visceral fat, or high hepatic triglyceride, low visceral fat and high liver hepatic fat, visceral fat. And you saw that in the liver, hepatic insulin resistance was the lowest when you have both low hepatic TG and low visceral fat. But when you have both high TG and visceral fat, you have the highest insulin resistance. And the same, the inverse for insulin sensitivity in the muscle, highest insulin sensitivity, so lowest insulin resistance in the group low, and the highest insulin resistance in the group high TG, hepatic TG, high visceral fat. Yes, I'm finishing. So insulin secretion, we look using the OGs. I like to show you these slides because these are the OGTT and the in different groups: normal glucose tolerant, insulin sensitive, insulin resistant, chronic hepatitis C, and NAFLD. You see that having liver disease, and these are all non-diabetics, is associated with high glucose, but only NAFLD, they have high insulin. And when we look at the subject with different fibrosis, you saw that those with the low fibrosis had a lower glucose than those with high fibrosis independently of obesity. And this was not true when we look at steatosis versus obesity, where the same subject, they were very similar despite the group of steatosis. Again, when we look at chronic hepatitis C and NAFLD, insulin sensitivity was reduced only in NAFLD and in NGT-IR, not in chronic hepatitis C, but chronic hepatitis C have a decrease in insulin response. Instead of the NAFLD, non-diabetic, the insulin response is the same, but the fibrosis instead is associated with a reduced insulin sensitivity in NAFLD, but not a reduced insulin response. And also you see here the same as when we group subject as NGT, IGT, and type 2 diabetics, those with NASH and high fibrosis were the one with the lowest insulin sensitivity. So just to look at the natural history of diabetes, you probably have seen these slides from Ralph several times. When you start decreasing insulin sensitivity, you have an increased compensatory insulin secretion. But when you have also a decrease in this insulin response, you start having hyperglycemia. And but we are looking at insulin. Actually, we have to think what happened before. It's secreted by the pancreas, and the great majority is degraded by the liver. So only one part, 40%, is coming into the periphery. So insulin clearance that is developed of the liver is very important. So these are the insulin concentration in NGT, IGT, and type 2 diabetics for NAFL, NASH, and NASH fibrosis 2-4. You see NASH fibrosis 2-4, they have a much higher insulin. So what's going on here? Is it a problem with the insulin secretion? So when we look at the hepatic insulin secretion, is indeed higher, but is not as high as the insulin. So it's probably a difference, a reduction in insulin clearance. And indeed, we confirmed data we published, back in 10 years ago, when we found that hepatic insulin clearance is reduced in percent parallel to increasing hepatic fat to allow more insulin in the periphery, and it's more reduced in those with NASH fibrosis 2-4 independently of their glucose tolerance status. So here we need to put together also the insulin clearance in this picture that I showed you before. So the crosstalk between pancreas and the liver is very important for both NAFLD and diabetes, also to understand what's going on and how is the best treatment for this and the risk for type 2 diabetes. And if we look at the disposition index, that is things to look at the risk to develop type 2 diabetes. This is a study published with Ralph back in 2004, where we demonstrated that 80% of beta cell function is already lost in IGT. Here, when we look at the same type of curves in NGT, IGT, and type 2 diabetics with different severity of NASH, you see that NASH with fibrosis 2-4, they already, even if they are NGT, already lost like half of their capacity and their disposition index. And these are data that were just presented at the ADA, were writing the manuscript. And same here for chronic hepatitis C. Also, chronic hepatitis C has already a reduction in disposition index. So it's very important also that you follow up your patients after resolving hepatitis C, because they could have like already a defect in beta cell function that for this reason they could be at risk. So I like to conclude with this picture that is from a paper we just published, and is the risk of diabetes in liver disease. So you see what we found is if we subject stay NGT, they are NAFL, they probably are even upper secretory, and then their insulin response is more than enough. So they are upper the curve compared to also to the NGT insulin sensitive. And of course, you know, even if they stay NASH, but they are NGT, they are on this curve. But as they progress to NAFL, and also if they have ACV, so hepatitis C, before they were exposed, then they can progress much faster to type 2 diabetes. So subject with NAFLD have increased hepatic and peripheral insulin resistance, increased insulin resistance during fasting and post-prandial, but decreased insulin clearance, decreased disposition index, and for this reason are increased risk of type 2 diabetes. And with this slide and with the presentation of my lab and thanks to our European grants, I'd like to conclude my talk. Thank you very much for your attention.
Well, thank you, Dr. Amalia. That was a very well and very nicely spoken in the presentation. I just wanted to confirm, shall we take questions right now or after Dr. Kusi does his presentation? Dr. Bhatnagar?
I think let's take it once both the presentations are done. I think we take question answers at the end of Dr. Kusi's presentation.
Okay, sure. So we have here Dr. Kenneth Kusi, who's the chief of endocrinology from Florida. And I think in a private chat, he said, just say only this and nothing else. So the screen is all yours, Dr. Kusi. Dr. Kenneth Kusi, please.
Yes, sorry, I didn't unmute. Can you hear me now? It's good?
Yes, we can hear you. Yes.
Okay, well, thank you very much. Amalia, great presentation. I want to thank the organizers, Dr. Samir Dani and Dr. Rucha Mehta, particularly. I know the effort that's behind the Global Cardiometabolic Conclave. I know it takes a lot of work to put all this together, and I'm very honored to be part of this presentation. So I'm going to now, hopefully, there we go, get my slides. Oops. There we go. Let's start from the beginning. Okay. So with that, these are my disclosures. Just want to share where I am. So if we can ever travel again and come to Orlando to visit Mickey Mouse, you know, Gainesville is not that far. Just come. I promise that on the first visit, I've never done a liver biopsy on any of my guests. That's our hospital, different hospitals that we have, and that's our research unit. If any youngster wants to do research, you're welcome to send me an email, and we'll get you work to work. So we're going to talk in these next 25 minutes about the links between fatty liver and cardiovascular disease, highly controversial topic. And we're going to talk about management of the liver, and you'll see how this relates to the management of the other complications that we see in type 2 diabetes. And I know in India, diabetes and fatty liver are two big problems. So this audience is very well educated on the role of lipotoxicity. I would call NAFLD more lipotoxic liver disease. That's my favorite name, but I know it will never happen. But what we're going to focus today, we're not going to talk about diagnosis or other things. We're going to focus on the interaction between the heart and the liver, and what can we do about it, and what is the future work that we need to do in the field. So this is one of those horrible slides that you can't read anything. But my only point here is to say these are recent review that we did with 2 of our fellows, and I could put 2 or 3 more slides like this. Again, there are many studies who just put those that had more than 100 patients, different diagnostic modalities, biopsies, ultrasounds, liver enzymes, again, different endpoints, either intimate meal thickness or cardiovascular events. But here's what I would like you to pay attention. In all of them, there's an increased risk, but typically the people with fatty liver have more traditional risk factors or are more obese. So when you try to adjust now about 30 to 40%, that relationship is not there anymore. And again, most are retrospective, some are cross-sectional, but again, it's not completely clear that this association is as robust as we would like to. So if you look at patients with type 2 diabetes, there are fewer studies that have focused on just people with type 2 diabetes. But here again, you see the same thing. Lots of studies, and there are many more. I hope I haven't offended anyone who I've not included. But again, if you look at the again different outcomes, not all the studies have shown that there is this close relationship. Although you'll see soon that there are many good reasons for having increased cardiovascular disease. But the issue is separating all the metabolic risk factors and whether fatty liver or NASH by itself is associated with it. And that's where the difficulty stands. And again, I just highlighted 4 reviews on different aspects of this from 2020. A very nice review by Amalia and Dr. Bedonia and Dr. Foshi about all these pitfalls and limitations of these studies. I highly recommend this read in Current Opinions in Lipidology. So again, there are many, many studies on this. I didn't want to take too much of your time on that. But the key thing is what could be the mechanism. So these are all the factors that could be playing a role in this problem. So if you look at this, you'll see very clearly that there are many factors, as Amalia mentioned, insulin clearance and insulin resistance that lead to hyperinsulinemia. Long debate whether that's atherogenic. High glucose production. You heard from Amalia that you have a twofold increase, at least in the progression from pre-diabetes to diabetes. Subclinical inflammation, lipids. I mean, we have shown, many people have shown that there's atherogenic dyslipidemia is associated with more cardiovascular disease. One minor contribution that we made is if you take non-obese individuals with fatty liver disease, their LDL particle size is smaller being greater cardiovascular risk. So there's something intrinsic about the metabolism of lipoproteins in fatty liver that increases their cardiovascular risk. So keep that in mind, of course, also in obesity. But where I wanted to focus my attention was more on the heart. And in the heart, what we see is that there are a number of mechanisms that could be at play. In the prior session, there was a very nice talk about heart failure. And again, it's very common in diabetes, type 2 diabetes, and in fatty liver to have maybe between 10 to 20% that have what we call a heart failure with preserved ejection fraction. So this is something important for you to recognize, as the best treatment for NASH at the present time is pioglitazone, and you need to select patients without heart failure. So let's talk a little bit about that. There's been a classic study from the group in Dallas that showed that if you compare to lean individuals, people with obese, prediabetes, and type 2 diabetes have increasing amounts of fat in the heart, typically measured, as you can see there in this MR image. And we think that this affects the metabolism of the heart and its ability to contract normally. Then in 2008, a very nice study, European study from the Netherlands showed that myocardial steatosis is an independent risk factor for diastolic dysfunction. And to just move all the way to present times, there have been now many studies that have looked at this. In a nutshell, 12 studies and 280,000 subjects have been able to show a close association between fatty liver and diastolic dysfunction. So also recommend that read. And again, diving a little bit deeper into the mechanisms, you can see that this nice study also from that group shows that how this affects myocardial metabolism. So what this group did, they divided subjects between those with diabetes and low heart triglyceride content or high triglyceride content, pretty well matched, except the BMI a little bit heavier in those with more triglycerides. And here you see this is glucose uptake, insulin, say cardiac muscle insulin sensitivity. You see that as you begin increasing your amount of fat in the liver, that sensitivity or normal glucose metabolism decreases in individuals with diabetes. This is the amount of energy that the heart cells have also goes down. And long story short, they demonstrate very elegantly that having more fat in the heart is bad. This is also something showed by Lydia Sepaniak in the Dallas from the Dallas group at the time. Just a word, there's also been work on pericardial and epicardial fat as it links to myocardial function and insulin resistance. Amalia, I think, has done good work also in this area. Wrote a very beautiful review a few years ago. Again, just in a nutshell, as hepatic triglyceride content goes up, this is closely associated. These are normal individuals. These are individuals with fatty liver, and you can see that there's an increase in myocardial content and also an increase in epicardial fat. Again, we don't understand the pathophysiology, but this is an area of active research. So with that, what I would just want to say about the first half is this is important because it's associated with increased mortality. So if you have just steatosis, it's not benign as people hear. You might hear over there, having just fat without NASH is associated with increased mortality. Again, these are not great studies, mostly retrospective, but the liver mortality will not be significantly increased. Once you develop NASH with fibrosis, now you add the liver-specific disease and a significantly, almost a threefold increase in mortality. So this is why tackling the liver and the extrahepatic complications is truly important in the management of our patients. So let's talk in the last 10 minutes about the management, okay? We're gonna divide it between the liver-specific approach and what are we gonna do about cardiovascular disease. So lifestyle, I put this slide to remind myself, lifestyle is very important, but we're not gonna have time to talk about it. So if you, I know some diets in India might have a lot of carbohydrates or coconut oil, delicious, but with moderation. So very important to take lifestyle into account. So for a practical perspective, I mean, you can divide things in the treatments for the liver. And I personally have a strong bias for pioglitazone, very inexpensive medication worldwide. And then second line therapies, and then lifestyle intervention, and why not bariatric surgery. And again, control of cardiovascular risk factors, glucose control. I'm sure you're going to hear more about this during the meeting, blood pressure control, and statins. The real reason why I show this is because people take patients with elevated liver enzymes off statins. And I think that at least if they're not about 3 or even 4-fold, you can start low dose statin. We have a paper that we showed over 3 years in a pioglitazone trial that you can give statins safely over a period of 3 years, as we did in 100 patients, and we did not have to discontinue it in any patient really during that period of time. So fairly safe. Okay, what are our treatments for NASH? The last guidelines from that I was proud to be part of looked at the 3 diabetes medications. Metformin, great drug for diabetes, doesn't do a whole lot for NASH. We'll talk about pioglitazone and GLP-1 receptor agonists. At this time, there was only 1 study. Now there's a second large study. And vitamin E from Pivens works in non-diabetics, but has not as potent effects in people with type 2 diabetes. And there's always some concern about prostate cancer and cardiovascular disease with vitamin E. So just be aware of that, but it's another option. So there are 5 studies with pioglitazone. We were able to do this first study with Dr. Belfort and Dr. Gastaldelli. We did the second study, a 3-year study. I'll show you a couple of slides. And recently, we published this study trying to add the effects of vitamin E to those of pioglitazone. But vitamin E had some benefit, I'll show you later. But adding it to pio didn't add anything. So I typically don't use it because it doesn't have an additive effect. And there's issues about prostate cancer with it. So if you gave somebody, so if you tell somebody, this is what I'm going to show you about lifestyle. So our nurse would see the patients and tell them, this is done in San Antonio, stop eating tacos and pizza and sodas, and your liver enzymes rapidly go down. And then if you give pioglitazone, your liver enzymes typically normalize within a few weeks and remain like that as long as you take the medication. Now, I don't show you what happened afterwards. I wanted to show you, but the editorial made me cut it off because we didn't have all the patients. But as you can imagine, liver enzymes go back up. This is the effect of diet, you know, some improvement. And again, when we added pioglitazone, it just gets better. This is the primary endpoint. So this is a pretty cumbersome endpoint. Just focus more on this one. You don't have NASH anymore. 58% of patients benefited compared to 21 on placebo. But when we took those who really had bad disease, this was like a 50% response versus placebo. So very impressive results. And same in that last study we did last year. Now, pioglitazone, how does it do all this? So pioglitazone reduces fat, and in the meantime, will improve insulin clearance, lowering insulin levels, as you know, reduces insulin resistance, lowers glucose, reduces inflammation and CRP levels, lowers triglycerides, increase HDL. And I'm not going to have a lot of time, but it does have effects on reducing fat in the heart. So these studies that I show you are proof of concept that these changes are important. The proactive was the first one, controversial because peripheral vascular disease muddied a little bit the waters, but there was a reduction in heart disease, myocardial infarction, and strokes. These were 2 intravascular ultrasound studies showing benefit. And the last one is the IRIS study in people without diabetes who had a stroke or a transient ischemic attack, and given pioglitazone for an average of 4 years, reduced cardiovascular disease. I'm going to show you just the last one of these because we don't have time, but remember that all of these things are going to be probably your most effective way of getting rid of heart problems, okay, in patients with NAFLD. One thing I always get asked, oh, but pioglitazone causes heart failure. So if you take people with pre-existing heart disease or even mild, heart failure with preserved ejection fraction, and they get edema, which happens in about 5 to maybe 8% of patients, more if you're on insulin, those individuals are going to get in trouble. So you got to be smart selecting your patients. Otherwise, it improves left ventricular ejection fraction. And these are studies that have not seen an increase in heart failure. This is the IRIS study we're talking about, in none of our studies. And again, so in all of the studies that have been done since then, there's no increase in heart failure. So you can just go and check it out. I told you I was going to show you one slide about the IRIS study. Here it goes. If medications work a lot better if you take them. So what they did, they looked at patients who took it at least 80% of the time. So if you do that, and I should have done some columns to make it nicer, but if you look at the reduction in stroke and MI by 43%, stroke alone, acute coronary syndromes, and new onset diabetes. So one of the mechanisms of cardiovascular disease in NAFLD is that you get diabetes. So you can reduce that by 80%. Even if you include those who didn't take the medication, the effects get diluted, but they're still significant. So the good, we talked about that. What about the bad or the things we want to avoid? So there are things we want to avoid and keep in mind. Those things are edema. So avoid it if you're on high dose insulin or amlodipine that causes, edema in about 30% of patients, particularly at 10 milligrams. Look at their ankles. If they have edema, not a good patient to use. They might have, very likely, they have already some degree of heart failure. Bone loss, again, you would have to do a bone density at baseline if you're a postmenopausal woman. And this is something that you can manage. And again, it's the art of medicine. You'll decide whether having cirrhosis or cardiovascular disease is worse than treating osteoporosis. Bladder cancer, no time to review this, but if you ask me, I'll tell you more later. Most studies have been negative, 18 out of 23. And yes, there is weight gain. It's about 2 to 5%. And again, if you do a intervention with a dietitian, you can prevent that. Or if you combine it with agents that promote weight loss, like SGLT2 inhibitors or GLP-1 receptor agonists. The other approach is to use low-dose pioglitazone. So these are 4 studies that have compared 15 to 30 milligrams. If you look, the effect of 15 milligrams is quite significant on lowering your glucose by 30 to 40 milligrams, lowers your A1C markedly. Look, lipids go down, triglycerides, HDL goes up, and weight gain is typically between 1 to 2%. So that's an approach. You start 15 milligrams if you're not familiar or comfortable. And then in the next visit, you decide if you want to increase it to 30. I rarely use now 45 milligrams. So you're treating beyond glycemia, cardiovascular disease, and NASH. I avoid it if your BMI is very high, if you already have edema or on amlodipine, long-standing diabetes or long-standing history of heart disease. I would work out if the patient has heart failure, maybe NT-BNP or consult cardiology. And again, if you have osteoporosis, start 15 milligrams and then monitor. 90% of the patients usually can take it. Check for ankle swelling, educate the patients about ankle swelling, to stop it if you get it or to contact you. And if you're a lot of insulin, say 1 unit or more per kilo, that you're going to get in trouble because both are going to promote weight gain and edema. And ask for shortness of breath at the baseline and over the next visits. Okay, let's shift gears. What about GLP-1? Novo Nordisk announced on May 11 that the semaglutide trial, and again, I'm conflicted because I were part of this study. We were the ones that recruited the most patients in this trial. So 320 patients, 2/3 of them with diabetes, randomized to, these are daily doses of 0.1, 0.2, or 0.4. Resolution of NASH without worsening of fibrosis means the pathologist looks at the slide and says, you had NASH before, you don't have NASH now. And of course, these are blinded. And then the results were pretty impressive. Just focus on the higher dose, almost 60% responded compared to 17% on placebo. Very impressive results. And we'll see the full publication in a couple of months. This was not unexpected. Semaglutide lowers, promotes weight loss more than liraglutide. There are many studies looking at liver fat with liraglutide, open label, randomized trial, except this little small and short study. All have shown this is the LEAN trial, showed reduction in liver fat enzymes, weight enzymes and liver fat, and also histology improved. And then this is a fairly consistent finding. So keep that in mind that these agents work. The problem is cost. Sitagliptin instead doesn't work. So sitagliptin and any DPP-4 will not work because they don't change weight. So liver enzymes don't change, and it's no different than placebo. Another big class, SGLT2 inhibitors. I know you're very familiar with them. These are drugs with broad metabolic effects on the heart. And again, what they do, they will improve left ventricular hypertrophy, again, improve remodeling, cytokines, cardiac metabolism, apoptosis. So remember, this would be a good combination with pioglitazone. And again, we have all the kidney effects, but we still have no histological studies looking at that. However, we do have some studies on liver fat. Just focus on the control studies. They all go in the same direction. There are 3 studies with dapagliflozin. We did a study with canagliflozin. There's a study by Can and Roden from Germany, and empagliflozin, pretty consistent results. This is the difference against placebo. Liver enzymes are unchanged because they were normal at baseline, but they would probably go down if you have elevated liver enzymes. and placebo-subtracted differences are between 10 to 22%. So a good approach, we don't know if it improves NASH or not. Last 3 or 4 slides, what about the future? So there are many agents. I don't have time to go in detail. FGF21 agonists, FXRs. Just last week, the FDA put on hold the approval for obeticholic acid. However, semaglutide is undergoing review, where the action is really an insulin sensitizer. I need to say saroglitazar was approved for NASH in India this year. It's a PPAR gamma alpha. But the curious thing that sitadelpa, PPAR delta did not have any significant effect. Rosiglitazone is a PPAR gamma only reduces fat but doesn't improve NASH. And elafibranor is a PPAR alpha delta that also was negative. So it seems that you have to have PPAR gamma and alpha, pioglitazone being a milder PPAR gamma with huge effects, and lanifibranor just reported 2 weeks ago significant effects on patients with NASH. I heard that. I'm about to leave. So take-home message: diabetes agents that target adipose tissue and insulin resistance, either you reduce the amount of fat or you shift the fat back to normal. And again, these are the agents that have worked: pioglitazone, vitamin E, some semaglutide, lanifibranor, but not a number of other ones. So with this, remember your target is adipose tissue. Either you melt it away with exercise, bariatric surgery, or medications, or you change its biology, shifting from that of an obese person to that of a lean, healthy individual. So take-home messages for the audience: type 2 diabetes and risk of NASH with advanced fibrosis. You need to screen these individuals. There are many mechanisms why they have increased cardiovascular disease. Adipose tissue dysfunction is key. Current diabetes management for these people are more focused on cardiometabolic impact because they have diabetes associated with increased cardiovascular disease, NASH associated with increased cardiovascular disease. So you got to work very hard on your lifestyle. Don't underestimate bariatric surgery. Again, pharmacological therapies, we have pioglitazone, GLP-1 receptor agonists, maybe SGLT2 inhibitors. What's the future? We need to find better ways to screen our individuals. But the future is going to be pretty much like the future of diabetes, giving agents that treat the insulin resistance, treat the cardiovascular disease, and help with NASH. So with that, I want to thank all the wonderful people that work with me. I have many people from India working for me. So it's a country that I love very much. So thank you for having me.
Well, thank you, Dr. Kusi. I think it was a very well alluded all about the NASH and everything. So can we have now both the speakers, Dr. Amalia and Dr. Kenneth, for the question answer session? Maybe we start with Dr. Bhatnagar. Maybe he would have to ask you something.
Yeah, wonderful exposition, Dr. Kusi. I really loved the lucid presentation. My first question is to Amalia. Where exactly do you see the role of gut microbiota in the management or even the pathogenesis and the evolution of NAFLD-NASH?
Yes, well, there are several studies, and we heard today in the other in the parallel session, Dr. Turini, that was also talking about the implication of dysfunctional gut microbiota, and also dysfunctional gut microbiota has been associated to NAFLD and NASH. I think it's possible that several metabolites that are produced by the bad bacteria are implicated in the sort of second hit, to go from a simple steatosis to then the steatohepatitis. However, it's very difficult to understand which are the mechanisms. And there is just a recent study published by Professor Christopher Byrne in gastroenterology, I think was in May, where he gave a symbiotic to for I think 14 weeks. He was able to change the gut microbiota of these patients, but but they did not decrease liver fat. So for sure, you need probably more than just treatment and changing gut microbiota. You need a completely lifestyle changes. So it's not a simple addition of symbiotic. You need a new diet, for example, a diet full in fiber, because we know fiber are stimulating also the production of short-chain fatty acids. Short-chain fatty acid, in turn, they stimulate GLP-1. We know the good effect of GLP-1 because Dr. Kuzi just talked about GLP-1 receptor agonist. So I think it's playing a role. We don't know exactly which role, and I think we need to, it's not the solution, but we need to take it into account.
Okay, thank you very much. Yeah, Dr. Altamash, would you?
Yes. I think I would also
please.
like to ask one question. That's what to Dr. Amalia. Dr. Amalia?
Yes.
I think just on a little lighter note, while showing the lean NAFLD slide, you showed the man with the spectacles. Was that related to myopia, or it was just a diagram?
What, a man with?
All your illustrations, only one fellow had spectacles in a lean.
Oh, yes, yes. Well, actually, I took the slide from a review from Professor Bujanesi. I'm not sure that this is related to lean NAFLD, but it's interesting. I should ask Professor Bujanesi what if there was something related to that.
Before the COVID started, there was a paper which said that NAFLD in association with diabetes and obesity should be labeled as MAFLD, metabolism.
Yes.
MAFLD. What are your thoughts on that?
Well, I think Dr. Kuzi also wants to say something on this. On my behalf, I think, you know, just a little bit of wine or alcohol, if it is not a high degree alcohol or whiskey, and especially if you drink it during the meal, like we do in our Mediterranean diet, it could be not harmful. And of course, you know, it's, you know, non-alcoholic has the one of the assumption that you don't drink at all. I think metabolic is more appropriate, even if it will be more difficult probably to do that. What do you think, Ken?
Sure, Dr. Kusi, your comments on the same question, please.
Well, there's a lot of controversy and some we'll go back about 20 years. I don't like the metabolic syndrome because the name doesn't mean anything. In that sense, I would share with Dr. DeFranco that the insulin resistance syndrome tells more about the mechanism, although it's not, you know, the only mechanism. And the same way in NASH, I think it's lipotoxicity. So I would favor a term that is more linked to lipotoxic liver disease or something like that. So metabolic doesn't mean a whole lot. It's confusing. But but just to be fair with the field that of people who don't like it, like some people in the ASLD, is because there's already confusion among primary cares of what NAFLD is, and now you introduce another term. The second thing, the argument that many experts or key opinion leaders say, well, we don't know the mechanism, so why? And third is that patients like that they don't have alcohol. It's not due to alcohol, so it makes them feel better. But again, I think the controversy will go on. I just don't like metabolic. It matches, but that doesn't say much. But I know what the point is. It tried to move away from a non-something. So, you know, I think we shouldn't get tied up or go spend hours and hours on nomenclatures. Just focus on educating patients and moving on.
Right.
Yeah,
right.
if I can add something, you know, in an editorial that I wrote like a couple of years ago, actually, the distinction was between metabolic and genetic NAFLD. So, because there is also that part, you know, the genetic NAFLD, the one that has like the PNPLF3 mutation, TM6SF2, the MBOT, and so on, they usually are not insulin resistant. So for sure, it's like a sort of different NAFLD. And instead of saying like metabolic or genetic, because I agree in that part with Dr. Kuzi that if you give the wrong message, then it's already difficult to tell the patient not to drink. So you try to do good things to try not to cluster in the wrong way, but on the other side, you give the wrong message. But, we should distinguish between what is, at that time I was saying, like, we should have like a sort of type 1 and type 2 fatty liver disease, because like type 1 and type 2 diabetes, because they are two different aspects of the same disease, but they have different physiopathology. The mechanisms are completely different. One is based on the genetics, and the other one is more based on an alteration in metabolism, and especially insulin resistance.
Right. Dr. Bhatnagar?
I just would like to ask a lot of other faculty members here, and anybody in the audience has a question. I see Dr. Rajiv Chawla is with us, Dr. Shalini Jaggi. Dr. Chawla, if you're still listening in, go ahead and you can unmute yourself and ask a question. Dr. Kuzi, so I would like to just post to you, there are a lot of clinicians in the audience, and in India, we have a lot of fear, if all my, both my colleagues will agree, of pioglitazone. So, this whole fear of edema, the weight gain is really a deterrent. So if you can take that fear away, what is the minimal dose you would advise for an insulin resistant liver? I'm not going to call it anymore anything else.
Okay, so I would just start first, make sure they don't have edema, that their BMI is not very high, they're not on 100 units of insulin or amlodipine. Okay, those would be the 4 things. Then make sure they clinically, at least, they don't have heart failure or a history of having 6 stents or several bypass. So then start 15 milligrams, and see how it goes. This is a chronic disease. There's no rush to bump it up. You can take 3, 6 months, a year. Liver enzymes are always going to go down. And if you don't see that there's significant weight gain or edema or shortness of breath, which happens in really 5 or 8% of patients, then you can bump it up to 30 milligrams and just keep it there, because you get 90% of the benefit at that dose. I wouldn't increase it more. I mean, we did higher doses just to prove an effect, but that's the approach that I think is most practical.
So do you believe that the effect of pioglitazone is not because of the insulin resistance or something else which could be? Why I'm asking this, because saroglitazar is very much available in India. We've been using it in around past 5 to 6 years now. Although semaglutide, whenever it comes, we will use surely. So how would you see saroglitazar, a drug available very much in India, versus pioglitazone, where we have a scare kind of using it for whatever reasons Dr. Rucha also has mentioned?
Well, we have participated in studies in the US with saroglitazar, and there are some biopsy studies from India, Mexico, but we have not seen, or I cannot comment on the results. So saroglitazar is more about PPAR alpha than gamma, but has also a gamma. I don't know. We don't have a head-to-head study, and I don't know what to tell you. But if you get good results with saroglitazar, just go ahead. If the results are not as good, maybe you want to try it as another alternative.
Okay. Dr. Shalini Jaggi has joined us, and she's been raising her hand. So Altamashif.
So I wanted, Dr. Kuzi, in India, we have a lot of people who use 7.5 milligrams of pioglitazone. Do you think that would also help rather than 15 milligrams? Again, the same.
Well, I don't have personal experience on it, but I've seen the literature, and again, it's a dose response. So if you're more comfortable starting 7.5, just do it. And then if you see that the response is okay, you bump it up to 15. There's no rush. We're talking about years and years of disease. So as long as you start at any dose you want.
Thank you.
Dr. Amali, we did one study on 75 non-obese diabetics, and we tried to compare their NAFLD score. We did an RFI for all 75 patients. Their BMI was less than 25. Of course, as per Asian criteria, they had some amount of visceral fat, although BMI was 25 or less than 25. All these patients, they had higher HbA1c, but it correlated very well. After doing the RFI and the NAFLD score on that, we found that it correlated directly with HbA1c, duration of diabetes, the visceral fat, and the BMI, and also the microalbuminuria. So these were the confounders. All those patients on RFI, which were stratified by RFI in terms of NAFLD score, they correlated very well with microalbuminuria, duration of disease, and poor glycemic control. What is your comment on that?
Well,
it is
you
yet
know,
to be published. That data we are sending, it is yet to be published.
yeah, well, I wish that we will, I think that they will
Send it to
add a
Dr.
lot.
Gasaldelli for review.
Yes, yes. Of course, I think this is very interesting, especially because, as I said, that there are not many studies in lean NAFLD. And I remember when we wrote our first paper with was back in 2004, and actually we had so much trouble because they were saying there is no lean NAFLD. So it's been rejected just because people were thinking that we were not, and these were all with liver biopsies. So I mean, it's not something, and right now a lot of people are talking about lean NAFLD. I'm pretty sure that in the US it's more difficult to find lean NAFLD, but in Asia and in Italy too, you all have people with low BMI, and of course they have a sort of, lipodystrophic phenotype with more visceral fat and less subcutaneous fat. And I think it's very important to add the data on this field because we know a lot about the obese NAFLD, but we don't know much about the lean NAFLD. So I think it's all the information that are on this topic needs to be made public.
That is why we took all lean, those who were having BMI less than 25, because we were not doing liver biopsy. So risk stratification and NASH scoring we did by RFE. And then we tried to correlate it with all other microvascular complication, as well as glycemic control and duration of disease also. And it was a statistically significant correlation.
Interesting, yes.
If I can make a comment,
yes.
If I can make a brief comment, and
yes.
I know Rucha is going to get angry with me, but you're going, but because you want to move on. But really quick, we wrote a little editorial that people with lean NASH or NAFLD are always insulin resistant. So you could still give them an agent that improves insulin sensitivity for their NASH, 7.5 or 15 milligrams of pioglitazone. And again, it's a generic. I have no conflict of interest with pioglitazone. They haven't given me a penny in 15 years, so go for it.
Plus, there is no worry about gaining weight because they are lean. Right?
Okay.
Very good.
Right.
I would like to just take this chance to thank both my professors, Dr. Kuzi and Dr. Amalia. Both have been my professors in the past, and it's a great pleasure and honor to have you at our conclave. So this is really wonderful, and I'm sure the audience is benefiting from all the sessions. And then I'll hand it back to you, Altamash. Sorry, I didn't mean to interrupt you there.
Sure. No, the last comment that we were saying with Amalia, that we think Rucha was one of our best trainees. So we are not surprised that now she's a leader in her country.
Thank you, sir. Thank you so much.
Congratulations, Rucha.
My last comment and question, with the permission of my co-chair, Dr. Bhattakar. Dr. Kenneth very nicely said in his talk about that we need to avoid tacos, pizzas, and carbonated drink. So in our experience, in our population, what would we do that, Dr. Bhattakar? You are the HOD of gastroenterology, and I think your expert comments would really help all our physician friends and others, those who are attending. Three foods that you would want to avoid.
I think Dr. Kuzi briefly alluded to the fact that coconut oil, good carbohydrate rich, typical Indian diet, what we used to call in our residency days and training days as typical heart attack food. I don't think we need to get into a politically incorrect discussion about this. I think most of our traditional Indian food, what is being consumed in the rural areas would be termed as pretty much healthy food. I think it is the urban population which needs to cut down on its saturated fats and the colas and the pizzas and the burgers. I think it's the fast food epidemic which has hit India in a very big way, which is something we all need to guard against to stop this pandemic, which is spreading very rapidly, the one of NAFLD NASH. I don't think time permits us to have a very detailed discussion on this. By and large, I would agree with what Dr. Kuzi said very clearly, that still I think lifestyle management and modifications would be the key to stop fatty liver in its track. And we know that there is a cross between the liver and the pancreas, which was very beautifully brought out by both the professors. So I think I would definitely want to educate my patients on that. And for that, we have a dedicated dietary advice team which takes care of these things. On a broader note, to answer what you said, I think we would ask them to go back to the basics, have proper home cooked food rather than the processed junk which we are consuming in a very big way.
Well,
Right.
COVID, I think COVID made us to stay home and go back to cook healthy food. So one of the few good things of COVID is not to eat properly at home and try to cook our own meals.
Couldn't agree more. Couldn't agree more.
No.
Just a quick comment. I've noticed Professor Sylvia Toroni, who's an expert on this, is in the audience. Professor Sylvia, do you have a quick 30-second comment on diet and probiotic and fatty liver or gut microbiota? I see that she's there, listening to Amalia's talk. Okay, but I don't think there she is. Yeah, thank you for joining us, Sylvia. Do you have any comments on, she's the expert on gut microbiota and metabolic syndrome or the fatty liver. So do you have any dietary advice for all our panelists and the audience from the gut microbiota?
Advice is, excuse me, always the same. I mean, dietary fibers for sure, because as I told you before, the short chain fatty acid that are the result of microbiota metabolism of dietary fibers are very important, variously important, but very important for our physiology. So for sure, in the context of metabolic disorder.
Okay, thank you. Thank you so much. I think I would like Dr. Bhattagar to say final concluding remarks as a senior co-chairperson. Dr. Bhattagar? Okay, over to Dr. Rucha Mehta. Thank you so much, Dr. Rucha, for inviting us.
Yes.
Thank you so much.
With this, we would end the session, move to our next symposium. For the next symposium, I would like Dr. Krishnan to lead as a coordinator. Thank you. Dr. Goyal, are you with us? You need to unmute yourself.
Hello.
Thanks for the wonderful sessions, Dr. Kuzi and Dr. Amalia. Let's move on to the next session, medications and the heart. For that, may I invite Dr. P.P. Mohan sir, our President-elect Cardiologist Society of India from Kerala, a very senior cardiologist, and Dr. Shalini Jaggi ma'am, diabetologist from New Delhi. Over to you, sir, Mohan sir and ma'am.
Thank you. Without wasting time, let us go to Professor Tilton's talk. I don't want to upset the endocrinologist by saying we cardiologists see more patients of diabetes. But then this was one of the paper in 2019 Endocrine Society annual meeting. But then so we better know more about the OHA, and that is what when 2008 has shown, when the FDA said that we should have outcome trials. And Professor Tilton is one of the wonderful persons who can educate us. He's the chairman of the ACOI Board of Examiners for Interventional Cardiology, director of Cath and Electrophysiology Lab, associate program director of Interventional Cardiology, director of Clinical Proteomics Research Lab at UT, cardiologist at NASA, with a huge amount of publications and, of course, a lot of grants. Over to you, Dr. Tilton. We have listened to you earlier, and we enjoyed that. Please, over to you. Dr. Tilton, are you able to hear us?
Yes, I can hear you, and I am trying to start this video. Here we go again. Let me see. Maybe we got it. Let's see. Do you have me there?
Sure.
Okay, let's get going then. Okay. Actually, I really appreciate being invited to this, and I thoroughly enjoyed Dr. Kuzi and all of your comments about NASH, because it certainly triples our heart disease risk in the cath lab. But let me take you through my view of the oral anti-diabetic agents, or should I say the cardiovascular drugs that actually improve glucose. Because I think these drugs that you have brought to the market that help us also help you and actually both of us a lot. The target to me is oxidative stress, and I will cover the drugs, but I'm going to do it from a basic science point of view in reverse because it covers a bigger area of the drug class. What all of us are trying to do is decrease cardiovascular events to a large extent, but also solid organ disease, which eventually in time leads to that. So I think lifestyle wins. It trumps everything I have. Find me a drug that loses weight, that's safe and easy to take. I think it will beat all my drugs. I can put stents in till I'm blue in the face, but I can't beat the metabolics throughout the entire body. This slide, actually, I put together from Ken and Charlie Reasoner, who passed away recently, and a very good friend of all of ours, and Ralph. And I think this really is the bottom line to a large extent of the problem. The cellular structures are just all messed up. When you become insulin resistant, you can see on the pathway that you actually are still driving the atherogenic pathways. And I think many of us forget that. And I know the house staff, certainly cardiology guys, miss this a lot, but that's the one that I really worry about. This one over here, I'd love to correct, but my PhD guys don't think I can fix that. Once it's damaged, the PI3 kinase is pretty much damaged metabolically. It may be because metabolically, nobody ever corrects their diet and loses weight again. So I think that's still up for grabs. Nitric oxide is a big deal. If you can make more nitric oxide, you'll live a long time. Women have more nitric oxide in the brain. Very interesting article published in Nature. I guess that means they're smarter than us. But you can see the two pictures. I'm showing it to you on the actual cell wall over here. You can see the gas, and over here, the beautiful effects of higher levels of nitric oxide. It could be hyperpolarizing factor. It could be other things. It could be drug. But primarily, your body runs on NO, and if it goes down, basically the lights go out and your vascular bed becomes atherogenic. These are the three areas that I'm going to hit in the very short time that I have, but I think I'll hit a lot of drugs here. The actual inflammatory circuit is huge. I cannot imagine how many drugs we're going to have that target inflammation. We hit metabolics for 20 years. I think now we're going to hit inflammation. At the same time, we're going to hit metabolics and wall stress. I won't mention, but blood pressure counts because it's the only thing that's different than the actual metabolics and the inflammation. But if your blood pressure goes up, you're going to beat the heck out of your blood vessels, and you will eventually fracture a plaque someplace that's unstable. These are all the areas that you can potentially imagine that you can hit that actually go down to inflammation. All of these areas are ones that all of us in the cardiometabolic area have really worked on. At the center of it is everything the endocrine guys do. All of you guys, to me, are my research folks. You show me my new drugs and you help me, but they're way down the road when I get them in the cath lab, and basically I end up putting stents in. But if we don't take care of the metabolics after the stents, these guys crash much quicker. And I'll close and I'll show you how good we really are doing surgery. It's not real pretty. We don't do well. These are three big areas, I guess four. Your mom and dad count for the most, so you need to pick your parents very carefully. Your genes account for heart disease, huge, probably trumps everything that I have. But then you have a choice. You can do your metabolics and you can get fat and you can have a lot of things that lead you to the cath lab, but I'm not going to make you live longer. I will stop your chest pain or infarct your vessel, but I won't decrease heart attacks. I won't decrease anything like that. That is metabolics. The wall stress I mentioned earlier, the inflammation, I think goes with metabolics. You control the metabolics and you get it under control, the inflammasomes will kind of cool off and the inflammation goes down and the patient will do better. And I'll show you case in point. This is the problem in the US, and it's got to be in India too. You're not getting better by 2030, you're getting worse. If you look at the heart, you're looking at the robotic surgery that's going on, but the problem is just look at the fat on the heart. It looks like a chicken fat. That is a human heart, and it's just full of fat. You can imagine that's in the liver too. And that's why Ken and Rocha and all of us really struggle with these metabolic syndrome cases, even though you may not like the term. At least the cardiology guys finally recognize something. You guys can argue more specifically, but I think for cardiology, it's a pretty good term, and they seem to have bought on to this. But it looks like 1 in every 2 people by 2030 is going to actually have the actual obesity problem. It also, in people that don't have much money, here's under $20,000 a year. It's much worse in India. The severity of obesity is higher, and certainly it's higher African Americans. Now, India probably doesn't relate too much to you, but women seem to have more. These areas need to be looked at more and targeted. But again, it's an income problem and stuff. This is a fat cell diagrams. I happen to like this one. Many people have used it, but look at all the things, all the different kinds of adipokines that come out of fat cells. If you get macrophages turned on, they become active and they become actually inflammatory. They will secrete every bad thing you can imagine. They will rupture my plaques. They will give you guys more trouble, and the inflammatory circuits are certainly going to be cranked up, and the interleukins will go straight up with that. There's a lot of things that go into it. So let's take proof of concept. Can you really decrease inflammation and make a difference in events? This is a great trial that that Paul Ricker did. And I think the thing about Paul's study is that in the CANTOS trial, the argument was, if I bring down CRP but don't change any of the lipids, can I really make a difference in events? And what he found was you could. Now, what I'm going to do now is I'm going to take a little bit different turn to it. You all know that. But you may not be aware of how bad the kidney plays into this game. If you take a look at chronic kidney disease, it certainly increases inflammatory signals and atherothrombosis. It's certainly connected, and it's not related to the lipid level. So is it possible, if I separated it out by GFR, I could look at a different rate of incidence of actually the three big things that we have in heart diseases: heart attacks, strokes, and MIs. And you can see as the kidney function falls, it becomes very powerful. So if you give me chronic kidney disease and on top of it, you've got abnormal metabolics, which you probably have, and most of the kidney disease I see comes from diabetes, you have really increased the chance for cardiovascular events, death, and all-cause mortality. Can I tune that down if I was to use these different types of agents? And you can. Most of the people with moderate chronic kidney disease have diabetes. It may even be higher. But if you take a look, most all of your trials in diabetes all have high blood pressure. Same thing in kidney disease, 80% plus. Notice too that their CRPs are higher. Certainly their serum creatinine has gone the wrong direction, and the GFR has certainly gone the wrong direction. So when you look at metabolics and you're really looking at glucose, cardiology seems like it gets everything. If the glucose is bad, you're in trouble. If the guy's kidney function's in bad, you're in trouble. Blood pressure's bad, you're in trouble. All these things hit the heart, and certainly is it possible that you might be able to give the drug that decreases inflammation like IL-6 blockers and do some decent work, and you can. This is the CANTOS primary endpoints, and you can see that if you give canakinumab, which is again it's a 1C blocker, but at the same time it blocks interleukin 6. If you block that, you do decrease cardiovascular events by decreasing inflammation. So it works really quite good. Now, does it have other effects that are off target? It does, and I think we'll have to look at it much cleaner drugs. But it does have an important area that we haven't discussed outside of metabolics, insulin, and glucose. And I think metabolic guys, like most of the endocrine folks are, this is still in your bailiwick and one that we need to watch. Now, how does it get to the SGLT2s and the drugs that we use for supposedly lowering glucose? One thing is it does improve the actual glucose disposal. It does have an ability to improve insulin sensitivity when you give SGLT2s. And I'm going to show you the SGLT2s also have inflammatory signal benefits. But more than that, they actually hit fibrosis. And fibrosis is now getting to be much more of a problem. For example, most of you guys have people that are short of breath would have an ejection fraction that's normal. And you say, well, gosh, they're short of breath, it's because they got diastolic dysfunction. That, to a large extent, may end up being a fibrotic problem. So when you give SGLT2s, you actually, and this is an example of canagliflozin's data, but in fairness to the other companies, they also have similar data. You can improve these signals. If you just simply look at the gene expression over here, look at all the ones under the SGLT2 that are green. Look how it changed from the control. All of these signals relate to a lot of different parts of the mechanisms at a cellular wall. So you're going to change actually TNF alpha, many of the matrix metalloproteinases, in inflammatory circuits. So I think it's one that we're all going to have to embrace. I don't know of a guy who's just an inflammatory guy who just works into that area. I think certainly glucose falls into diabetes. Inflammation, it falls in both of our target areas, and we both need to pay attention to it. Here's just a bar graph. Let me take you to the most important ones. Here's TNF alpha, and you can see that certainly it brings it down. That's important because that's a transcriptional factor that regulates inflammation. Over here is interleukin 6, very similar. MCP1 did not seem to change as much in this trial. If you look at the matrix metalloproteinases, again, those are ones that weaken my cap. But at the same time, there's some of the MMPs that are beneficial in a different direction. And over here is growth factor. We've really hit that hard. So I think these will need to be sorted out in time clinically, but ones that we all are going to have to pay attention to as we move into more molecular medicine. Here's an example of if you weaken a cap. This is an endothelium under high pressure. Look how it's torn the actual skin lining right off of the vessel. Over here is one of my patients, and look, he ruptured a plaque in the left anterior descending coronary, and you can see where he's torn and bled backwards and underneath the plaque. That's not stable. And over here is actually where he blows out part of his plaque in the cath lab from optical coherent tomography. This is a laser. It has a 7-micron accuracy. That's my catheter, and watch it. It just blows right out of there. That's an acute infarct type of setting, and one that, again, we can see, but the metabolics that you guys work on with me are the ones that's going to change and help the patient long term. This takes a look at the SGLT2s, at all of them pretty much across the board, and you can kind of see where they have an ability in some respects to decrease hsCRP. I think we need mass spec. I think we need proteomic and lipidomic signaling better than this. This is old technology to me. Everybody on this call that's in endocrine knows these have been around a long time. We need better information, and we need it to be explained to each of us a little bit more accurately than we currently have. This simply shows you the curve, and it shows you the correlation between actually the actual amplitude of the wave, different types of inflammation in the arterial stiffness. Notice CRP is actually related to how stiff your blood vessels are. Now, is this important? As your aorta becomes non-elastic, you increase the shear forces in faster way that you tear arteries. That tells me it's an aging process. Your whole body is 60,000 miles of artery. That inflammatory circuit that's connected to it certainly is going to make it much more likely for you to rupture a plaque. So here we have wall stress and we have inflammation. So all you have to add to the mix to make a real nice soup is just some metabolics. Add a lot more grease, and these people will be off to the races with more cardiovascular events. This may be new to many of you, but you might want to look at this. Nitric oxide dilates blood vessels. How is it that you can lower blood pressure with an SGLT2? So that's been worked out, and it's in the basic sciences, but probably most of us don't look at that a lot. But here it shows the activation of the KV channel, and when it does, it can vasodilate the actual aortic rings. If you take and strip the endothelium off, it still works. So how is that? Because there's no nitric oxide now. It can block the calcium channel. It still works. And if you block L-name, it still works. So where is this thing working? These potassium channels actually have their own ability to regulate vasodilatation. But at the same time, along with the fact that they have ketones in SGLT2s that increase a little, that ketone is actually antiarrhythmic. At the same time, you can shorten repolarization of the ventricle, and that is independent of glucose control. Down here is a picture. If you take a look at the ones in the red and the brown, those are examples of increased Q2 dispersion. That means you're more likely to have a bottom problem. These compounds have an ability to shorten that. It brings to mind, how did we find decreased cardiovascular death in empagliflozin? It could be that these potassium channels also relate to as an antiarrhythmic, but we don't have any data yet, but it's pending. The potassium channels are the ones that most antiarrhythmic drugs work on. So I think, again, these drugs are much more wide sweeping than just lower glucose. This simply shows you all of the trials. To a large extent, we've got the main players here. You've got DAPA, you've got CANA, and you've got IMPA. The only one that dropped the death was the IMPA-REG trial. But if you take a look at the MACE endpoints, all of them actually have targets for that. And you can see these trials are very short. Cardiovascular trials, as a rule, are 5 years. I have difficulty with these short ones, but even in a short time, I'm still able to show a major improvement. Now, let me show you very quickly heart failure syndrome. These have an annual event rate, and DAPA-HF is probably the one talked about the most right now. I want you to take a look at the green bar. If you get, again, heart failure, and you're in the DAPA-HF, you have a 15% chance of having another worsening heart failure, hospitalization, or death from cardiovascular causes in 1 year, 15%. Watch this one. This is the new drug that works on inside the guanylate cyclase, and look, it has a 35%. Huge. These, I mean, if you think about it, you have a guy and he goes 1 year, 35% have another event. That's incredible. Most of your drug trials that you look at are 4% or less. Here we're 15 to 30. So heart failure, not a good player. And here's the Paradigm HF that all of you are familiar with, the sacubitril group. It still runs around 15% or so. So you're looking in heart failure, once you get it, at a very high event rates. It's not as easy as taking a statin. Most of my statin trials had event rates not even close to this range. This takes a look at the mechanism of action. So I'm going to start with, again, the Paradigm HF with the actual ARB and neprilysin inhibitor. And this helps to counter the overactivity of actual neurohormones. Does it lower glucose? It actually has an ability to do that. It can lower blood pressure, decreasing wall stress, but it doesn't protect the kidneys. But you have drugs in your diabetes area that protect the kidneys. Matter of fact, it may be the most powerful part of it. But at the same time, their endpoint was death, cardiovascular causes, hospitalizations for heart failure. Now, if you look at the Victoria trial, which was recently done, that's a guanylyl cyclase that increases GMP, it actually didn't seem to be quite as significant as all of us would have thought. But at the same time, I'd have to ask you, if you're at 35% in 1 year event rate, what did you expect a drug to do when the heart's already dead? You should have started a lot sooner. So that may be too sick a population to really tell me as much about. I think we probably should have backed up a little bit. And this is the actual DAPA-HF. Now look at the mechanisms that you gain when you use the SGLT2 inhibitor. My gosh, I mean, I couldn't even get them all in my slide. I don't have that many benefits setting over on the Paradigm HF side or the Victoria side. So does the SGLT2 inhibitor that folks in Inter can actually sort of own at this point in time and share with cardiology show a bigger benefit for a lot more things? It may be, I mean, it drops the blood pressure good, it gives you a little ketone boost, it protects the kidney big time. I don't see kidney protection so big in the other compounds. The GLP-1s definitely have some advantages, but they don't have the actual benefit you see from the SGLT2 in some respects. But they do have one thing: they make you lose weight, and weight loss is very impressive. And if you just had to pick one drug, weight loss almost trumps everything. So I think they have a big benefit, but I can't spend time on all these. But I just show you just some of the highlights. Here's the PPAR gammas. Ken and I guess many of us love this. Ralph does too. I think this drug is way underutilized. Low dose is great to me. It's a master regulator. One way or another, I think we're going to be back to these type of compounds because they regulate so many things. They can make you vasodilate. Even if you block the PPAR gamma receptor, the drug still decreases your glucose. Mechanism unknown. It can decrease macrophages, but it's the best one for skeletal muscle taking up glucose. So I like it. And I use it still in my practice in cardiology patients, but I don't use much more than 15 and maybe 30. But by and large, I don't have to worry if I give an SGLT2 because it balances it out. And if you add a GLP-1, they may even lose weight. So I think there's a lot of advantages to the actual PPAR gamma. Here's simply the IRIS trial. This was actually picked up from the actual proactive years. And we saw that if you had a stroke, the second stroke, we can decrease. As a matter of fact, we can decrease the second stroke and we can decrease heart attacks in a prospective trial that was very nicely done by the people at Yale. And Silvio Zucchi in that group over 5 years did nearly 4,000 patients. This shows you the hard evidence. Here's your stroke setting right here, and you can see a benefit. Here's your stroke and MI, very nice significant change there. I think we have to pay attention to this. If you've had a stroke and you want something that works, you actually used low dose in a lot of these patients. They didn't have trouble with fluid retention because the physician chose the dose and watched the patient. And I think we could do just as well. Diabetes, cut it in half. That's just a freebie, but glucose is important to eyes and kidneys. So even though the cardiologists don't make much homage to this, I like glucose. And if it's up, the biomarker tells me that you're not doing well and you need to improve that. These are simply the curves here again for MI, and you can see again the ones from PIO versus the control. And here's PIO for stroke versus the control. Huge difference, quite significant. This shows you acute coronary syndrome in that trial. Here's the ST elevation MI in that trial, but it doesn't help the non-STEMI. The reason I put that in there is most of your patients in endocrine have non-STEMIs. They don't have ST elevation MI because you already treated them with statins. You already gave them all those drugs, so they don't really close the coronary. They only sort of close it, and then it leaves me time to fix it in the lab before they lose more cardiocytes or more muscle. If they have a STEMI, they're killing so much muscle in seconds. It's amazing. And you know, I don't have much to work on if you wait 90 minutes to get to the cath lab. I have maybe 10 or 15% muscle I can save. 80% is dead. You got to get to me in 15 minutes. So you want to have your heart attack on the cath table if you had a choice. So sleep there maybe at night sometimes. Over here is pioglitazone's area in the brain. And the reason I picked iris is pio has an effect on peroxidase 2. It's an anti-inflammatory, back to inflammation. It works on the actual mitochondria. It actually protects it. So when you look at PIO, it has a lot more effects than actually just taking a look at lowering glucose. It even works in these areas. And again, I just quickly show you, here's PIO up here is a very powerful antioxidant. And here's the parts of the brain a lot relate to high blood pressure strokes. Again, PIO lowers your blood pressure significantly in the proactive trial. Kind of closing up, this is an important one for all of you who have human hearts. If you don't have a human heart, you don't have to worry about this one. If I cath you and do and I look with IVUS down your coronary, and I give you a pravastatin molecule to lower your cholesterol in 18 months, I can actually slow the progression. I didn't decrease it, I slowed it. And you'll see here where I started and over here after giving the high dose statin. That's this group right here. If you took PIO and you gave it, you would find in the glyburide group, you will have still advancement of atherosclerosis over 18 months. Everybody advances except if you're taking PIO. It actually slowed it down. It halted it. Does it reverse it? It didn't quite hit significance for part of that, but it's telling you that if you can take that drug, it has an ability to actually slow down the atherosclerosis in your heart. How do you know if you're the guy who got it? The guys that have high HDLs have carotid regression or slowing down, and they have intravascular ultrasound evidence of actually halting the progression of disease. Closing comment, 3 slides. Back to the human heart. Here's a guy that 6 years ago had normal coronaries. I want you to look at these. This guy is 42. Look at those blocks in that artery. There's one, here's one over here, and look down under here. He already closed his right coronary. It doesn't even fill. It's going backwards. That is what you get. So you say, well, I'm going to send this guy for operation, and I'm going to send him to get fixed. Here's the very best surgery in the world. Freedom trial, diabetes. This is our bag. Okay, take a look. If you're a low-risk guy and you have easy vessels to put grafts in, this is your event rate. If you take a look, this is your event rate, and it's 5 years out. If you have a PCI, your event rate is actually much higher than if you had a Lima artery put in with a graft at 5 years. Event rate means, again, you had death, MI, or stroke. If you take insulin, this is where you are. It doesn't make any difference what you do because you're high risk all the way across. But one thing's very clear, don't pick a PCI. If I give you the best surgery I can give you, at 5 years, you will still have near 20% another heart attack, stroke, or MI after bypass if you have diabetes. That is far from being perfect. We need to do better than this. This is all metabolically controlled patients as best they could do, but even in the trial, they didn't do well. This is my last slide, and I think it's food for thought. I don't have time to talk about diabetic lung disease, but I think another time we should probably take a look at that, because that now is becoming one of the most common things I'm seeing in the cath lab. And I think it's one that you all are going to have to face. Who is that guy? The shorter breath guy that's got big right-sided chambers. He is hypertensive in the lungs and he doesn't do well and he's got diabetes. Thank you very much.
Thank you, Dr. Shilton, for that excellent coverage, right from canakinumab to SGLT to GLP to Versigua, whatnot. May I request Dr. Shalini to introduce the next speaker so that we'll have the discussion at the end of the session.
Sure, sir. Can I have the slide for Dr. Devjit Tripathi, please?
Okay, okay, I'm trying to put it now.
Good evening, everyone. So we've had excellent sessions and we're all glued to our screens. We now have another eminent speaker, Dr. Devjit Tripathi. And before I introduce him, let me tell you, I already know a lot about him. I've heard a lot of stories from my mentor, Dr. Rajiv Chawla and Dr. Dandona. So I know what we are in for. So welcome, Dr. Devjit Tripathi. He's Professor of Medicine and Endocrinology at the University of Texas Health Sciences Center, San Antonio. He's also the Director, Diabetes Research Unit, VA Hospital, San Antonio, Texas. He established the Botnia clamp, which is a study that allows one to quantitate both the insulin secretion and insulin sensitivity during a single setting. He was one of the first to describe detailed metabolic characteristics of the then newly introduced pre-diabetic state or the impaired fasting glucose. And I'm sure that's a big credible thing to his credit. He has characterized the metabolic defects in the pre-diabetic states in patients with LADA and MODY. And of course, he has several publications and grants to his credit. So welcome, Dr. Tripathi, and we're all eager to hear you talk on GLP-1s and the cardiorenal benefits.
Okay, thank you, Dr. Jaggi, for the introduction. And I would like to thank Dr. Rucha Mehta and Dr. Samir Dani for the invitation. It is indeed an honor. I don't know why my pictures look crooked. Okay, maybe I'll try to. Okay, can you see my screen now?
Not yet.
Lights. Okay. Okay, so the title of my talk today is GLP receptor agonists and cardiorenal outcomes. So I enjoyed Dr. Chilton's talk, and as an endocrinologist, my goal is to prevent sending patients to Dr. Chilton, to send to cath lab. And if he puts a stent, then my goal is to say, send him again, so that for his second event. And so, so the talk today is about how the GLP-1 receptor agonists actually prevent or have any cardiorenal benefits. So I was told that to keep it purely clinical, so I'll try to keep it purely clinical. So I'll start with the case. So this is like in a typical clinic, you'll see a patient with a 62-year-old male, has a long-standing history of type 2 diabetes. Currently, he's on insulin and metformin. He also has a history of hypertension, hyperlipidemia, and had a previous history of MI, had a stent, and has mild chronic kidney disease. So he asked you, okay, doctor, can you prescribe me something which will improve my diabetes and also reduce my risk of future cardiovascular events? So these are his lab results. He has A1C of 8% and has a fasting of 140 and has mild chronic kidney disease. His LFTs are normal. So you decide to add a new medicine. So which one of the following will be the best for this patient? You're going to start premill insulin, short-acting insulin. But think of that, it will increase.
Dr. Tripathi?
Yes.
Sorry to disturb you in between. You tilted your iPad, so I think your video is coming.
That's okay. His slides are okay.
Okay. No. Okay.
Can you hear me?
Yes, we can hear you very well, and your slides are upright. So, and okay. You appear to be resting, but that's okay.
I don't know why. So, try to see the video. Okay. Yeah, still does not. Okay, can you hear me now?
Yes, sir.
Okay. Very well.
So, okay, I'll continue. So So the other medicines can you add is glipizide, is a sulfonylurea. However, it will increase the risk of hypoglycemia. The other option is DPP-4 inhibitor. The problem with them is that it's very mild. They lower the A1C only by about 0.4%, 0.4 to 0.5%. So I think the best option is to GLP-1 agonist, particularly the liraglutide. Now, why is it so? So this is the AD and American Association of Clinical Endocrinology guidelines for algorithm for treatment of type 2 diabetes. So the metformin is the first line of therapy. All patients should be started on metformin. Subsequently, if there is a history of coronary heart disease, then either GLP-1 receptor agonist or SGLT2 inhibitor is the next choice. If the patient has heart failure, then of course the SGLT2 inhibitors are the preferred agents. Now, why do we need to care about heart in patient with type 2 diabetes? It's well known that patients with type 2 diabetes are at a much higher risk of coronary heart disease. In fact, coronary events like myocardial infarction, stroke, and PV, peripheral vascular disease, account for more than 80% of all mortality in type 2 diabetes. Although recently it has been questioned, or is a debate that whether diabetes is really a coronary risk equivalent. After the the Steve Hapner's paper showed that if you have diabetes, it's as good as you had a MI in the past, but that is being questioned now. Regardless, there's a lot of data to show that, confirm that indeed diabetes is a risk factor. This is the data from UK, about 1.9 million patients. And on the x-axis show the age, starting from 40 to 90-year age group, and then the y-axis show the event rates. On the top left, it showed that there's, the blue is the non-diabetic and the red line is the diabetic individuals. So you can clearly show that on the top left, the stable angina is much increased in patients with diabetes. The unstable angina is also increased, and the same with non-fatal MI. And there's heart failure, Dr. Chilton just alluded, is much higher incidence in diabetics. The other higher incidence is ischemic stroke and the peripheral arterial disease. So angina, MI, heart failure, stroke, and peripheral vascular disease that clearly increase in patients with type 2 diabetes throughout their lifespan. Another data showing similar data that from UK, on the top is the men and the bottom is the women. The top line is the diabetic and the other one dashed line is for non-diabetic. Again, it showed the increased incidence MI and death from any cause in diabetes. So clearly patients with type 2 diabetes have increased risk of heart disease and stroke and peripheral vascular disease. Now, we all know that if you treat intensively diabetes, you can reduce the microvascular complication. This is the UK PDS data, and showing that with 1% decrease in A1C, you can reduce the complication, microvascular complication by about 37%. However, the same does not hold true for macrovascular complication. Even if intensive control, this line is not linear, it's kind of completely flat, although it's statistically significant. So there are other factors for treatment of macrovascular disease. Although when this study was done, we did not have the GLP-1 agonist or the SGLT2 inhibitors. So after the 2008, the rosiglitazone debacle, the FDA mandated that all new diabetes drugs have to undergo a cardiovascular safety trial in phase 2 and phase 3 to prove that these drugs, all new drugs, do not induce have an increased risk of coronary events, or the upper limit of confidence interval should be less than 1.8. Although this is now being questioned that whether should we do all these trials because all these trials have been neutral or positive. But in my opinion, if you did not do these trials, we would not have known the beneficial effects of these new drugs. So I think these trials actually have helped us. So just to give a brief background how the trial numbers are decided, in diabetics, the event rate varies from about 2% to 4% per year. That's MI, stroke, or death from cardiovascular disease. So the power analysis, the number of patients you need to enroll in a trial depends on these events. For non-inferiority, that is most of the trials, cardiovascular trials, have been done non-inferior. That is to show that the new drug is not inferior to the existing or currently available anti-diabetic agents. You need about 600 events. However, if you want to show superiority, that is that the new drug is superior to the currently available anti-diabetic agents, you need 1,400 events. So if you have 2% event rate, you can imagine what the number of patients you need to enroll in a trial to show a superiority. So again, these trials are designed in such a way that you enroll patients with pre-existing heart disease so that you have a high event rate and you can completely end the trial in a shorter time period. Now, keep in mind that the trial population are always a high-risk population. They may not be representative of the same patient that you see in a typical clinic. So there's mostly for secondary prevention. There are only one trial which look at the primary prevention. Just to give an example, the Excel study, which looked at a long-acting exenatide, and they had to enroll 15,000 patients. The trial, they aimed for superiority, but they could not achieve. So you need, if you just do a non-inferior trial, you can get away 3,000 patients. But to show superiority, you need about 10,000 patients. So now coming to GLP-1 receptor agonist. Before I go into the trials, I'll just give a brief physiology. Now, this is the incretin effect. You must have seen it several times. So the incretin effect is defined as the difference in the insulin response when you give glucose orally versus you give the glucose intravenously. And this is the incretin, the difference in the insulin response. This is clearly lost in patient type 2 diabetes. And the two hormones, which incretin hormones, which account for this effect is called glucagon-like peptide 1, GLP-1, or the GIP, glucose-dependent insulinotropic polypeptide. So there's now this is GLP-1 is derived from called pre-proglucagon, which then gives rise to proglucagon. And there's a differential, tissue-specific differential processing of this proglucagon. In the pancreatic alpha cells gives rise to, is acted upon by an enzyme called PCSK2, which gives us to glucagon, whereas in the intestine and in the CNS, this gives us to GLP-1. The GLP-1 receptors, GLP-1 belongs to a class of receptor called G protein-coupled receptors. This is show how it increases insulin secretion. But just keep in mind that GLP-1 receptor not only are present in the pancreatic beta cells or alpha cell, it's also present in myocardium, vascular endothelium, central nervous system, and kidney, and also in adipose tissue. So that's why you see the effect of GLP other than just on the pancreatic beta cell or on satiety. So these are the currently available GLP-1 agonists. All of them are approved. Albiglutide was withdrawn from markets, not for the efficacy, but purely for commercial reasons. And semaglutide is the oral GLP-1, which is just recently approved. Exenatide was the first GLP-1 was just approved. Just to give you an idea about the structure so that you know why some of them are short-acting, some of them long-acting. Now this is the native GLP-1 molecule, which is about 30 amino acids, and this is the site where the DPP-4 inhibitors act. That's what make it inactive product. And exenatide, it's the first one to be developed, is about 50% similarity to the native GLP-1. Liraglutide was the first long-acting GLP-1 was approved. It's combined with the fatty acid, which leads to binding to albumin. That's why this effect is prolonged. And the semaglutide is similar, but again, it also adds a DPP-4 inhibitor, change the alanine to another molecule here, so that efficacy, it is one of the longest acting GLP-1 receptors, half-life of about 160 hours. And dulaglutide and albiglutide, again, they're bound to the fatty acids, bound to immunoglobulin or to albumin. That's why their duration reductions increase. And because of this bound to albumin, they are not renally excreted. So these are the GLP-1 agonists. Some are exenatine-based. Those are the earlier, the short-acting ones, exenatide and the lixisenatide. And because they're and GLP-1, they're similar to native GLP-1, albiglutide, liraglutide. And the newer this is the ITCA, this is the implantable GLP-1, which can be implanted for about 6 months at a time. And we have the orally active GLP-1, semaglutide. So these are different pen devices, just to show, and of all of them, I think semaglutide and dulaglutide are the one most convenient to use. The patients prefer this to other pens. And these are the two which combine insulin with the GLP-1 agonist. This is ideglira combines insulin degludec with liraglutide, and this is lixisenatide with glargine. So the GLP-1, the first it was developed to use for diabetes because of its effects on insulin secretion. The study is showing that the insulin secretion, one of the earliest metabolic defects in type 2 diabetes is the loss of first phase insulin response. So when you give glucose intravenously, you see a nice peak in insulin response that in normal subjects. In patients with impaired glucose tolerance, is somewhat decreased, but in diabetes, it's completely flat. Now, if you treat this patient with a GLP-1 agonist, you restore the first phase insulin response to like that of a normal glucose tolerance subject. This is a study showing in patients with type 2 diabetes treated with exenatide and showing that after 1 year of treatment, you could completely restore. This is a two-step hyperglycemic clamp. This you cannot. So if you magnify it, you show that there's clearly increase in first phase insulin response as well as the second phase insulin response. And this is the response to arginine. Just show that they have remarkable effect on glucose lowering. And this is a comparison of semaglutide as the oral semaglutide. Now, this is one of the newest drugs approved. And the problem with this, I mean, you have to consume a lot of drug. This is 14 milligram of oral semaglutide you take every day, and which is equivalent to 1 milligram if you take in a week. So the bioavailability is 1:100. But the efficacy is almost similar to injectable semaglutide. In fact, it's better than empagliflozin. This is shows the change in A1C and the change in the plasma glucose, also better than SGLT2 and comparable to injectable drugs. So this is the glycemic effect of GLP-1 agonists. They increase the glucose-mediated dependent insulin secretion. They have decreased glucagon secretion and increased beta cell mass. So now coming to the cardiovascular trials. So after the Alexa trial, the later trial was the next, the first trial to show that there was a cardiovascular benefit to GLP-1 agonists. So this trial enrolled about 9,000 patients, showing that there's a 13% decrease in MACE, that is major adverse cardiovascular event, that is not for MI, stroke, and cardiovascular death. And subsequently, semaglutide in the same year also showed that there's another 25% decrease in major cardiovascular endpoints. The difference between this sustained study and the leader study is that leader was 5-year study, where this is only like 2-year study. The exenatide was one of the largest studies. However, it could not, the problem was that it did not reach statistical significance. And the problem with this study was that it was, there's no run-in period, so there's patient acceptance and the dropout rate was very high. And even the placebo group, there are a lot of more patients getting SGLT2 inhibitors. So I just briefly talked about the two newer trials, the Rewind. I know there's the complete session on this study and this trial, and the Pioneer is the oral semaglutide trial. So this is the effect of oral semaglutide on cardiovascular endpoints. Again, and this was a very short study, only about 15 months. And here it shows that the semaglutide did not reduce compared to the placebo, but it was non-inferior, that is compared to placebo. And however, it does has showed improvement in death from cardiovascular, about 50% decrease in incidence rate. Now, I was asked last time about why we did not see any difference in oral semaglutide versus we saw a significant improvement injectable. It could be because the shorter duration and the number of very low, event rates lower compared to the injectable ones. So although they have applied for a cardiovascular indication, I don't know if it will be approved. It will be, FDA will approve it. Only drug that's been approved is liraglutide for cardiovascular endpoint. So this is the Rewind study, is dulaglutide. The only difference this study compared to other GLP-1 trials is that this is the study which has primarily enrolled patients without pre-existing heart disease. About 70% of these patients did not have pre-existing heart disease, only 30% pre-existing heart disease. And combined, they showed 12% decrease. So that shows an indication that could be GLP-1 could be used for primary prevention also. However, when you do a subgroup analysis, the events are primarily driven by the patient with pre-existing heart disease. So it's still not clear whether these GLP-1 agonists have a clear role in preventing heart disease as a primary prevention. And the other thing they showed here was that there's a significant decrease in non-fatal stroke, and also they have improvement renal outcome. So this is a combined of all GLP-1 agonist studies show there's overall there's about 50,000 patients. There's a 13% overall decrease in cardiovascular endpoint, the MACE 3-point MACE. And there's no effect on, there's 9% decrease in heart failure incidence, but it's not statistically significant. And how about patient with and without prior history of cardiovascular disease? So in patient with cardiovascular disease, clearly shows this, the GLP-1 agonists are improved, show improved outcome, whereas patient without cardiovascular disease, the data is not very clear. And none of the studies were clearly showed that they are beneficial. Again, this is comparative study of between GLP-1 agonist and SGLT2 inhibitors and DPP-4 inhibitors. So on the top, you can see the red lines are GLP-1 agonists, the green is SGLT2, and the blue is DPP-4 inhibitors. in all the 6 trials, Alexa, Leader, Sustain, and Excel. And here clearly showing the leader, the liraglutide, semaglutide, and the albiglutide and dulaglutide. It clearly showed that improved outcome. Excel and the oral semaglutide did not show. And similarly, as SGLT2 inhibitors, the EMPA and canagliflozin showed improved outcome. The hazard ratio is kind of similar, both with EMPA, DPP4 and SGLT2 inhibitor. All-cause death was also shown. Liraglutide was the only one who showed clearly significant reduction in all-cause mortality, and the oral semaglutide also showed decrease in all-cause mortality. And in the SGLT2 inhibitors, is the empagliflozin showed improved. Now coming to the heart failure, of course, there's clearly only one class of drugs which is beneficial, that is the SGLT2 inhibitors. So how about GLP-1 in acute coronary syndrome? There have been studies in acute coronary syndrome, and however, the data is not very clear, and none of them have shown improved long-term outcome. So the mechanism of action GLP-1, there's several hypotheses, mostly animal studies, does increases cardiovascular risk, decreases cardiovascular risk factor, improves glucose metabolism, increases myocardial glucose uptake, and decreases blood pressure. I'm not, Dr. Chilton already talked about it. So the mechanism is not only the GLP-1 molecule, but some of its metabolites also exert some beneficial effects. And so these are the proposed mechanism of action. The decrease after an acute coronary syndrome, decrease in infarct size, and also it reduces inflammation, endothelial dysfunction. I think I can skip this. Now coming to the patient with renal disease. So you see another patient, 65-year man, who is referred for diabetes management, and he's obese, has a BMI of 34, GFR 40, is currently on glipizide, metformin, and basal insulin. He has A1C 8.1%. But his main concern is the weight gain. He doesn't want to gain any more weight, because what happened was when the insulin was up titrated, he started gaining more weight. So what do you do? What is the next option? Should you still keep going on increasing insulin, add a DPP4, or you add a GLP-1 agonist, and which one to add? Now I'll talk to why liraglutide was preferred. He was started on liraglutide, and after 6 months, the A1C improved, and his weight decreased by about 20 pounds. His eGFR was stable, is not decreased or increased. Now, which one to choose when you have a patient with chronic kidney disease and has diabetes and chronic kidney disease? These are the short-acting GLP-1 agonists. They are renally cleared. So clearly you have to adjust the dose in patient with chronic kidney disease, but you can use them till the GFR falls to about 30. For this long-acting ones, the liraglutide, dulaglutide, albiglutide, and semaglutide, they can be safely used in patient with chronic kidney disease. In fact, liraglutide, you can use it up to the GFR of 15, and same with semaglutide. And not only that, you can use them in these patients, but they have shown to have beneficial effects in patients with chronic kidney disease. So again, short-acting are renally excreted, long-acting are not. So you can safely use them chronic kidney disease, and no dose adjustment required up to 60. But after that, you need to adjust the dose, particularly with exenatide. However, in patient with and they still preserve their A1C lowering efficacy in patients with chronic kidney disease. The renal outcome, clear the studies leader and liraglutide and semaglutide, and now the dulaglutide have also shown that decreased composite renal outcome, that is new onset macroalbuminuria, doubling of creatinine, and all this renal outcome driven primarily by reduction in new onset macroalbuminuria. So overall, there's 18% decrease in renal outcomes in patients treated with GLP-1 agonist. So this patient, after 2 years, you see that the A1C decreased and its sustained decrease. The eGFR, in fact, improved, and the BMI also decreased. So this patient not only decreased the weight, but also preserved the eGFR. So another patient just showing that is on very highly insulin resistant, A1C is high, is very high dose of insulin, and he was started on liraglutide. You can see the insulin dose almost halved after 6 months, and the BMI also decreased. So this another class of patient you can use the GLP-1 agonist. Patients who are non-diabetic, who are obese, and have a strong family history of diabetes. The studies here the liraglutide showed that non-diabetic obese when treated them with liraglutide because significant weight loss and prevent progressive new onset diabetes. Again, this is a study on showing the effect of patient with liraglutide on patient with impaired glucose tolerance. Clearly on the top panel, so that there's reduced incidence of progression to type 2 diabetes. The blue line is patients on placebo, or red is on patients on liraglutide. And here you see the fasting glucose. There's significant reduction in fasting glucose when you treat patients with liraglutide. So the safety and tolerability of this GLP-1 agonist, clearly this is on the left side, the short-acting ones, and they have seen about 30% will complain of nausea and vomiting. The key is that you start slow, go with low dose, then slowly escalate the dose. There's not much difference between short-acting and long-acting, although short-acting ones thought to be more incidence of nausea and vomiting much higher in patients with short-acting. And hypoglycemia, if they are not on insulin or sulfonylurea, the rate of hypoglycemia is very low in patients treated with a GLP, regardless of the short-acting or long-acting GLP-1 agonist. So now always you get questions from patients like, what is the risk of pancreatitis or pancreatic cancer? Now there's, as of now, based on current data and pooled data for about 60,000 patients have shown that this GLP-1 treatment is not associated with increased risk of pancreatitis or pancreatic cancer. Again, the safety and the convenience of this, all these agents, so in terms of glucose lowering effect and the weight lowering effect, the semaglutides presumed to be most potent. And they're almost similar efficacy in terms of glucose lowering, liraglutide, dulaglutide, semaglutide, or oral versus injectable semaglutide. So how do you select patients, which patient to start them on a GLP-1 agonist? It can be started as monotherapy, although we recommend to start metformin fast, but you can start directly on GLP-1 agonist. You can combine them with the thiazolidine-dan, SGLT2 inhibitor, or insulin, and preferably patients with pre-existing heart disease, and particularly in patients who have hypoglycemia, particularly patients with commercial drivers, and you cannot use insulin. Instead, avoid using GLP-1 agonists in patient pancreatitis, gastroparesis, or I think this is the last slide. So these are the patient group we prefer to start on GLP-1 agonist: obese patient, middle-aged patient with recently onset diabetics. So to summarize, GLP-1 agonists improve glycemic control and they reduce body weight without inducing hypoglycememia. And not only they improve glycemia and body weight, they also have cardiorenal protection. They reduce the rate of cardiovascular events as well as renal outcome. So in my opinion, this should be more widely used than being currently used because of all these beneficial effects. I think that is my last slide. Thank you.
Thank you very much, Dr. Tripathi, for that awesome lecture. And I think we've had a very beautiful overview on GLP-1 receptor agonists. So just talking about this, the GLP-1s primarily reduce the atherosclerotic outcomes. When you compare it to the SGLT2 inhibitors, you have the heart failure outcomes as well. And when you look at the renal benefits, they are primarily little less with the GLP-1 receptor agonists versus the SGLT2 inhibitors. So if you look at the US, you look at, no, it's not my kutta. I don't have a dog. Okay. So the thing is, when you talk of the ADA algorithm, don't you think the demarcation should be clear that, you know, if you are looking at atherosclerotic cardiovascular reduction, the first choice is GLP-1. And if you're looking at an heart failure or a renal reduction, the first choice should be SGLT2s. Shouldn't there be a more demarcation in the algorithm then?
So I think, yeah, the patient you suspect, because you can see if you're the SGLT2 inhibitor data and the GLP-1 agonist, so in SGLT2 inhibitor, you see the cardiovascular benefit within few months, but a GLP-1 takes at least a year or two to show any benefit. So it's clearly that patient, different mechanism acts on those. I mean, it should be clear that patient with suspecting atherosclerotic heart disease, you should start them on GLP-1 rather than SGLT2. But if you have heart failure, then of course you should go on there.
That was the reason, possibly the discordance between the MACE and the heart failure being one of the reasons why people suggested GLP-1 use should be restricted to primary prevention in diabetics, while those with established heart disease, it may be there's GLT2, which will be of use.
No, actually, for secondary prevention, if the patient do not have heart disease, you can, GLP-1 has shown to be, all the studies have consistently shown that they're of definite benefit. And there is no head-to-head trials comparing GLP, but if you look at the hazard ratio, this is kind of similar if you have atherosclerotic heart disease for secondary prevention. So I mean, but in fact, the primary prevention, the data is not yet clear, but I think if you do long-term, you need longer-term studies for primary prevention, and none of the companies are willing to do that. So there is a study actually they're planning to do now, and which look at primary prevention with semaglutide. I think that will provide data. If you do more than 5 years, then it will definitely show evidence that the GLP-1 agonists have better effect on primary prevention.
Dr. Chilton, I hope you are around.
Oh, I'm here. I'm listening.
Okay.
I listened. The last two questions are really important to me. To me, there is no primary prevention. Everybody is secondary prevention. All of you have heart disease. So this primary, secondary, you're just simply raising the risk, whoever's the highest risk. But I have really liked Dr. Tripathi's slides, because I think what it shows you is that GLP-1s don't do much for ischemic disease, but neither do SGLT2s. The SGLT2s do help heart failure, but the thing that GLP-1 to me, you guys have to correct me if I'm wrong. The thing I want from GLP-1 is I want a positive, a drug that is at least neutral for the heart, which it is. It's a kind of a positive inotrope. But I want you to lower my weight. I want weight reduction. And if you don't get weight reduction, I don't know that we're going to win anything. You can lower glucose, but that weight has to come down, because that gives me blood pressure, wall stress, everything. But I don't get that same weight loss with SGLT2. So to me, the ace in the hole is you got great weight reduction with semaglutide. That to me is incredible. You take a patient from surgery, if this guy doesn't lose his big belly, he's going to be back. You got to lose that weight. And I think semaglutide or something like that, any of the GLP-1s give me that advantage. But for stopping a heart attack or acute coronary syndrome, they don't work. And the inflammatory part of SGLT2, even with that and GLP-1, you don't see any heart attack reductions, non-STEMIs, very little. It's mainly other than that. And to me, the weight loss is enormous. I'm just one for the weight loss. It helped Ken's liver.
Let us hope the comparative trial will shed some more light. Dr. Chilton, you mentioned about the forgotten, cost-effective cardioprotective drug of glitazones, pioglitazone especially. What do you think its prospects in amongst the SGLT2 and the GLP agonists?
Oh, the GLP-1s and the SGLT2s to me, and again, you guys are endocrine guys. To me, you got a better drug for skeletal muscle sensitization. Skeletal muscle improvement is probably better with PIO-like drugs. The liver is great, but the liver probably improves with anything that you can lose weight, but the SGLT2s look really good. Independent from weight loss, then I think PIO has a real advantage. I've seen the stuff in the coronaries because we did that. The carotid, I have nothing for GLP-1 and nothing for SGLT on actual removal of cholesterol and decreasing carotid atherosclerosis. PIO wins, hands down. If you add statins to PIO, it amplifies its actually anti-inflammatory effect. So PIO to me, still at low dose, is a really big drug. SGLT2s, though, is right behind it. And I always like GLP-1 because when we did those pressure volume loop curves in the left ventricle, when you use Mylar catheters, it shows it has a pre-ischemia protection. Post-ischemia, let me give you an example. If I close your coronary with a catheter for about 15, 20 seconds, I blow the balloon up, no blood down the front wall. It takes 15 seconds for the SC segments to get as high as the R wave. If I then give you intravenous 736 exendin 4, it will take 30 seconds. So what I have done, I have preconditioned your heart. You get that with GLP-1. It has a special thing for that. But of course, you can't study that very easily. But Dr. Tripathi's comments on his drug, I really like GLP-1. But when it comes down to just stopping events, not so much, but protecting the heart during ischemia, it's probably pretty good.
Dr. Tripathi, you have a question from one of the panel. What is the role of GLP agonist in pre-diabetes?
Yeah, I just showed you the data that this data only with liraglutide, it decreased the prevention of conversion from pre-diabetes to diabetes by more than 70%. And here's now this drug called Saxenda, liraglutide 3 mg, is approved for treatment of non-diabetic obese patient in the US. And if you use that, I think it has not only weight loss, it will prevent progression to type 2 diabetes. We do not have the cardiovascular data in non-diabetic individuals yet, but there is a study now going on. It's called the SELECT, which is looking at effect of semaglutide in non-diabetic individuals for secondary prevention. So I think that will, and in my opinion, is one of the most potent drugs for prevention of diabetes. If you treat with particularly there is data on semaglutide and liraglutide. In
Sir,
fact,
what
you can
is
use any of the GLP-1 agonists because they do not cause hypoglycemia and induce weight loss.
Sir, do you think that after the DAPA-HF trial, the role of SGLT2 inhibitors also will come in a big way for the prevention in the pre-diabetes?
I think it will, yeah. I mean, both the SGLT2 inhibitors and the GLP-1 agonists will definitely play a role in prevention of type 2. I am not aware of any data yet, but I think in long term, there will be definitely studies looking at the effect of SGLT2 inhibitors as well as GLP-1 agonists.
Bob, let me ask you a question, Dr. Tripathi.
Yes.
How would you compare beta cell preservation or protection with all these drugs that we have? Which one's the best one to save my beta cells from dying early?
Okay, so as of now, the best data, at least in animal models, is with the GLP-1 agonist. There has been showing that it causes pancreatic beta cell neogenesis. However, it's shown in animals. In humans, what happens, there have been studies in which what you do, you treat them with GLP agonist. The problem is as soon as you stop this medication, your beta cell function goes back to what it was before. So as long as you continue treatment with them, it does not depend for the decline, but it preserves whatever is there. So, I mean, of all this class of drugs, I think the GLP-1 agonists are one of the most potent preserving beta cell function as of now.
Oh, good. Okay.
Dr. Shilton, I have a question. Dr. Tripathi, you can also take this question. All these cardiovascular outcomes trials actually came out and showed us the pleiotropic benefits of all these different newer agents for anti-hyperglycemia treatment we have today. Because, you know, the US FDA mandated the CVOT safety has to be proven. Now that they have said, no, it is not necessary, don't you think the issues of heart are still important? Should it have been taken back the way the US FDA has taken a U-turn on this issue?
I agree. I mean, Dr. Chilton comments. The thing is that when it first came out, we thought it was such a waste of money, and because this can be better utilized in other other studies. However, if we did not do these studies, we would not have found out the beneficial effect of these drugs. So I think it should not be mandated, but all companies should do it anyway to see long-term effects, because otherwise you would not have known the effect of liraglutide, semaglutide. Now they have cardiovascular indication, both GLP-1 agonists as well as the SGLT2. In fact, cardiologists are prescribing more of these drugs now in here.
So it's basically science losing out to the money part. Is it just that?
Not really. No. I mean, I think Dr. Chilton will comment on that maybe.
Let me tell you, if I was spending money, I totally disagree with doing some of these big money-making trials. I would spend my money on the basic science stuff because that's where you get ahead. To do these big trials, there's so many confounders, the genetics and et cetera. Of course, most of us are in the basic lab, but if you don't spend money on the basic sciences, you hurt yourself 20 years down the road. You don't know what's going on. You need that basic data. That's what we're not doing. We used to do 20 years ago. You can do the big trial, but you need to really hone it in. And the way you do that is find out what is the basic science telling me, and then I'll do it. But I wouldn't do the big outcome trial first. You don't even know how the drug works. That's what these guys are doing. And then if it doesn't work, well, it's not any good. That may not be true. You know, there's things we find. And again, the example being canakinumab, which was used, actually Paul Ricker's study, it decreased lung cancer 50%. We didn't know that.
And we also know about many of the DPP-4. DPP-4 has an anti-inflammatory function, but it was neutral to the cardiovascular effect. So we need, even though it may not be doing the extended CVOT trials, but we need data.
Yeah, let me comment on that. The DPP-4s, everybody throws those out with the water. You know, if you look at the animal data, you run it long-term, do you know that ventricular performance improves, but it takes 3 years. No one did a 3-year trial. The other thing is aortic stenosis. 3% of the entire US population has aortic stenosis. We're putting in valves. How would you like to have a drug that decreases the calcification of the aortic valve? Well, DPP-4s in our animal studies do that. Do you think anybody wants to fund it? No. But if you decrease the progression, it does. It's interesting.
Shalini, you can, if you have exhausted the question, you can conclude, Shalini.
Sure. So I think Dr. Rajiv Chawla is raising his hand. So is Dr. Amalia, and I see Dr. DeFronzo has joined. So I just want to give a chance to those people also. So Dr. Chawla, please.
Yeah, good evening, Devji. Just an excellent lecture. Stayed back to say you hello and hear from you directly. Just a brief comment. When we are talking of cardiorenal continuum these days in practice of type 2 diabetes, and we know both the drugs, GLP-1 analog or SGLT2, they have different mechanisms to address to. GLP-1 primarily working through atherosclerotic mechanism, and SGLT2 inhibitor reducing intraglomerular pressure and all other benefits which are hemodynamically mediated. So are these two agents, as Dr. Shalini very rightly said, in an algorithm of ACE or AD or any other algorithm, interchangeable? Because we combinedly say that when you need to address cardiorenal continuum, you use GLP-1 analog with evidence or maybe SGLT2 inhibitor. I'm sure that now is the time that we should address them differently, because both have different mechanisms and they are going to sort of address to cardiorenal continuum in a different way. What do you say?
I agree that the mechanism of action of how GLP-1 inhibitors improve renal outcomes not very clear.
Yeah.
And the majority of the effect is driven by the reduced incidence of macroalbuminuria.
Yeah.
Whereas SGLT2, they have shown to have preserved the decline in GFR. Not many studies of GLP have shown that. So I think they could be complementary to each other. If you combine, I don't know, there's not many studies that looked at renal outcome to combine GLP-1 with SGLT2. But definitely, patients with advanced kidney disease and heart failure, I think I would prefer SGLT2 inhibitor than GLP-1. However, patients with atherosclerotic heart disease, who have, I mean, most of them do have some kind of kidney problem, they can GLP-1 will be a better agent. And the mechanism of action, how it does, in particular, the GLP-1 agonist renal outcomes is not very clear. A lot of animal studies, they have been shown that there is GLP-1 receptors in the kidney and the vascular endothelium that could be playing a role in vasodilation, but we don't know exactly. A lot of animal studies, in the human study, I am not many aware of GLP-1 effect on kidney.
You know, the comment
is also with us. Dr. DeFronzo is with us. So welcome, Dr. DeFronzo, and we would welcome your comments on the discussion going on, GLP-1s and SGLT2 inhibitors and the heart and the cardiorenal benefits.
I'm here. I don't know. Can you hear me? Someone tell me you can hear me.
We can hear you.
Oh, yeah.
We don't
Okay.
see you.
So I think it's strange that I'm here in San Antonio and I never see Dr. Chilton, Dr. Tripathy, and I have to get on this stupid virtual communication to see my friends here in San Antonio. Shows you what the state of affairs is.
COVID-19.
It's safe to be at home and talk to people on the TV, so to speak. Also, I have to say I'm pretty embarrassed to say that I actually turned this computer on all by myself. I'm sure that Nick and Bob will never let me forget this day.
Oh, I will write that down.
It'll be marked on the
We need to see
calendar.
you, Dr. DeFronzo. You need to show us your face. You need to turn the video on, though.
Oh, it's scary. I don't know if he will.
But now, wait a second. Wait a second. Start video.
Where?
Did that work?
There he is. Yeah.
Hey, that's it.
Oh, now I'll never live this down.
Oh, man. That's great, Ralph.
Yeah.
Do you have any expert comments? Because we have Dr. Samir Kapadia already here with us, so we don't want to delay him too much for the next session. And then you have your own session at the end, of course. So
Yeah, so I mean, I think that the comments that Devjit and Bob have made have been really, really quite on. To me, these drugs are all beneficial, but they have somewhat different effects. I would say we still really don't know how the GLP-1 receptor agonists work in terms of cardiovascular protection. And also, if you look at the individual MACE endpoints, to me, it's very clear that the GLP-1 receptor agonists seem to have a pretty significant effect on stroke, whereas the SGLT2 inhibitors really have no effect on stroke at all, which is quite surprising since the SGLT2 inhibitors lower your blood pressure. And I have a feeling that someday when we understand these drugs better, we'll kind of tailor them to the needs of the patient. So maybe people with stroke should be on a GLP-1 receptor agonist, but clearly the best drug for stroke is pioglitazone. I mean, the IRIS study has shown us that. Yeah, see, Bob agrees. And it has nothing to do with lowering glucose. Whereas for kidney disease, it's very clear that the SGLT2 inhibitors are the superior drug. I think it really remains to be seen what the effect of GLP-1 receptor agonists are, because most of the data we have, when you look at the renal composite outcome, is based on changes in proteinuria, and particularly microalbuminuria. And we know that albuminuria is not a good risk factor for renal disease. So I would say the story is still out on whether GLP-1 receptor agonists have a significant effect on kidney disease. And then clearly for heart failure, the SGLT2 inhibitors are the drug of choice. And the one thing that we don't know, and the only group that I think will ever get these studies done is the NIH, is what about combination therapy? And just to come back to the point that Bob made about weight loss, the semaglutide is blockbuster. When you start losing 10, 12 pounds of weight and you get rid of fat in your aorta, that's good. You get rid of it in the liver. And, you know, Dr. Kuzi has shown that's great. Devjit has shown studies when you get rid of it in muscle, you improve insulin sensitivity. And when you get rid of it in the beta cell, you improve beta cell function. So weight loss is very good. And, you know, the strange thing is with pioglitazone, and I say this all the time, while you may gain weight, you're actually losing weight. So what people don't appreciate is that you're mobilizing fat around, and you mobilize fat out of the liver. It's the best drug we have for treating NASH. You mobilize fat out of arteries. It works in cardiovascular disease. So, you know, from my standpoint, these are all excellent drugs, and we need to learn to use how them in combination. And that's probably going to take the NIH to fund these kind of studies. I don't know, Bob, what do you think?
Yeah, I think so. And, you know, Ralph, I think the thing that all of us are missing is the kidney is a huge thing here. If you look at all these drugs, if that kidney goes south, you are going to lose the patient. I don't care what you do to the heart. All these trials have such an impressive ability, especially SGLT2 on the kidney. But I agree with you. You're going to have to get the NHLBI to do it, because the drug companies are not going to fund a trial that they run risk on. It just won't happen.
You know, I think we're starting to see some light. We have ACEs and ARBs, and we know that when you add the SGLT2 inhibitor to the ACE and the ARB, you get a completely, you know, beneficial effect. So it's an additive effect. And now we just had the study from Bayer where we have a mineralocorticoid receptor, a very positive study. We haven't seen all the data. We'll see what happens at the NIH. So we're starting to see drugs, and if you stay tuned, I hope that there'll be a paper in Nature Nephrology soon where I've gone through the pathophysiology of diabetic nephropathy and elucidated that there are at least 11 very important causes. So I think it's a mistake that we've focused on the hemodynamics, because that's just one part of the story. There are many, many other etiologic factors here. And again, I think what we're going to see for diabetic nephropathy is we're going to see combination therapy. And we're now starting to see different drugs that are being developed. And we have two for sure. And maybe the recent data with the mineralocorticoid receptor agonist, if it is as Bayer says, I suspect that'll get approved. And then we're going to have to learn how to use these drugs in combination. But I agree with you. If you develop kidney disease, you're in big trouble.
Yeah.
Cardiovascular disease goes up threefold in people who have kidney disease. Yeah. So this is a disaster, not only for the kidney standpoint, it's a disaster for the heart.
So thank you so much, DiFronzo, sir. We've had.
Can I make a comment to Devjit? So Devjit did this study, okay? Called the Act Now study. One of the co-PIs. And he didn't point out that pioglitazone has a great effect to preserve beta cell function. I know he talked about GLP-1 receptor agonists, and I agree with everything, every single thing he said. But Devjit, why don't you tell people about your study?
Yeah, okay.
So,
we will have to save it for another session, so we are not running out of time. Sorry about that.
So I just have a small comment, like somebody asked for when Amalia and Nick Kenkusi study that low dose pioglitazone. In fact, we did another study with Dr. Foley that with 7.5 milligram pioglitazone was actually reduced inflammation and had improved insulin sensitivity. So you can use very low dose pioglitazone also for treatment of, to improve outcome for diabetes or NASH. Yeah, thank you.
So thank you very much, Dr. Devjit and Dr. Robert Chilton. We've had a very stimulating session, and I'm sorry we're short of time, so we need to move on to the next session, and I hand it over back to the organizers for the next session. Thank you very much for being with us.
And I would like to thank Dr. Tripathi and Dr. Chilton, again, both my professors. It has been wonderful and stimulating.
Thank you.
And we'll hand it over now to Dr. Goyal to call the next few chairpersons for the next session, please.
Let's move on to the next keynote lecture by Dr. Kapadia, PCI versus CABG in diabetics. For that, may I invite, I'm honored to invite Dr. A.B. Mehta, sir, the past president of CSI, the Padma Shri Awardee winner of Padma Shri Awardee and a senior most cardiologist in India from Mumbai. And also Dr. Sanjeev Pathak, he's a senior diabetologist, director Vijay Ratna Diabetes Center in Ahmedabad. And Dr. Rasmit Pandya, senior cardiologist from Apollo CVHF Ahmedabad. Mehta, sir, please carry on the sessions. Hello, Dr. Mehta, sir. You need to unmute. Yes, sir.
I'm muted by the host.
Sorry. Please, sir.
All right. Okay. So can you hear now or?
It's audible, sir.
It's audible?
Yes, sir.
Loud and clear?
Please.
Okay, fine. It's been a special privilege to be able to chair Dr. Samir Kapadia's special lecture on PCI versus CABG in diabetic patients. And Samir has been the chairperson of Robert and Susan Tomschick Department of Cardiovascular Medicine at Cleveland Clinic, professor of medicine at Cleveland Clinic, Lerner College of Medicine at Case Western University, and he is now taking a special interest and a bias in structural heart disease. And to his credit, about more than 1,000 TAVR procedures, and he's a remarkable person. I should say to all those people who are young in this audience that Samir has been born and brought up in Ahmedabad, Dr. R.M. Kapadia's son, and I have known him when I've gone to Cleveland Clinic several times, when I've seen him growing from a status of a fellow when he was working with Eric Topol. And at that point of time, Eric Topol, a friend of mine, and when I would talk about him and he would speak in a absolutely superlative language about Samir Kapadia, and Samir has come in a big way. He's a name to reckon with, and I'm also happy that the subject on which he's going to talk now on PCI and CABG, that so far, to the best of my knowledge, things are favoring CABG in type 2 diabetes. Particularly, it's important to note that 40% of all our patients who are undergoing multi-vessel treatment, interventional treatment, have diabetes. And this is, I think, very important. And I'm happy to let you know, Samir, that I participated in Freedom Trial. We were one of the participants in that, and also I'm sure that you will also add a word that for those people in whom surgery for some reason or other is not possible, can that be compared with the aggressive medical management, and would that make any difference in the outcome or otherwise? So I'm really very, very keen to listen to your talk, like everybody else in the audience. Samir, the mic to you now.
First of all, thank you very much for the kind introduction. Of course, just like you, can you hear me now?
Yes.
Yeah, it is my great pleasure to join you. And as you said that, I have been connected with Cleveland Clinic, but also very intimately involved with India. So this is a great pleasure of mine to participate in this particular symposium. I'm also very close to Samir Dani because we went to the same school in India and also to the same medical school. So thank you, Samir, for inviting me. I want to give a little presentation and as you will see that it is a fairly balanced presentation about the PCI as well as for the cabbage. First of all, I want to say that why it is important that we are studying the cardiovascular outcomes in diabetes. The most important thing is that it is a high-risk situation. So if you have diabetes versus you don't have diabetes, the cardiovascular death, MI, and stroke are almost twice as much compared to people who do not have diabetes. So this is one of the important things to keep in mind, that when you're treating diabetics, you're treating high-risk patients. And that has been shown in several different small and very large registries to say this is from the REACH registry for 20,000 patients, again showing that if you have atherosclerosis and diabetes, your risk of events, of having future events, including death, MI, stroke, is extremely high. Now, if you go back in time, so this is now going back in time. So this is in 1988 to 91. This was the first study I'm sorry, I just move it down a little bit, my monitor, so you can see my monitor so you don't block the things. Okay, so here you go. So if you look at the Berry trial, so this was done in 1998 to 91. And the Berry trial tried to compare the PTCA with cabbage. This is balloon angioplasty. This is before the time of stenting. And as you can see, there are 1,000 patients in each group, cabbage versus PTCA. And if you see the overall survival, amazing. At 10 years, the survival is 73% versus 71%. So cabbage and PTCA, we are not talking about stenting. There was no difference. And then if you look at the diabetics, so this is all patient population, and the diabetic small population. So if you see diabetics were 170 patients in each group. So compared to the 1,000 patients, small population. And if you look at the diabetics versus non-diabetics, you can see that there was a difference. So 60%, 57% versus 45%. This is survival. So this led to a lot of commotion to say that, well, the diabetics are special and they should be treated. Again, to understand the diabetics are high-risk patients. So if you are going to do something, you will see the difference. So that made somewhat of a sense that revascularization in diabetics was important. That led to a second trial almost a decade later. So this is, as you can see, from 2001 to 2005. Now, this is a trial. This is not randomizing cabbage versus PTCA. This is randomizing a medical treatment versus revascularization. And the revascularization can be either by PCI or cabbage, 2 strata. And of course, they had another randomization versus of insulin treatment versus no insulin treatment. Now, if you look at this, amazing. So if you look at this, you can see that revascularization versus no revascularization, almost no difference. 5 years outcome, 2,000 patients. And if you look at insulin sensitization, I'm not going to talk about, but if you look at the freedom from death, MI, and stroke, again, not much difference at all between medical treatment and non-medical treatment. So they concluded, this is in New England Journal, they concluded that there was no major difference in revascularization versus not. However, if you look at now, looking at the PCI stratum and cabbage stratum, so if you look at the PCI stratum, no difference again, 78.9% versus 77% event-free survival, and death rate, if you look at it, it is 89% versus 89%. However, in the CABG group, overall survival was no different. But if you look at the death, MI, and stroke, MI were more prevented by CABG. And so that's what you found, 77 versus 69%. And this was statistically significant. However, keep in mind that this is in 2001 to 2005. Remember, in the United States, the drug-eluting stents became available in 2003. So 35% of the patients received drug-eluting stent. Only 35, 1/3 of the patient. 56 BMS and no stents in 9% of patients, because still some people were believing in provisional stenting. So then came the Freedom trial that Dr. Mehta was alluding to. And this is a trial, again, almost a decade old now, from 2005 to 2010. 2005 to 2010, just the beginning of the drug-eluting stent era. And there people got the DES versus CABG. And these are the patients who were, again, eligible for both stent and surgery. Very good primary outcome, mortality, non-fatal MI, and non-fatal stroke. So well-conducted trial, published in New England Journal in almost, again, a decade ago. Very important to recognize that out of 33,000 patients that were screened, 10% were eligible, and out of this 10%, 50% were enrolled. So we are talking about 5% of the people, or close to that, coming from the overall population that were randomized. Stents, sirolimus stent in 51% of patients, and paclitaxel stent in 43. So this is Cypher and Texas stents. So these are really, first generation, or some people may say second generation, whatever, first generation drug-eluting stents, in my personal opinion. And if you look at the outcomes of the patients, again, if you see this, the primary outcome, again, good primary endpoint, death, myocardial infarction, and stroke. If you look at it, PCI versus CABG, CABG was better, and the event rate was 26% versus 18% at 5 years. So again, a reduction of about 6% reduction in the overall primary outcome. And if you look at the death, there was also a 6% reduction in overall death. As you see, the death did not change until about 4 years. And then between 4 and 5 years, there was a change. If you do landmark analysis, there was difference from almost 2 years out. So it took about 2 years before we saw the data. But again, as you can see, the p-value is very marginally significant at 5 years endpoint. 3.8 years was the average follow-up in this particular group of patients. Syntax score, as you probably know, as many of the interventionalists, of course, know, that the syntax score is a way to measure what is the complexity of the disease process, meaning that how complex is the disease. That's what determines the syntax score. And if you look at the syntax score, you can see here that the lower syntax score, which we classically say is less than 22, this lower syntax score is the people who did particularly well. Intermediate syntax score has some difference, and high syntax score has even more difference. Again, if you look at it, very important to recognize that in multivessel coronary artery disease patients, 600 patients were low syntax score patients, 800 were intermediate syntax score, and 400 patients were the high syntax score patients. So again, fairly large number of patients were low and intermediate syntax score patients. And this is important to recognize that it is not true that most patients who present with diabetes have high syntax score. And however, so the first slide I showed you was death, MI, and not including repeat revascularization. But if you look at the repeat revascularization, it is still very different even at the low syntax score, intermediate syntax score, and of course at high syntax score. There is a competing risk here with the high syntax score of death. But the idea is that revascularization is definitely going to be higher if you do PCI compared to CABG at any syntax score. And that is understandable because the restenosis risk still exists in this patient. And this is, remember, again, the first generation stents. Now there is an 8-year follow-up that they recently published from this particular study. And again, if you look at the probability of survival, just dying or living, it was different in the PCI compared to CABG. PCI was less compared to cabbage. And as you can see, the survival difference is about 6 to 8% in that group. So why is cabbage better? So the most important reason why people say it's better is because it treats not only the proximal artery, but it's not just one lesion, but the entire length of the artery that is you're treating, because you're bypassing the artery. However, there are several things that are important to recognize, that as the whole symposium is on treating the patient. So it is better to treat the proximal segment rather than a lesion, but it is best to treat the patient. So the patient is very important. So treating the patient is crucial. So how good is the medical treatment is a very important part of the message. Bypass grafts, especially if you're vein graft, so there's a vein graft and there is an arterial graft. The vein grafts may not last as long, and I'll show you some data for the 10-year from Syntex. And then the acute closure of the vein graft is difficult to treat whenever it happens, because again, there's a large thrombus burden, especially because they don't have branches and they're very large in diameter. So there is another study, contemporary study, which was a Syntex trial. Syntex trial was a trial where again, patients were randomized to to cabbage versus Texas stent. So again, first generation drug-eluting stent, the Texas stent versus cabbage. And they were stratified according to the left main disease and diabetes. So diabetes was part of stratification in this particular trial also. And there were 1,000 patients in each arm. We will not talk about the registry, so we'll just talk about the cabbage versus Texas. And if you look at the diabetic patients, so this is also important information to keep in mind, that if you take non-diabetics versus diabetics, diabetics were about 400 patients, 1,400 were non-diabetics. So it is a relatively small group of patients compared to the Freedom trial. So that one has to understand. And these patients are 65 years of age, not 80 years of age, because many of the times when patients present to us, we are looking at 80 years of age patients rather than 60 years of age patients. And so it is important to recognize, both for the Freedom and for the Syntex, that they're relatively young patients that are undergoing these revascularization strategies. If you look at their HDL in the diabetics was low in many patients, and their triglycerides were high. And if you look at their Syntex score, it's not that different. It is 28 versus 29. And 1, 2, or 3 vessel disease was also not that different, although statistically different in the 3 vessel disease. But again, numerically, it is not that big a difference. So these are patients very similar. My point of saying this is that when you see diabetics versus non-diabetics, even though the disease pattern is different, the diffuseness of the diseases may be different, again, 10% versus 13%. In these trials, these are relatively focal lesions that were treated, or at least were identified. Now, if you look at the graft failure of the Syntex trial, so if you look at the saphenous graft failure, it is 50 to 60% at 10 years. If you look at the internal thoracic artery, means Lima graft failure, they are patent in 85 to 95% of time. So it is again important to recognize that the vein grafts don't last as good as arterial grafts. And there were some gastroepiploic grafts that did not do as well. What is the 10-year outcome of the Syntex trial? So this is a 10-year outcome in the Syntex trial, also reported relatively recently, almost a year ago now. But the idea is that the PCI versus cabbage 10-year follow-up in diabetic population, again, as I said, relatively small group of patients compared to the Freedom trial, but there was a difference at about 2 to 7 years, but there was a catch-up over time. Again, probably because of the vein grafts. There is not a lot of information on how the catch-up happened, but at least in the manuscript, they suggest that this may be related to some form of graft failure. If you look at, however, if you look at the total group of patients, the total meaning that entire group of patients, PCI versus cabbage, 28% mortality versus 24% mortality at 10 years. So again, important to recognize that the mortality is 1 to 2% per year, and maybe 2% per year. And you can say that it goes to about 25 to 30% over this group, this period of time in 65-year-old patient. If you take diabetics, there was a difference. If you take non-diabetics, it looks like that there's almost no difference in the mortality. Again, So there is a difference between diabetics and non-diabetics. The overall mortality is also higher in diabetics. If you look at the syntax score in the syntax study, so this is not the freedom study, but the syntax study in the diabetic population, if you look at it, less than 22, 23 to 32, low and intermediate syntax score, how complex is the disease? There was no difference in mortality. So this is the chance of dying. There was no difference in mortality. The mortality only changed when the lesions were very complex. And again, to keep this in mind, that this group of people are a relatively small group of people who are followed. And they did a multivariate analysis to say that did diabetes matter or not in that particular analysis. And in that particular analysis, it didn't. Triple vessel disease or syntax score more than 33 mattered, but diabetes per se did not matter in that particular analysis. And they discussed that in their discussion, saying that this is a little bit different than in the freedom trial. How about if you look at the courage, Berry 2D, and freedom? An interesting part to say that if you look at the patients who had CKD, kidney disease, and try to see what would be the outcomes on people who had no kidney disease and had PCI. And if you take the patients with no kidney disease and PCI, as you can see, their outcomes are relatively similar to the bypass surgery patients. So these two are the bypass surgery patients. The outcomes get much worse if you have CKD and do PCI. So how do we decide PCI, CABG, or medical treatment? So the first important thing is to understand that do you really need revascularization or not? And recently there is a trial, the ischemia trial, and I'll talk to you about that just a few slides. Assessment of risk and opportunity for risk factor modification. I think this is a very important piece to know that if the lipids are high, people are smoking, if the diabetes is out of control, obese, this is a big opportunity for risk factor modification. So that outcomes will be much different if you address this rather than addressing the coronary artery disease, which is a consequence of these risks rather than the real cause of their problem. And then the mode of revascularization. So you, of course, pay attention to complexity of disease and complete versus incomplete, and I'll come to that in a second. And then, of course, the patient expectation, the financial expectations, economic expectations, and of course, the quality of life and what really they want in the future. So if you look at the ischemia trial, this is a trial that compared people who underwent PCI or revascularization versus no revascularization, depending on if they had a positive stress test. And they ruled out left main disease by most commonly by doing a CT angiogram. And if you look at this, the primary outcome was very interesting, that there was no difference, at least at 5-year follow-up, although it looks like the curves are separating and the long-term follow-up is not yet published because this is a relatively recent trial published this year in New England Journal, end of last year. So if you look at the ischemia study subgroup analysis, very interesting thing to keep in mind that diabetes or yes or no, they did not find a difference. So this is very, very similar to, in some ways, the overall Berry 2D trial, that there was not that much of a difference in terms of looking at revascularization versus not in diabetic patients. Interesting part is that when do you really want to revascularize patients? So if you say ischemia trial says that no revascularization is necessary, well, it is not true because there are several trials that say that if you have some better ways of judging functional significance of a lesion, you may be able to classify people of having proper revascularization. So FAME was one of the trials, not necessarily diabetic patients, but these are the patients who have medical treatment versus PCI, and they did FFR, measurement of fractional flow reserve in this patient. And the primary endpoint was different compared to people who had medical treatment, and it's mostly related to need for urgent revascularization. That is not likely because these patients typically do not die, and the risk is less. Syntax 2 is an interesting trial. So there again, they're using a Synergy stent, which is a newer generation drug-eluting stent. It is IFR, FFR guided, IVIS guided. Again, multi-vessel angioplasty. and the syntax score is on the lower side. And the interesting part was that you will compare this to the original syntax PCI to say that whether we have improved in the PCI by doing a FFR guided PCI. And what they found was that they had to do less PCIs, less patients were thought to have triple vessel disease, they had to use less stents. All of those were true with this trial. And the outcomes were better. And this included major adverse outcomes and cerebrovascular outcomes, including revascularization. But again, the major outcomes were better. So compared to the initial trials, we are getting better in PCI and selecting the patients appropriately. If you go to the complete versus incomplete revascularization, it is also very clear that not all the patients undergo complete revascularization, whether it is PCI or whether it is coronary artery bypass grafting. This is from Syntax, BEST, and pre-combat. This is patient-level analysis done in all these trials. And if you look at the comparison of people who had complete revascularization versus CABG with complete revascularization, the PCI outcomes were very similar to the CABG outcomes. So one of the things to another point to keep in mind is that if you are going to decide between CABG and PCI, you have to make sure that you are going to have complete revascularization as you would have with bypass surgery. And okay, again, as I said, the complexity is very important. And the final part is that opportunity for risk factor modification. I think the diabetes, as you have learned, very important that what is the glucose control that will determine the ultimate outcomes. So it is very crucial to have better diabetes control. Lipid control is very important. There are several different ways that people have. This is one of the articles to say that it is also responsibility of a cardiologist to take care of their glucose control, the new medications, and how we utilize them. I want to just very briefly point out the antiplatelet agents and anticoagulants. There are several different pathways, and many of you know this very clearly, that there is an ADP-related pathway, there is thrombin-related pathways, and there is thromboxane-related pathway. This is the different ways that platelet is activated. It's very simple. And if you are going to use the diabetic patients, if you look at the CURE trial where the clopidogrel was used, you can see that the diabetes patients crossed the unity line in the sense that there was some variability how clopidogrel was helpful or not in diabetic population. You would think that it would be even more helpful because they're high-risk patients, but there was some variability in the diabetic patients. So that led to the idea that maybe the newer P2Y12 inhibitors may be better. The reason is that their bioavailability is better. Their way that they act on the platelets is more reproducible. And this is from ticagrelor trial, the Themis trial that was recently published. Again, the overall outcomes were better. If you look at the diabetic subgroup in Triton or in Plato, again, both of them show that the prasugrel or ticagrelor both have better outcomes compared to clopidogrel. And if you look at the low dose versus high dose ticagrelor, and this is a combined view to say that overall, if you combine them both, they're definitely statistically significant, but even the low dose or even high dose works. Obviously, more antiplatelet agents you use, you have more risk of bleeding. So the bleeding risk has to be determined in these patients, and especially if you are going to add aspirin to these agents. And so there is another very interesting idea is to say that instead of using the aspirin, if you do not use aspirin, so this was the Twilight study that was recently published, and this is a diabetic subgroup of the Twilight study. And if you look at the diabetic subgroup, 1,000 patients in each group, and again, you can see that the bleeding is increased, but is decreased by dropping the aspirin, and both the major bleeding and serious bleeding, both were decreased, and the ischemic outcomes were not that different by dropping the aspirin. So this is one of the ideas, is that if you are going to use ticagrelor, you can drop the aspirin in long term. Another totally different idea, as you know, is the COMPASS trial, again, 4 or 5 years old now, showing that if you have stable coronary artery disease, if you use rivaroxaban along with aspirin, you may have better outcomes. And this was aspirin worse outcomes. Rivaroxaban alone, a little bit better, but aspirin plus rivaroxaban better. Again, there is a penalty for bleeding. So if you look at the diabetic subgroup, so these are the, this is with no diabetes, and this is symptomatic. It includes the bleeding inside of this particular analysis. There was still a difference. And if you take the diabetic patient, the difference is even broader. So difference is even bigger in the diabetic patients, including bleeding, so that you are accounting for the net clinical benefits in this particular analysis. There is this simplistic approach. This is, in my mind, I'm not recommending this. So this is, some people have done this freedom score, for example, and say that, oh, patient one has, what is the chance of having recurrent angina or death or MACE? And then depending on these two outcomes, you can decide which is better. Very simplistic, because this is actually not true. When you see the patient, you are not just looking at this kind of information, and patients don't match up with this particular thing. Here, I want to show you a patient at the end to understand that this is a patient, 80-year-old, diabetes, has a lesion in the circumflex, has a lesion in the LAD, long lesion, you know, it starts from there to there. There is, you know, again, low syntax score. And here you can see that there is a lesion in the right coronary artery, right just before bifurcation. All relatively simple lesions to fix with angioplasty. Some of you may have seen that there is a severe aortic stenosis. So what should be the treatment? CABG or PCI or medical treatment? So most important is the clinical information is needed. So this is an 80-year-old retired neurosurgeon who came to see me. He says that he's active, but has recently been diagnosed with ALS. So if you have ALS and you are 80 years of age, you know, and the guy is super smart. He's a neurosurgeon. First is that expectation is going to be that please treat me percutaneously. I don't want to go through bypass surgery. He did have a recent non-STEMI. That's how it came to know. And his hemoglobin is, you know, A1C is fairly well controlled. His creatinine is 1.6. So he's not totally without CKD. Syntax score is 18, 3 vessel disease. So is CABG better? And as I said, that you may have noticed that the patient also has severe aortic stenosis. So what did we do? And he actually came from San Francisco to see me. So we did do TAVR and with excellent outcomes. And in the same time as doing the TAVR, we stented all his 3 coronary arteries. And these days, this is relatively simple because all the stents are deliverable. So one other important part to keep in mind is that it's not just how well the stents perform, but also that you can do complete revascularization because stents are now deliverable. So what are the conclusions? So that the optimal medical therapy is a very effective tool and should be the primary consideration. So I'm still a conservative person, and I would say that 50% may need revascularization in 10 years. So this is the Berry 2D data. So it is not that first time you say that, oh, you just do medical treatment, that means you never need revascularization. No, 50% of them will need revascularization. So upfront, you tell them that listen, right now we are going to go with medical treatment, but there is a very good chance that you will need revascularization, but we will deal with it when time comes. You're not going to die before you have a chance to revascularize. And if you have a severe lesion which subtends a large myocardium, so distal left main disease or ostial LAD, proximal LAD, large circumflex, right coronary artery, which is functionally significant, which is not just that it is a visually 60-70% lesion or 80% lesion, because some people call 80 very liberally. So I think that doing a functional analysis is very important. CABG is better than PCI if you have complex disease. So if your syntax score is high, and if you're going to use arterial revascularization, then CABG is better. No question about it. And especially if you're young and you're going to look at 10, 15 years outcomes. But if you are 80, 85, this is a questionable conclusion. In patients with low syntax score, PCI and CABG is equivalent, death or MI. one important thing I didn't highlight too much is that the stroke is different. Stroke, there is a 1% difference in stroke in CABG versus PCI. And there is a great opportunity for risk factor modification. And we should not miss that, especially when you are looking at these patients. So this is where I conclude, and I'm happy to take questions.
Great talk, Samir. A very balanced view, an unbiased view on the eternal debate. This debate is never going to end, CABG versus PCI. In spite of being an interventional cardiologist, you gave a very balanced and unbiased view. If you can recall, Samir, not only you and Dr. Samir Dani went to same undergraduate school, same postgraduate school. I was also sandwiched between two great Samirs. And I had the privilege to learn from both of you. Dr. Samir Dani, 1 year senior to me, and Dr. Samir Kapadia, 1 year junior to me, both in the school, post-graduation, and in the residency. Very happy to see you, Samir. We have a few questions, starting with the debate on the Excel trial that was there. So what are your comments on that?
So the Excel trial is a left main disease trial. So there were 3 trials, and as I pointed out, the Excel, Noble, Pre-Combat, there are several trials that looked at the left main disease revascularization with PCI versus CABG. Initially, a lot of people thought that left main disease is more dangerous, or it is difficult to treat, and initially there was class 2B indication in the guidelines. It is exactly the opposite. So the left main is a large artery. It is easy to treat. It is close to your catheters, so you can deliver things relatively easily. So the left main disease, when you look at the Syntax trial also, one of the most important things that comes out is that if you can revascularize it simply, many times you can do it with 1 stent. If you are to do 2 stents, then the risk of restenosis is high. And there are a lot of different studies to say that what is the best way, whether you could do DK crush or technical parts to decide how you treat the distal left main disease. But the bottom line is that if you have a simple left main lesion, ostial, distal with 1 stent, you can treat. Personally, I think it is better or very, very similar to treating it with bypass surgery. It is more difficult to answer that question for a 30-year-old, 40-year-old, 50-year-old person than a 70, 80-year-old patient. So 70, 80-year-old is easy enough to say that putting a stent is a very reasonable first choice. You're not going to burn any bridges. There's no risk of sudden death and things like that. Again, you have to be technically good about doing all these things and compulsive in making sure that you do IVs, you do whatever it takes to make the outcomes the best. But if you do a good job, either surgery or PCI, everywhere it's true. If you do a good job, the outcomes are going to be very good for the left main disease for PCI.
Samir, do you hear me, Samir?
Yes, I do.
Samir, I think I appreciate your talk, very balanced talk and very precise. A couple of things which I want to add. It may be a good idea to assess the total amount of myocardial jeopardy. If it's more than 10%, I think it's likely to create more events. And this can be done even by the radionuclide stress perfusion study, or if at all, as you rightly said, that in FAME2 trial was actually aborted because the event rates were higher in those people who were not treated despite FFR showing a significant lesion. And therefore, it is a little bit controversial that on one hand, it is not taking into consideration the ischemia, or it's just considering a chronic stable angina treatment, which I think FAME2 believes that any ischemia producing lesion, especially if it is large, then I think it is important to treat. The other thing is that we are talking of a diabetes substrate. Noble, Pre-Combat, and Excel trials were not diabetes derived. It is a different issue. And there too, I think 50 to 70% of the cases were a distal left main bifurcation in any arm, So that I think is very important to keep in mind, that majority of the left main lesions are with distal bifurcation, which adds to complexity. And the people who think that this is not my cup of tea should not even attempt it. And I also would say one more thing, and that is a pre-combat trial did not have power enough to come to any conclusion. It was only a hypothesis generating trial. So putting into all these perspectives together, I would say your summary is very appropriate and it's a real message to take home.
Thank you. Thank you very much. And I agree with you that all the trials were not diabetic trials as the question came up. And that's why I didn't include it in my talk to begin with, those trials. The one question to you is, in United States, we see this more frequently than ever before, that we have now a heart team assessment of the patient. What the heart team assessment means is that patients actually see a cardiac surgeon, cardiologist, for simple things. So they have an idea that what a bypass surgery would mean, what a transcatheter therapy would mean, and then they can make a decision. In my mind, this has simplified at least my practice tremendously, because instead of me saying that you should have PCI, a cardiac surgeon, when he says that you should have PCI, it becomes much easier for the patient to understand. Or similarly, I would say that somebody needs a CABG, I would say CABG. It's easier for the bypass surgeon to convince them to have CABG. So appropriateness of patient care is much better with the heart team assessment. My question to you is that, is it happening equally in India?
My frank answer is no. And let me tell you why. The thing is that what I see here amongst the people practicing now, I've reached a senior level, and what I see here is that there is a tussle for the procedure, and therefore biased towards the procedure toward which you have an expertise, I think playing important part, consciously or subconsciously, which I think is playing an important role in how you put across the patient the perspective of a treatment. That's what matters. Like I can easily convince a patient against bypass surgery, and the surgeon can always have, everything can be operable. I think anything can be operable, that's for sure. And this is unfortunate, but that is what is happening. And moreover, I think the patients also have reservations about one form of treatment against other. They are frightened about the restenosis too much. In my opinion, restenosis is not a complication, it's a sequelae. In a palliative disease, restenosis only happens to be a sequelae which you might have to be treated once more. As Andreas Grunge used to put it, do you like to have 2 sticks in your groin? You want to have a big incision on your chest. That's what you used to talk about. So that's way. And then the second thing is that about I see somebody else now on the screen. Okay, the patients have. Are you able to hear me?
Yeah.
Yes, sir.
Yeah.
Patients have a lot of fright about the bypass surgery also. And my feeling is, Samir, you know very well, any patient who has come with symptoms after the bypass surgery, you know how much deterioration of the native circulation is taking place. It is really a nightmare sometimes for an interventional cardiologist to perform a procedure on a patient who has received a previous bypass surgery. So there are lots of things which we can't discuss in such a short period of time. And I once again appreciate what a beautiful talk that you gave. Wonderful, very, very lovely.
Okay, I will.
Doctor, yes, sir.
Yeah, Sanjeev, go on.
Dr. Samir and Dr. Ashwin Mehta, sir. The era in the COVID-19 has changed. The cardiologists, the interventional cardiologists, they are saying no for angioplasty, and the bypass surgeons are refusing for bypass.
because of that, the patients are now going for the medical therapy. What are your opinions on that?
I think it may be the best for the patient that it is, it is probably better. But again, COVID, I don't think has changed coronary artery disease or any of that. There is in our practice, my practice, we did have a bump of COVID about in mid-March. Unfortunately, we are having another little bit of a bump, but currently we are not stopping any procedures. So again, I always say that if the patients can have a second opinion, meaning that if they can wait for 3 to 6 weeks for their treatment, they're all stable patients and they should be treated accordingly. So there is no rush to make any decision except in acute MIs that what you need to do. So just take your time. I tell all my patients when they call me from everywhere, they say that, they are telling me that tomorrow I need to have bypass surgery. Just last night, one of my family relatives in Philadelphia, they said that he needs a bypass surgery right now. I said, listen, just take it easy. He's 50-year-old. They say his left main disease. And I look at the angiogram. I'm not convinced. So I said that, listen, if I'm not convinced, there is definitely time. It may be there, but it is not 100%. So the message is that coronary artery disease is not a fatal disease in stable form. It is a very manageable disease. People don't die of coronary artery disease. Stable form. If you have acute MI, different story. But stable form, you have a lot of time to decide. And if you have an opportunity to change what you do, so if you're thin and if your LDL is 60 and you still have coronary artery disease, very unfortunate. And you need to revascularize. But if you have a lot of opportunities, then better treat those than trying to mess with one little lesion and thinking that that is the solution to the problem.
Right, Sanjeev, may I add something to what Samir
Yes, sir.
Okay, I tell the patients, look here, my friend, you have not developed these blocks yesterday night. They were there together. These blocks, you have traveled all over the world, or you have done this and you have done that, and you've been walking. So don't get frightened merely by blocks there. They are stable. You will have an opportunity, as Samir rightly said, to make an appropriate evaluation. And then after appropriate evaluation, we can prescribe to you either PICA or a medical treatment or a CABG and whatnot. Asking about COVID, I have to give one webinar tomorrow on COVID-19 and coronary interventions. But I might tell correctly so, it has not altered the pathology of coronary disease at all. But however, when an acute coronary syndrome comes to the hospital, don't forget secondary myocardial infarction. COVID itself sometimes, it leads to thromboembolic phenomenon in the later stages. And the secondary myocardial infarction, you might not be to be surprised that in your clinical evaluation, in vast majority, you'll be able to make out whether it's a acute coronary syndrome, irrespective of COVID, or is the secondary myocardial infarction with totally normal coronary arteries. That may rarely happen. One more thing to add is to Samir's talk is that the diabetic patients in whom we generally don't get good opportunity to study microvascular function. And microvascular function is the one which I think is responsible for making inferior results, whether it's a CABG or a PCI. We treat the lesion on their merit on the basis of FFR or whatnot. But what is important, what is delivered to the myocardial cell is dependent on coronary flow reserve, which is combination of FFR and microvascular resistance combined together. So keep it in mind that diabetes might be contributing to inferior results in both revascularization by presence of microvascular disease. What do you have to say, Samir?
No, I agree with you. Go ahead, Samir Dani.
Yeah, I will chip in. I think this discussion can go on, and a lot has been said and a lot can be said further. Dr. Chilton, if you want to add one or two sentences, please go ahead, and then I can sum it up socially.
Just real quickly, I really enjoyed the talk. And as an interventional guy, I completely agree with everything he said. The only thing I think all of us have forgot to comment on is I have patients now who say, I don't want bypass surgery. And even when we would suggest that. So I think the patient has become somewhat more aggressive on helping make the selection of what they really want. And sometimes they make good suggestions. And I think we are going to have to more and more, as the heart team approach becomes more common, the patient is part of that heart team approach to some extent. But excellent talk.
I'm just going to interrupt for a second, and I see that Dr. Shashank Joshi has joined and asked a question, and Dr. Prafula Kerkar is also here with us on the panel. So I'm sorry to jump in and interrupt, but Dr. Joshi, did you have a question about what you were? We were in the CVOT room earlier, and this discussion came up, and I said everybody needs to quickly go here before Dr. Kapadia escapes.
So, Dr. Kapadia, in the COVID lockdown phase, have you seen an impact that people are staying at home and revascularizations have gone down? And my question is also to Dr. Ashwin Mehta, that people are doing well. So how do you comment on these observations which will get unlocked after 3 months of lockdown? Maybe Samir, and then maybe Ashwin. And I think Dr. Mehta, I agree with you that we are seeing a lot of myocardial infarctions and strokes as the first presentation, or even diabetic ketoacidosis of COVID in Mumbai. So that's something which we are seeing very, very elegantly, and most of them, again, hardly they get revascularized. And they're still alive, and they are doing pretty well. So I just comment that best medical management, can it be at par with a revascularization procedure, is my provocative question.
Yeah, no, I agree. The first question is that we reported in 3 different times to say that our risk of having presenting to the hospital with acute MI has gone down. People are staying at home, and that has resulted in higher number of deaths, higher number of VSDs, higher numbers of decreased ejection fractions. Yesterday, we also reported in JAMA to say that we have more people coming with the Takotsubo, or people with broken heart syndrome. So that was another, because again, people are stressed or whatever the reasons are with COVID. This is also becoming apparent. And people who have enzyme elevation with COVID without coronary artery disease history, they are obviously at a highest risk of dying. So this is all very well said. And I agree with you to some extent that maybe some conservative approach has not changed the outcomes of patients, but this is not well defined. I would not go that far to say that please stay at home and be conservative just because of COVID. If you are having acute coronary syndrome, there is no question in my mind that treating acute coronary syndrome with PCI is a better choice than trying to stay at home.
It's not just cardiology. I'll interrupt here. In all walks, in all fields of medicine, chronic work, which we by and large do just for so-called symptom relief. Like my orthopedic surgeons talk about not doing any more knee replacements, isn't it? Or for that matter, there is on a lighter note, there is a talk about that the elderly, the 3% of the US population that Bob mentioned about having what you call aortic stenosis, and you're looking for a medicine that will remove the calcium out of the valves. So those kind of problems, like we're talking about knee replacements, that's come to an halt, and probably medical management would be as good for a lot of it. And a healthcare industry at the end of the COVID era will take a huge beating, is what is my guess. I'm just trying to lighten the mood and tell you the other things. Nobody denies, Dr. Samir Kapadia, that ACS requires immediate intervention, and we got to do it. We're talking here about chronic diseases and not just cardiology, all walks. And I want to be as provocative as what Shashank was trying to be. On
a positive note, for the chronic diseases, you need a good doctor. Exactly. So you will have a lot of business to do if you are going to. I always tell people that it is most satisfying to treat chronic problems than to treat acute problems. And that's where you make a difference
between a good doctor and not so good doctor. So I think that it is an opportunity for everybody to practice good medicine and be a good doctor, not a technician.
Absolutely. So COVID is teaching us a lot of things.
Yes.
Yeah, I think
Okay,
Praful, I
so-
think very well summarized. One small point I want to make from statistics of Mumbai city. March of the death rate, March of 2020, April, May, and June. And on an average, we compare deaths of 2017, 18, and 19. On an average, we had 9,500 people dying in Mumbai due to all causes. And in these 4 months of lockdown, the actual absolute number of deaths are down to from 4,500 to 5,500. So the health authorities, because I'm on the task force, asked me, how come less people are dying? Because no doctors are seeing them. And it's so embarrassing. So how do you answer such people? I want some insights from Samir.
I will
Bob
answer
Chilton,
you,
and
Shashank. I
Samir,
will.
because and Ashwin Mehta and Praful, because these are not easy questions to answer. Bob, what do you think? Because these are not easy. They are actually looking at us as if we have been some criminals, and and there are less deaths happening, which is not true.
Shashank,
And I think I told them in this way that minute it gets unlocked, you will see a lot of hidden disease coming out in the open, and that would be a disaster, like avalanche. But maybe Samir. So yeah, Samir.
Shashank, I would say that there are, I mean, that's very simplified way to look at things. You are talking about only one parameter, that doctors not seeing the patients, but you are taking away the effect of environmental pollution, which stopped or which reduced remarkably when the vehicular traffic was off the road. You are talking about people not going to restaurant, people not going to stress of daily walks of life. Of course, the stress of COVID is there, but there are many other stresses which are not there. So I think it's a very, very complex problem. I don't think that you just look at one problem and answer that.
Mumbai
And
City-
I don't think we should be so defensive about being a doctor.
Mumbai City,
No,
no
I am
railway
not.
accident.
I defended.
No railway accident
I said
from
that this
Mumbai
complete
City.
bed rest. There is zero pollution. People are happy at
You are
home.
eating home food.
Yeah,
you are eating home food.
But these are, see, COVID has changed the way we look at things, whether it is cardiology or endocrinology. I think we are all on the same boat that it's going to change the landscape, and it's actually very unique in its own ways. Dr. Ashwin Mehta, can you throw some pearls of wisdom how you see COVID and how it will change life?
Dr. DeFranco doesn't leave us. Dr. DeFranco, please don't leave.
अभी अच्छा बात नहीं, अभी तो रात भर चलेगी बात.
We can't hear you, sir. Dr. Mehta, we cannot hear you, sir.
नहीं गया तो.
We can't hear him.
For whatever reason, we cannot hear him. If we have any last comments from any of the panel members, or we will have to thank Dr. Samir Kapadia for creating a fantastic discussion. And, Shashank Joshi, we can always trust you, Dr. Joshi, to jump in. I see Dr. Bansi Sabu has just joined us. If you can give us concluding remarks, sir, and then we will move on to the next session. Unmute.
Samir has left. Dr. Kapadia?
No, I'm here.
He's here. He's here. Bansi,
Yeah,
you are
I just-
muted. Bansi, you are muted.
No, you go ahead, Samir. You finish the last thing.
Ralph has joined us.
See,
Ralph has
my
joined us.
co-chair is here. My co-chair is here, so I'm not running the risk of getting accused that I allowed the program to slide. I'm very happy that she's here and she's doing that one. So the program can go on. And the next talk is by Dr. Ralph DeFronzo, and he can be very mad at Rucha, not me. She is his student. So please go on. Bansi, you have anything to say?
No, Rucha is going to introduce the Ralph. We are already.
Okay, so let me sum it up socially. Samir, it was a great thing seeing you here, and thanks a lot for agreeing to do this talk. Wonderful, balanced talk. And Dr. Ashwin Mehta, he also agreed to do this, chair the talk. It was a great thing. And Sanjeev, you are you're a great guy. So you don't need to feel sandwiched between two Samirs.
I had the honor or privilege.
We have we feel great about having such a schoolmate, you know. So all in all, it was a great session. Thank you all. And let's have the next session, which is going to be a terrific session as well.
Thank you, everybody. And thank you, Dr. Samir Kapadia and all the panelists. And now, without wasting any further time, I now invite the next chairpersons. We have with us Dr. Prafulla Kerkar, who is professor and head of the cardiology department at KEM Hospital, Mumbai. We have Dr. Amalia Gasta Delhi, who's joining us from Italy. She's got several titles, but she's also the chair of the European Group of Insulin Resistance. She has started the EASD NAFLD group. She's a professor and director of the research lab at the ICNR in Pizza, Italy, and she also is my professor. And I also invite Dr. Sanjay Agarwal. He's a senior diabetologist in Pune. He has always been very helpful to us. He's part of our executive committee for this conference, and he's a secretary for the Research Society for the Study of Diabetes in India. And I now invite Dr. Sanjay Agarwal to please introduce Dr. Ralph Defranzo.
Thank you very much, Rucha. It's a privilege and honor to introduce such a legendary figure as Dr. Ralph Defranzo. Dr. Defranzo is a professor of medicine and chief of diabetes division at the University of Texas Health Science Center, and is the deputy director of the Texas Diabetes Institute at the San Antonio, Texas. His major interest focuses on the pathogenesis and treatment of type 2 diabetes and the central role of insulin resistance in the metabolic cardiovascular cluster of disorders known collectively as insulin resistance syndrome. For his work in this area, Dr. Defranzo has received many national and international awards, including the Banting Award from the ADA in 2008, the Claude Bernard Award from the EASD in 2008 again, and most recently, Dr. Defranzo received the Ham International Prize in 2017. These represent the highest scientific achievement awards given by the American and European Diabetes Association, respectively. With more than 800 articles published in peer-reviewed medical journals, Dr. Defranzo is a distinguished clinician, teacher, and investigator who has been invited speaker at major national and international conferences on diabetes. So we're privileged to have you, and I'll hand this over to you for your lecture. Thank you very much.
Great. Thank you. Now, if we can get the slides up, and if you tell me what I need to do it, just go to slide screen.
Share content, correct. Share screen.
Share screen.
Once we see your screen, we'll guide you further.
Okay.
So hit the green arrow once.
Tell me what I do next.
Well, we don't see your screen yet.
Don't do anything yet.
And just click on share screen and you will see a window, pop-up window coming in.
I clicked on it, and this is like what happened last time. Now, in the bottom right, it says share.
Yes.
There's Zoom.
No.
Yeah, you are sharing your screen now. So close that Zoom.
Close the Zoom.
Just open the PowerPoint from the bottom.
Yes.
You can see the P over there. Yeah.
There it is. No, where is this talk?
Just click on it.
Double click on it.
Double click.
Yeah.
Come on.
Yeah.
PowerPoint open, it says. Miracles
is happening.
Oh my God. This is the wrong slide deck.
So we can also play the slides for you if you want. We have your slides.
You can close it and open the correct one.
Okay. Because I wanted the slide deck that we sent to Rucha last night. This is the slide deck that the talk that I gave 2 weeks ago. So should I just close this?
Yes.
Yes.
Okay, it's closed. And now you have to guide me, okay?
No, I can click on P.
I'm sorry?
P at the bottom.
P at the bottom.
Yeah.
Hit the PowerPoint button, yes.
Yeah. You see which one is the correct one from this?
Well,
should we play it for you?
I have a suggestion. You open the email which you sent to Rucha.
Yes.
And open the attachment there.
Perfect.
Close this PowerPoint. Close this PowerPoint, please.
Close it. Okay.
Now open the mail which you sent to Rucha yesterday, which says slides for Saturday.
Link for Saturday.
On the left side, you have a mail.
Yeah, see, they were sent from my secretary.
It says Rucha and Ralph.
Oh, yeah, I see it.
One. Click on that.
Okay.
Not that.
Yeah.
No.
No. The lower one. Yeah. Click on that.
Click on this one.
Yeah.
Double click.
Okay.
Yeah. Now you see the PowerPoint there, icon there.
On your right. On your right.
On the right.
In the box, there is
Yes,
a PowerPoint.
that one. Click on that. Yes.
Double click.
Double click.
Yes.
Yes.
Aha! Miracle.
Click on the slideshow.
That I should put it to slideshow now.
Click on the slideshow.
That's right, yes.
Okay.
Once, go to the left, home button.
Home button?
Just below the home button, play from start.
Oh my God, a miracle. Okay, I think we did it. Okay, it's a great pleasure to be with you all tonight. I would say the only thing that's missing is me in India. And hopefully if we can get past this coronavirus epidemic, we'll do this in person next year. So I'm going to talk about the insulin resistance and syndrome and cardiovascular disease, because I think this really is the missing link that we are really haven't come to grips with. So we know that the incidence of cardiovascular complications has gone down progressively over the last 15 to 20 years, but complications cardiovascular wise in diabetics still remain significantly higher than in non-diabetics, despite all of the medications that we use. And what I would like to suggest to you, and as we go through this presentation, is that we're missing the underlying link, which is the insulin resistance. And in particular, we're missing the molecular link. And this is not a link that's likely to be discovered by cardiologists, because in all of the epidemiologic studies and all of these clinical trials, they're not measuring the appropriate parameter to get to the etiology of the insulin resistance. So everybody who's taking care of diabetic patients is very familiar with this slide. In the upper left, this is a person with advanced diabetic retinopathy with hemorrhages, exudates, microaneurysms. In the upper right, this is someone with end-stage kidney disease. And you can see that you can barely see there are the remains of the glomeruli. And then in the bottom, diabetic neuropathy. So we have learned now over the last 30 years that these microvascular complications are related to two factors. First, how high your glucose is, and we get an index of this by the A1C, and then how long the glucose has been elevated. So what I'd like to do, just to make it simple, is to show you the data from the United Kingdom Prospective Diabetes Study, which was the first study that showed that in type 2 diabetics, the good glycemic control makes a difference. And this is what's called the epidemiologic analysis of UK-PDS. So we're going to take everybody who's in UK-PDS, some 4,000 patients, and we are simply going to plot the A1C on the x-axis against the hazard ratio for the microvascular complications. And you can see as you go from an A1C that here is 5.5 up to an A1C that's 9.5, there is about a 8 to 9-fold increase in the incidence of microvascular complications, so that for every 1% increase in A1C, there's about a 37% increase in the microvascular complications. But although the microvascular complications cause an enormous amount of morbidity and they're costly to treat, what really kills our patients are the macrovascular complications: heart attack, stroke, peripheral vascular disease. And collectively, these complications account for 80% of the mortality. And of course, they're also very expensive to treat. So we can ask, what role does hyperglycemia play in the pathogenesis of the atherosclerotic complications? So again, I want to come back to the United Kingdom prospective study and then look at the same kind of epidemiologic analysis for myocardial infarction here and stroke to the left. So you can see for MI, as we go from a A1C of 5.5 to 9.5, the hazard ratio is 2.2. This is a lot different from a hazard ratio of 8 or 9 for the microvascular complications. And then if we look to the right, you can see for stroke, the hazard ratio is 1.8. So clearly, hyperglycemia is a risk factor for the macrovascular complications, but it's an extremely weak risk factor compared to what it is for the microvascular complications. And I can say that this has really been borne out in a number of studies since the United Kingdom prospective diabetes study. Now, what about treatment? So again, I come back to the UK-PDS study. So we're going to plot risk reduction in the treatment arms. And as we lower the A1C by 1%, we decrease eye, kidney, and nerve complications by 37%. But for MI and stroke, although there was a trend for a reduction with improved glycemic control, neither MI or stroke were significantly reduced. Again, confirming that lowering the glucose is not going to save your patients in a big way from having heart attacks and stroke, okay? And if we just sort of look at the story for macrovascular complications, we know that over 2/3 of people with type 2 diabetes have subclinical disease. And in fact, about 20% of people with type 2 diabetes, when you see them for the first time, have clinically evident cardiovascular disease. I've already told you that the great majority of the mortality in type 2s comes from cardiovascular disease. And the disease manifests itself 15 years earlier in type 2 patients. So in terms of longevity, our diabetic patients are living significantly less than non-diabetic patients because of this high incidence of cardiovascular disease. One thing that we've now come to learn is that heart failure is a huge, huge problem in our type 2 diabetic patients. And this is, even though it was very, very evident from the literature, has become, I think now, much clearer with the advent of the SGLT2 inhibitor cardiovascular trials. And chronic kidney disease is very common in our diabetic patients. And if we look at people with chronic kidney disease, cardiovascular mortality has increased about 3 to 3.5 fold. So cardiovascular disease is a huge problem, and it's really an unsolved problem. So if hyperglycemia is not the major factor in the development of atherosclerosis in our type 2 diabetic patients, what really are the factors that we should be thinking about in these individuals? So what I would like to suggest to you, that insulin resistance per se is the unifying pathogenic disturbance that links all of the components of the insulin resistance syndrome. You call it the metabolic syndrome. And so as I take you through the components of the metabolic syndrome, you're going to see that each individual component of the syndrome is a risk factor for cardiovascular disease. But I would like to take it a step further and hopefully convince you that although each factor in the syndrome is a risk factor, that the insulin resistance per se is a major contributing factor. And that's why the cardiologists, unfortunately, are not going to solve this problem. So let's look at the insulin resistance syndrome. Top of the list, obesity, particularly visceral obesity, major risk factor for cardiovascular disease. Diabetes and prediabetes, okay? The risk starts to go up long before you develop diabetes. Hypertension, a major risk factor. Diabetic dyslipidemia, clotting factor abnormalities, high PI1 levels, endothelial dysfunction. We now know that NASH is the liver component of the metabolic syndrome. In my opinion, there's nothing unique about NASH. It's part of this whole syndrome. Atherosclerosis, as I will show you, is an independent risk factor. But at the bottom of the list is insulin resistance. And the insulin resistance per se is not only responsible for these risk factors, it has its own mechanism by which it's contributing to the atherosclerotic cardiovascular disease. So my guess is that the great majority of you who are listening in know what the insulin clamp technique is. But I was told that there are a number of primary care docs who are listening in. So I just want to review for you very briefly the euglycemic insulin clamp technique, which we developed many years ago, because this is the gold standard for measuring insulin sensitivity. So here's the fasting insulin concentration. We're going to infuse insulin, and we're going to raise the insulin concentration by 100 microunits per ml. Now, that's the only thing that we did. The plasma glucose concentration here shown in green would drop. And we don't want that to happen. So every 5 minutes, we adjust the variable glucose infusion rate to keep the glucose concentration constant. So if we just simply add up all of the glucose that was infused to keep the glucose concentration constant, that's a measure of insulin-mediated glucose metabolism. And this really is the gold standard now that's used throughout the world for measuring insulin sensitivity. So let's now start to examine what it is that diabetes and obesity have in common. So this is actually the first study that we carried out many years ago with the euglycemic insulin clamp. The height of the bar represents the amount of glucose uptake. The units are milligram per meter squared per minute, but from the points that I want to make, you don't have to worry about the units, okay? And then I've divided the height of the bars into how much glucose is going into glycogen and how much glucose is being oxidized, since these are the two major components of glucose disposal in the cell. So let's look at normal weight diabetics. You can see there's about a 50% reduction. They're severely insulin resistant. Let's look at obese people who have completely normal glucose tolerance. They are equally insulin resistant. So both diabetics and obese people who have normal glucose tolerance are insulin resistant. And if you look, the major defect here is in the glycogen synthetic pathway, and I'm gonna come back to this point in a second. So what about hypertension? What does that have in common with type 2 diabetes? Now, many years ago, I had a young fellow, you're going to recognize his name because he, in my opinion, is the top clinical investigator in Europe, Professor Eli Farinini. He got this idea that people who were hypertensive were insulin resistant, and he published a very, very famous article in the New England Journal of Medicine. And then we subsequently went on to perform insulin clamp studies in people with essential hypertension. And you can see that people with essential hypertension are also severely insulin resistant. And the defect resides here mostly in the glycogen synthetic pathway. So in fact, now you see we have three very different diseases: obesity in the middle, diabetes to the left, hypertension. And from the physiologic level, they look very similar. Now, what about dyslipidemia? What does that have in common with type 2 diabetes, obesity, and hypertension? So remember, diabetic dyslipidemia is an elevated triglyceride. It's a low HDL and small dense LDL cholesterol particles. It's not an increase in the LDL cholesterol. So we've also performed insulin clamp studies in people with hypercholesterolemia. They have normal insulin sensitivity. But if you look at people with elevated triglycerides, you can see to the right here that these individuals are also severely insulin resistant. And again, you're seeing the defect, the lighter part of the bar, is always in the glycogen synthetic pathway. Now, what about people with coronary artery disease? What do they have in common with the people with diabetes, people who are obese, people who have hypertension and dyslipidemia? So a number of years ago, I had a young fellow, Peter Bressler, and we took people, actually working with Dr. Bob Chilton, who you heard earlier today, who had diffuse coronary artery disease, who were non-diabetic and were not obese. And by that, we meant you had to have at least 2 coronary arteries with more than 50% stenosis. And then the control group were people who had clean coronary arteries. So how do we get people with clean coronary arteries? These are people who came with atypical chest pain or heart murmur and were subsequently found to have really normal cardiac functioning coronary arteries. And that was the control group for this study. Now you can see to the right that when we look at people who have coronary artery disease, but are not diabetic and not obese and don't have dyslipidemia and hypertension, they are also severely insulin resistant. So what we have is these diverse phenotypes that are all associated with severe insulin resistance. So again, coming back to what I said earlier, I believe that insulin resistance is the link between these multiple components. Now, as we started to publish these data, a number of people throughout the world said, okay, look, if insulin resistance really is playing a role here, let's make a measure of insulin resistance, and then let's follow these people up with time. So every single study that has been carried out has shown that if I have an index of insulin resistance, could be the HOMA-IR, the Matsuda index, could be from an OGTT or clamp, that it predicts who's going to have a cardiovascular event. So the Botnia study, Dr. Group's study in Sweden, Enzo Bonora's study in Verona. I think everybody listening in knows the Framingham study. The San Antonio Heart Study, this is Dr. Stern's study, which I'm going to show you in a second. The Brunick study, the Malmo study, again, Dr. Group. Steve Hafner's IRIS study, the ARIC study, many studies by Dr. Reven, and recently a guest meta-analysis of these 17 studies all show that if you look at people who are insulin resistant and you follow them up over 5 to 10 years, insulin resistance strongly correlates with the development of coronary artery disease. So let me show you Dr. Michael Stern's study. So this is a study carried out here in San Antonio, 2,500 individuals followed up for 8 years. Now to get into this study, you can see in the top, you cannot be a diabetic. And then based on HOMA-IR, he divided the people into 5 quintiles. So quintile 1 is the most insulin sensitive, quintile 5 is the most insulin resistant. And you can see that if you are insulin resistant, you have a 2.5-fold increased incidence of having a cardiovascular event. Now, the reason why I chose this study is not because it was done in San Antonio, but because Dr. Stern actually was a cardiovascular epidemiologist. And so in this study, he corrected for age, sex, blood pressure, dyslipidemia, smoking, exercise, etc. And you can see that after correcting for all of these, still insulin resistance had a 2-fold increase in the hazard ratio for having a myocardial infarction or cardiovascular event over the subsequent 8 years. This is a study, again, from Europe, from Professor Farinini. This is the risk study that Dr. Gastadelli has also been intimately involved with. So this study is extremely important because it's a large number of people who have all been studied with the euglycemic insulin clamp and they're non-diabetic. Now on mean, their BMI is 25, but of course there's some people with a BMI greater than 25 and some people with a BMI less than 25. And then they looked at a number of cardiovascular risk factors. And they also, using the clamp, had a direct measure of insulin resistance, and the clamp measure is the best you can get. And then they're going to look at the load of cardiovascular risk factors. And the risk factors they're looking at are age, blood pressure, heart rate, glucose, and dyslipidemia, etc. So as you go from the least insulin resistant or the most sensitive 1 to the most resistant 4, the number of cardiovascular risk factors goes up dramatically. This is quite striking. Now, if you were to plot obesity, you see the same kind of picture. From lower body weight to higher body weight, okay, the cardiovascular risk factor goes up. But of course, obesity is strongly correlated with insulin resistance. And then if we now look at the insulin response to the right, you see the same picture. So hyperinsulinemia also predicts an increase in risk factors. So again, we see this very strong tie between insulin resistance, risk factors, and also clinical events. Now, this is a very enlightening study that was published by Dr. D'Agostino, whose first name, by the way, also is Ralph. Must be a good guy by definition, okay? And so what he did is he wrote to the investigators of the individual studies that I'm going to take you through here, like Framingham study, ERIC, et cetera. And he said, can you give me the raw data from your epidemiologic studies? And they did. And he used the Framingham engine plus a couple of additional risk factors. And he's going to look and say, how much of the risk from the Framingham study and these other risk factors, how much of the risk for a cardiovascular event can I explain? So here's Framingham in white males. Here is Framingham in white females. We have ERIC study in whites and blacks. We have the Honolulu heart study. We have the Puerto Rican heart study, strong heart studies, American Indians, and so forth. And what if you look at the mean, he could account for about 69% of the risk using the Framingham engine plus these other risk factors. So that meant that the best that he could do in all of these big studies is account for about 70% of the risk for cardiovascular disease. So what's the other 30%? And interestingly, as I told you before, we've done a really good job lowering blood pressure, treating cholesterol. But the fact is, people with diabetes still have a significantly increased risk, 2 to 2.5 fold, compared to non-diabetics, despite everything that we've done in terms of interventional strategies. So what I'm going to propose is that the molecular etiology of the insulin resistance is the basic defect that's explaining this missing 30%. And in fact, as I take you through this, it's going to be pretty obvious why this is never going to come out in any of the big clinical trials that are ongoing. So in order for insulin to work, it must bind to the insulin receptor. There are 3 tyrosine molecules that after insulin binds get tyrosine phosphorylated. And once they become phosphorylated, IRS, okay? This is not the Internal Revenue Service in the United States coming after you. This is insulin receptor substrate 1, moves to the surface. It gets tyrosine phosphorylated on the same 3 tyrosine molecules. You activate PI3 kinase, AKT, and if this all happens, now glucose gets into the cell. And then the other thing that people don't understand is that this same pathway is activating nitric oxide synthase and generating nitric oxide. So nitric oxide is the most powerful vasodilator in the human body. And it's also very, very anti-atherogenic. So if this system all works well, glucose will be metabolized normally, and you'll get protection against hypertension and atherosclerotic cardiovascular disease. So what goes wrong in people with type 2 diabetes? Now, I can see some red scribble on my screen. I don't know if I did that, but I'm sorry for that. That if you look at insulin activation of the receptor, it's perfectly normal. The block, however, is at the level of IRS1. So now you block the insulin signaling pathway. So what does that mean? Glucose is not getting into the cell. What is that? That's diabetes. You also block nitric oxide synthase. Nitric oxide is not generated. That's endothelial dysfunction. This is going to lead to hypertension. This is going to promote atherosclerotic cardiovascular disease. Now, there's another part of the story that we haven't discussed yet. So there's another pathway that insulin activates, and it's called the MAP kinase pathway, mitogen activated protein kinase pathway. And it's activated here by a molecule called SHIC, okay? Well, it turns out that this pathway is completely intact. The classic insulin signaling pathway is blocked, okay? So now this pathway is intact. So why is this pathway important? This is the atherogenic pathway. When this pathway is activated, it causes inflammation. I-kappa beta, NF-kappa beta, and other toll-like receptor 4 pathways are activated. This is the pathway that causes vascular smooth muscle growth and proliferation, hallmark lesion of atherosclerosis. So this is what happens now. You have a defect here. Glucose cannot get into the cell. Blood sugar goes up. It's prediabetes, okay? So in prediabetes, your beta cell's still functioning pretty well. You get a big increase in insulin secretion. And even in early type 2 diabetics, they have plenty of insulin around. Insulin binds to the receptor. So now it wants to drive the insulin signaling pathway, but it can't. This pathway is broken. So what does it do? It drives the MAP kinase pathway. So now this is a double hit for atherosclerosis. You're activating the MAP kinase pathway, and then the ability to generate nitric oxide is blocked. And this is why diabetes and atherosclerosis go hand in hand. And as I'm going to show you in a second, these defects are probably present since age 1 of your life, okay? So to look at this, what we did is that we said, look, how can we get non-diabetic people and study them at a very early age? Well, in San Antonio, this is pretty easy to do. So we look for families where 2 parents were diabetic, very easy to find. And we want to look at the children of 2 diabetic parents. And there are lots of these families. The problem, most of the children are obese, and that's an insulin-resistant state. So it took us a while, but we eventually found a large number of lean children. And we did insulin clamps in these children. So what about insulin receptor tyrosine phosphorylation? Completely intact, just as it is in their diabetic parents. Now, what about the ability to activate IRS1? Completely blocked like in the parents. Activation of PI3 kinase, also blocked. Now, these kids have perfectly normal glucose tolerance, but they have markedly elevated insulin levels. They look, from the molecular standpoint, exactly like their diabetic parents. So let's now look at ERK, which is a component of the MAP kinase pathway. ERK activity increased. ERK phosphorylation increased. So these are young kids. They're sitting in the sea of molecular insulin resistance. And when you look at their risk factors, okay, hypertension, well, their blood pressure is normal, but compared to the kids who have normal insulin sensitivity, their blood pressure is actually up. Or what about triglycerides? Same story. Well within the normal range, but compared to the kids who have normal insulin sensitivity, it's up. So the risk factor changes have already now started to set into place. So what I want to argue with you is that the reason why we can't get rid of this excess risk for cardiovascular disease is because it's related to the metabolic and molecular etiology of the disease, and we never treat that, okay? Now, there's only one drug that reverses everything that I've been talking about here, and that's pioglitazone. And I still use pioglitazone as first-line therapy, and we know from the IRIS study, okay, we talked about this earlier, that's a study done in non-diabetic individuals, okay? You could not be a diabetic to get into that study, okay? Those are people who had a stroke or a TIA within 3 months, and then they were randomized to pioglitazone or to placebo. And what happened, it was a dramatic about 25% decrease in recurrent stroke and TIAs and cardiovascular events in individuals who were not diabetic. So this is what Dr. Michael Stern and Steve Hafner referred to as the ticking clock hypothesis. So you are born with genes that cause this molecular insulin resistance. So the ticking clock for coronary artery disease starts probably when you're born. Maybe it starts in utero. I mean, you got some bad genes from your parents and they're ticking away while you're in the mother's womb. But for sure, in young children, we see this already manifest. So that's why, in my opinion, when you see diabetics for the first time, 20% of them already have clinically manifest cardiovascular disease. And as I said earlier, 2/3 of them have subclinical disease. Now, what about the ticking clock for the microvascular complications? This clock doesn't start until your glucose goes up. So this clock starts when you're in your 40s or so. So we clearly need to lower the glucose. We don't want people going blind. We don't want them developing kidney failure. But now we need to come back and start to think about how are we going to prevent the high incidence of cardiovascular disease. So it's essential that you remember that type 2 diabetes is 2 different diseases, and I've tried to highlight the 2 for you. Microvascular disease, blindness, eye disease, kidney failure, dialysis, transplantation, neuropathy leading to amputation. You've got to control the glucose, okay? Macrovascular complications, heart attacks and strokes, okay? Well, we don't want our people dying. So if we prevent eye, kidney, and nerve damage, we want them to live longer so they can enjoy their life, okay? 2 different pathogenic sequences, microvascular, glucose, macrovascular, insulin resistance syndrome. 2 different syndromes, eye, kidney, nerve damage, heart attack, and stroke. So there's been an enormous amount of interest and emphasis placed on atherosclerotic cardiovascular disease because of the clinical trials that have just come out. And I think these trials are fantastic, very, very important, and they have focused this now on the cardiovascular part of the story. But that doesn't mean that you can forget about controlling glucose, because I can tell you, if I were to put my nephrology hat on and I take care of people in the dialysis unit who come 3 times a week and are blind, their life is absolutely miserable. So we need to attack both problems. You need to be aware that they're very different etiologies. And then I think there's going to have to be a complete rethinking about now starting to do studies to look at the basic molecular etiology of the disease. And for those of you who are listening in earlier, Dr. Chilton said, these big trials are paralyzing us. We're spending enormous amounts of money on these trials, their clinical outcomes, and basic grants for science are being trashed, unfortunately. And here is, I think, a very important example of this. We've forgotten the basic science, and we're focusing on the clinical trials. Of course, the clinical trials are incredibly important, and I'm not trying to minimize this, but I think we need to go back and understand the basic molecular mechanisms that are responsible for the atherosclerotic cardiovascular complications. So at this point, I will end, and we will turn this back to our panel to entertain questions from the panel or from the audience. And thank you for listening in.
Great talk.
Thank you, Ralph. This was a great talk. And now we have, you see me, Ralph? It's Amalia. Hello.
Hey, Amalia, you're beautiful.
Thank you. I'm amazed that you were able to start, this nice presentation.
My life is being ruined now that people know I can turn on a computer.
I'll remember, Ralph.
We all remember, The first time I met Ralph, Ele Ferranini sent me to San Antonio to teach him how to use a computer, I have to say that somehow I was successful if you are able to start a presentation, a virtual presentation.
There's another woman, as you can imagine. Her name is called Olga.
I know it's not all my merit. I know that.
But it's beautiful women collectively. Now, Chilton, you're not a beautiful woman, but you're a handsome dude.
Yeah, Ralph, I thoroughly enjoyed you going through that because people just don't realize if you don't take care of the cellular structures, people just forgot that. They just went through these big trials. The money is in the basic sciences, and I thoroughly enjoyed that talk. That was superb.
I concur.
Yeah.
But you made the comment first earlier.
Oh, no, you taught it to me.
Okay, I think everybody is sort of tired or sleepy because I don't see any comment.
So they're coming in through to us, Amalia. So I will just go ahead and
yes,
somebody
please.
is asking about, from the cardiology standpoint, about this is a very common question. I think Ralph gets it every time. The dose of pioglitazone and the role in somebody who has no prior existing ASCVD but has a family history of ASCVD.
So let me first comment on pioglitazone, because there's this concern that pioglitazone does something bad to the heart. Now, pioglitazone, if you look at the studies that are published, including our own, does nothing to systolic function, nothing negative. If anything, it may improve a little bit. And Bob Chilton and I have published a study, it's in Diabetes Cure, showing that it actually improves diastolic dysfunction. So this issue of pioglitazone doing something bad, even cardiologists say this to the heart, it's not true, okay? And in fact, Dr. Nissen, who will be speaking tomorrow, he and I have written a paper on this, and we agree that pioglitazone is an important drug for treating people with type 2 diabetes and atherosclerosis. The problem is pioglitazone works on the kidney, and you retain salt and water. So if you have significant underlying heart failure, you retain fluid, even though the drug may do something good to the heart, the fluid retention is going to overwhelm you. So don't be giving pioglitazone to people with heart failure, okay? Class 3, 4, forget about it, okay? But in newly diagnosed diabetics with reasonable normal function, to me, it's an excellent choice. Now, the dose. Dr. Tripathi even mentioned earlier in a study that Franco Foley did when he was here, we showed that the drug works at 7.5 to 15. And so in the United States, we don't have the 7.5, we just have 15. But you can split it, but you have to be careful because it's not scored. Or you can just start at 15 and go to 30, never go above 30. And I think Bob Chilton referred to this earlier, and I agree. If you're using drugs in combination, you're not going to have to worry about fluid retention. So if you use pioglitazone with an SGLT2 inhibitor, that's a great combination. So now the next question is, this person asked, what about if you had someone with a very strong family history? Okay. So let's say I worked somebody up. The mother died from a heart attack and a stroke. The father also had a heart attack and a stroke. And now I got a 40-year-old guy, and he's got some risk factors, but he's not had an event. And you do a glucose tolerance test, and it's normal. But you measure the insulin levels, and they're markedly increased. So he's insulin resistant, okay? This is sort of a pre-diabetic patient. So we know from the IRIS study, okay, if you're non-diabetic and you've had a stroke or you had an event, okay, you're going to have a markedly decreased risk of having a recurrent stroke or cardiovascular event. So one could make the argument in this high-risk person who's non-diabetic, even though they haven't had an event because of the family history, you should treat them. Now, having said this, this is completely off-label. Can I prove it? No. Okay. So this is a study that I think should be done and funded by the National Institutes of Health. The Takeda people are not going to do it because they're basically out of business. But it's a very important study. How early should we treat? Primary prevention. And when does primary prevention start? I might argue it starts a lot earlier than just having risk factors.
So how would you compare a statin vis-a-vis a pioglitazone at the molecular level in terms of being preventive? Because we cardiologists know only about statins as being the preventive for atherosclerotic coronary disease, right?
So I'm not going to argue against statins. They're fantastic drugs. Every diabetic patient should be on a statin.
In your MAP kinase pathway, where do statins come?
Right.
There is one unifying link that you talked about, insulin resistance, even in the non-diabetics. So how do statins, okay, there's much thing about against statins when it comes to even primary prevention, right?
Yeah.
So what parallels do you draw between statins and a pioglitazone?
Well, they're working by totally different mechanisms, of course. So with statins, you know, I think it's pretty clear now, if you're a diabetic, at least clear to me, your LDL cholesterol should be less than 50. And there's no J-shaped curve where things are getting worse. So in high-risk people, I think lower is better. Now, having said that, as I said earlier, even though we treat with statins, we treat with the blood pressure, et cetera, there's still a large risk that's there in diabetics compared to non-diabetics. So what I'm saying is that this large risk, okay, is due to the insulin resistance per se, not the insulin resistance syndrome. So the insulin resistance syndrome is, of course, it's the dyslipidemia, it's the hypertension, et cetera. We're treating all those things, okay? That's coming from the insulin resistance. They're independent risk factors. We treat the independent risk factors, but we're not treating the insulin resistance, which in my opinion is an independent risk factor. And, and I'm not saying the cardiologists are doing anything wrong, but when you do studies and you do a study with 5,000 people, could you do a muscle biopsy in 5,000 people and make these measurements? Of course you can't. It's not possible. So we have these data that are done in sort of mechanistic type studies in 30, 40, 50 people, et cetera. So is that enough, the basic science, to convince you to start using these drugs earlier? Well, it's not going to convince the FDA. They want 5,000 people with MACE endpoint. So this is something that each physician, you as a cardiologist, if you have one of these people, mother died at an early age, MI, father died at an early age, stroke, and this guy is, maybe got a little central obesity, he's got some risk factors, but he has normal glucose tolerance. And then you measure the fasting insulin, it's markedly increased. You do an OGDT, it's normal, but the insulin levels are off the map. Would you put this person on an insulin sensitizer? And the only true insulin sensitizer is pioglitazone. That's a decision that we all have to make on our own. Now, personally, I would. Now, the other thing that I want to come back to is what Dr. Chilton mentioned earlier. We were talking about GLP-1 receptor agonists, and the data now with semaglutide show that with the high dose of sema, up to 2.4 milligrams, we get 10, 15% body weight, obesity, and lipotoxicity. This is a huge problem as well in our diabetics, okay? So this is also a natural choice because most of our diabetics are overweight. And if I get fat out of tissues, I also improve insulin sensitivity. So semaglutide, although it's not a direct insulin sensitizer, basically is doing the same thing that pioglitazone is doing by getting the fat out of tissues. So taking this obese person and putting them on pioglitazone, which is an approved drug in the US for obesity, would be another option.
Just a comment, Ralph, amplify for both of you. This is interesting. You asked about the statin, and Ralph is commenting about the insulin resistance. I showed you in my talk, which Ralph is well aware of, and that we were involved in this trial, the Periscope trial. It was, first, let me start the reversal trial. Even if you give a high dose statin, you still see progression of atherosclerosis. In the Periscope trial on high dose statin, it actually, with pioglitazone, it halted the progression by IVUS. So as an interventional guy, if you look down the coronary, you will still see more disease progressing at a slower rate if you give a statin. But if you give the statin and you give pioglitazone, you actually see it stop or actually go down some visually, if you just look at it. So you need to add the pio in order to get that protective mechanism. But Ralph is exactly on target as far as I'm concerned too. If you don't see the cellular benefit, you're going to have trouble. But just optically, if you had a coronary and that's yours, you know that if the HDL goes up with pioglitazone, you're in the right group.
Yeah, so the Periscope study that Bob referred to is a very important one. It's Steve Nissen's study. And in that study, they compared pioglitazone versus a sulfonylurea in over a year and a half. There was a 34% progression of coronary atherosclerosis in the glipizide group and a 14% regression with pioglitazone. And the difference was highly statistically significant. So as Bob clearly points out, this is anatomical evidence and we have clinical evidence. So we have both.
Yeah, both.
And Bob also mentioned earlier carotid intermedial thickness in the Chicago study showing with pioglitazone that you slowed carotid intermedial thickness, which is a surrogate measure of atherosclerosis. So we have both in the carotids and in the coronaries evidence of anatomical halting of the disease. And we have clinical evidence that you have fewer MIs and strokes with pioglitazone.
Hey, I'd like to ask Dr. Jainik, that is in the audience, because he has a question. Why don't you ask him directly?
Dr. Yagnik, you have a question. Please
Yagnik.
welcome.
Dr. Rajiv also.
You need to unmute yourself, Dr. Yagnik.
Need to unmute yourself.
He has just given us a wonderful talk earlier today on the origins of cardiometabolic syndrome in Indians. And he had quoted your theory, Ralph. So we have Dr. Yagnik now about to ask you something. Please go ahead.
Okay, Professor DiFranzo.
Hey.
We set up a preconceptional cohort 30 years ago. And we studied mothers from before they became pregnant. And the children are now 25-year-old. And we have a serial glucose tolerance test, cardiovascular risk assessment, their growth, and a whole lot of other measurements. So today I presented the data at 18 years, and there were 30% of them who were pre-diabetic at an average BMI of 19 kg per meter square. And we were able to look at that test behind, so at 12 years and 6 years, and we were able to show that actually it all started with less insulin secretion rather than insulin resistance. Both the boys and the girls at 6 years who subsequently went on to become pre-diabetic had lower insulin secretion. Boys also had insulin insensitivity. At 12 years, both of them had lower insulin secretion. And by the time they became pre-diabetic at 18, there was a combination of insulin secretion defect as well as insulin resistance. They did not have higher triglycerides. They did not have obesity. They did not have adiposity as measured by DEXA. They did not have central obesity as measured by Westip ratio. So I suspect that actually in populations which have been undernourished multi-generationally, the small fetus, which like Indian babies are on average 2.8 grams, 2.8 kilograms, as opposed to Western babies, which are 3.5 kilograms. And one of the important things which we had shown before was that this 2.8 kilogram baby has more fat than the English baby. So that's how we coined the term a thin fat Indian baby. But despite being thin fat, the primary initiating event for subsequent glucose intolerance seems to be failure of beta cells to secrete. And the insulin resistance does come later. And I think part of it is due to building up of the glucotoxicity and the lipotoxicity. And I would like to discuss this with you to see if you have any serial data from childhood to the adults in populations who are much more obese than our populations.
Yeah, well, unfortunately, well, this first I could say is a great study, and as I mean, definitely should be published because there are all kinds of implications for this. I'll make a few comments in a second, but we don't have that kind of data, and my guess is very few people do have it. Now, there've been studies here at the we have a very large non-human primate center where the primates have been followed from birth onward. And in the primates, malnutrition in the mother or malnutrition in the fetus, and also malnutrition after the child is born, all have a major impact not only on beta cell function, but insulin sensitivity, future development of diabetes. So this obviously is a very complex situation where nutrition is playing a critical role. Now, you actually probably have all these data where you can go back and look at the environment which I would say this is a very unique population, and see both in the mother as during the period of her carrying the baby, as well as after would if they're breastfeeding, whether this has an impact on both insulin secretion and insulin sensitivity. And I think that will be probably the only such data that are available in the literature on this. Now, from my standpoint, how did you measure insulin secretion and how did you measure insulin sensitivity? Because these are obviously important points.
That was oral glucose tolerance test. In children, it was the standard 1.75 grams per kilogram body weight. And we calculated all the Wareham and the Matsuda indices and calculated the disposition index. And disposition index, low disposition index, seems to me the first event which we can predict, which will, like say, predict the future glucose intolerance. The fasting glucose at 6 and 12 years was a very strong predictor of glucose intolerance at 18 years. So that if we develop a ROC curve for the future future glucose intolerance, three factors which allowed us to predict was one was male sex. It was twice as common in boys than in girls. Second one was small length at birth. And the third one was glucose at either 6 years, and then again we had at 12 years. And this gave us a ROC curve with a area under curve of about 0.75.
Yeah. So I would say that that's really an incredibly rich database because rather than using these HOMA indices, which are okay, you actually have much better indices from the OGTT, which I think are quite reliable. And I think one of the things, again, I haven't seen the data and I didn't see the presentation, but it sounds like that these are almost malnourished in a certain way or smaller kids. And it may well be that that malnourishment, whether it's protein malnourishment or total caloric malnourishment, maybe you can figure out, is contributing to a beta cell defect, which we tend not to see in the US, where we don't see too many malnourished people in the Hispanic community. You know, our problem is we have people with BMIs of 45 that we can't fit into the magnet to measure their, fat composition. So this is, I think, a very, very interesting group, an interesting sort of experiment of nature that really is quite unique.
Yeah, but see, if you see data from Harvard, from the nurse's health or the physician's health, low birth weight combines with the subsequent obesogenic risk factors to increase the risk and is an independent factor even in Americans.
Oh yeah, I mean I'm not refuting that. That's well established, and the monkey studies, both that were done here and in Seattle, there's a lot of evidence for this. Now, the point that I was making is that undernutrition may actually have a specific effect on the beta cell.
Yes.
And I'm not refuting that they have an increased risk for diabetes and coronary artery disease. I agree that's well established. Amalia, actually, she and I have worked, I think we published 45 papers over the years. What do you think about the beta cell finding, Amalia? Do you want to make a comment on that?
About the study of Dr. Yain?
Yeah, finding.
Yes, yeah. First of all, Dr. Yannick, I like to congratulate because I follow your presentation that was very interesting. The beta cell function, we think it's probably what is going away much earlier than the insulin sensitivity, or at least until if you still have a very good beta cell function, then even if you're insulin resistant, you don't develop type 2 diabetes. And just on people that they have NAFLD or chronic hepatitis C, those NAFLD, they have an extremely high insulin resistance, but they still have a very good insulin response and a very good disposition index. While, for example, the people with hepatitis C, they had a very good insulin sensitivity, but they lost most of the beta cells. So just an example to say that if you lose, even if you are still insulin sensitive, and this is because of a virus, because we know the virus is also going into the pancreas and is affecting the insulin secretory, the capacity of the beta cells. So I really think that, of course, insulin resistance is bad, but if you can preserve your insulin response and you can preserve your beta cell function, you are still fine. And if you look at the bariatric surgery, for example, studies, even if those are very obese and they have a very bad diabetes, whenever they lose a lot of weight because of the bariatric surgery, they restore their insulin secretory capacity. The direct study has shown that only those that have a preserved beta cell function, they can regress diabetes. Those that they lost their beta cell function, even if they lose weight, they lose fatty liver, they lose fat in the pancreas. I mean, beta cell function is lost, then you cannot do anything. Dr. Chawla,
Dr. Rajiv Chawla seems to have a question, so let's invite him.
Dr. Ralph, wonderful, awesome lecture on IRS, how it is contributing towards rampant atherosclerosis. And I'm sure not to say that no one can have more insight into the molecular and the biochemical pathways contributing towards rampant atherosclerosis than you, because almost whole work is your own. We have one publication in IGM in 2016 where we have hypothesized that micro and macrovascular complication seems to be a continuum. Conventionally, we agree that it is thought that micro and macrovascular complication, they are not aligned together and they have a different mechanism. You rightly said, by the time you have onset of macrovascular complication, micro has a linear course after the onset of the disease and both are not aligned. But of late, last 15-20 years, a lot of data has come, whether you talk about Hoon study, Mountain 3D study, you talk about ERIC study, which has said that if you have microalbuminuria, you are at a greater risk for CAD, heart failure, CV mortality. And based on our own work over last 10-15 years, we also hypothesize that if you have peripheral neuropathy, you are at a greater risk for lead or peripheral vascular disease. If you have microalbuminuria positive along with neuropathy, you are at a greater risk for CAD also. So to us, it seems that micro and macro, they go hand in hand and they are more aligned than distinct. And we said finally that it seems to be continuum, not a distinct mechanism for micro as well as macrovascular complication. So what is your final word on that?
Simply, I totally disagree.
We also disagree. That is why I am very keen to have 1:1 answer from you.
So I'll tell you why.
Hoon study, Mountain P3D study, ERIC study, all these studies said that if you have microalbuminuria, you have heart failure, you have more CAD, you have retinopathy, you are at a greater risk for CVD and CV death also. And same way, we have tried to link peripheral neuropathy with PVD, peripheral neuropathy with microalbuminuria. If you have microalbuminuria, you are at a greater risk for CAD. And I am sure that these are the shared mechanisms. If you have neuropathy, you are also likely to have neovascularization of vasa nervorum. If you have microalbuminuria, not only you have endothelial dysfunction, you also have all other micro mechanism contributing towards macrovascular disease. So heart involvement in diabetes today is no more a macrovascular disease. It is also a microangiopathy. Of course, mechanisms are different. But I think if you see overall these mechanisms seem to be aligned with each other and more of continuum than distinct.
Okay, so I totally disagree. All right, so I think you completely missed the point. All right, your observation that they parallel each other is absolutely correct. And I'm not going to sit here and say that people who have microvascular complications don't have macrovascular complications and vice versa. So that part of the reasoning is correct. The second part of the reasoning, in my opinion, is totally incorrect, okay? That the underlying mechanisms are totally different. You just simply look at what the macrovascular complications are. Dyslipidemia, hypertension. They are totally distinct from the microvascular complication. And now this will end this discussion completely when I tell you the following thing. What cells get microvascular complications? Only cells or organs where they don't have insulin-regulated glucose transporters. So GLUT4 is in muscle. It's in the myocardium. It's in the skeletal muscle. You do not see microvascular complications there. You do not see microvascular type changes in any cell or organ where you have insulin regulation through GLUT4. Where do you see trouble? Nerve, eye, kidney. Why? Because glucose gets into those cells via mechanisms that are totally independent of GLUT4. So something goes wrong in the muscle, the glucose goes up. The muscle is not going to be harmed, okay? Because the glucose cannot get into the muscle. The glucose then flows into the retinal cells, into the nerve cells, and it activates a whole host of pathways that got nothing to do with atherosclerosis, okay? Now, the fact is, however, that micro and macrovascular complications, they're parallel each other, but the mechanisms are completely different. So I don't believe that they are related to the same defects. Now, of course, if you have retinopathy and you're hypertensive, the hypertension is going to make the retinopathy worse. But what caused the retinopathy had nothing to do, in my opinion, with caused the hypertension. So yes, do you see them in parallel? Yes. Are they closely associated? Yes. Are the mechanisms responsible for the two the same? In my opinion, no. And I know you're going to argue, well, in coronary arteries, there's small blood vessels, vasovasorum. So of course, there's going to be some contribution of small blood vessels to the macrovascular disease, but that's not what's causing plaques in your coronary arteries, okay? So I think the mechanisms are very different.
Ralph, we have also some other question. Dr. Dharmendra, do you want to ask yourself, you said, do you recommend to use HOMA-IR follow-up in diabetes metabolic syndrome management? Do you want to comment on that also?
Me, yeah. So, I mean, HOMA-IR is, it depends on how sophisticated you want to get. So HOMA-IR is pretty easy to measure, you know, you just need a fasting glucose and a fasting insulin. And, you know, over the years, we've shown it, actually, Amalia's been involved in some of these studies. HOMA-IR agrees with, you know, it agrees with the insulin clamp. It agrees with the Matsuda index. So I think it's not an unreasonable measure of insulin resistance. I'm not sure it's very helpful in diabetic patients. Why? Because all diabetic patients are insulin resistant, okay? So if you say you lose weight and you want to follow HOMA-IR, it'll get better. But if the patient losing weight, you pretty much can guess that they're getting better. But it's a pretty simple measurement. And if you want to follow it, I think it's okay. For any kind of sophisticated research study, however, I don't think it's what I would be following.
Well, as a comment to that, if you have a defect in beta cell function by high glucose, you have the same number, because even with low insulin, high glucose, or a high insulin, a relatively not so high glucose, and then you say it's insulin resistant, why actually it's insulinopenic. So the product sometimes is not so helpful in finding those that are really have a beta cell dysfunction from those that are mainly insulin resistant. You know, the OGDD that in most of the countries you cannot do it, or a meal test where you will see if they have a lower response, or probably much better at least. Yes, yeah. Rucha.
So Amalia makes a good point, and that gets to HOMA beta. You know, yeah. If you want to use HOMA-IR as an index of insulin resistance, you just want to kind of flip where the insulin and the glucose is, and now you got HOMA beta. In my opinion, HOMA beta is worthless, and that shouldn't be used at all. Whereas I think the HOMA-IR is reasonable. But as Amalia said, depending on where you are in the natural history of diabetes, insulin and glucose are changing, so you can get kind of funny results. But early on, if you want to know someone who's insulin resistant, let's say you have a normal glucose tolerant individual, I think just measuring the fasting insulin is not too bad. This glucose is going to be normal. So HOMA-IR will be increased, but it'll be increased because the fasting insulin is up. Remember, that's what they used in the risk study. You had to have a HOMA-IR greater than 3 to get in. You could be non-diabetic. And so they basically selected people in the risk study who were insulin resistant. And remember, those were people who had a previous stroke or TIA. And you saw the dramatic effect of pioglitazone in people who were non-diabetic.
So thank you, Dr. Franzo. I think we also have joining with us some of our friends. You'll be happy to know Rodolfo is here from Mexico, and Dr. Ken Kuzi, and Dr. Neil Mehta has just joined us a little while ago from Cleveland Clinic. And I was wondering, Dr. Mehta has to leave if he has any questions before he leaves, or Rodolfo or Dr. Kuzi, if you have any questions or comments.
Hi, this is Neil Mehta. I'm a general internist from the Cleveland Clinic. That was a great talk. Thank you so much. Have a quick question from the primary care point of view. You know, most internists would probably not get into the weeds with the basic science, and they would be following guidelines, say, from the ADA or whichever organization. What would you tell them about when to start considering testing for insulin levels, insulin resistance, and even thinking, I know you mentioned it's off label, but when would they go off and start thinking about pioglitazone? Yeah. And I'm talking about the US audience and then also the audience in India. And would you say there is any difference?
I would say in general, I don't recommend for primary care physicians to be measuring insulin levels, okay? If you have someone who you get to the point that you understand what we're talking about today, and I told you that mom had an MI stroke and pop had an MI stroke, and now I have a 40-year-old person and I'm worried about them. And if you got to the point that you're thinking about treating with pioglitazone, you're not a primary care doc. You're like an endocrinologist, because you wouldn't have got to that standpoint unless you've been following this area. And again, to me, I would treat that person, okay? I would measure the insulin level. I'd probably do an OGTT. And if the insulin levels were markedly increased, I would treat that person with low-dose pioglitazone, okay? Maybe 15 milligrams. If you're asking me, do I have proof that that's going to do something? And the answer is absolutely not. The best I can tell you is the IRIS study, because in IRIS, those people had normal glucose tolerance, but they had a previous cardiovascular event. So there, I think I can convince you by showing you that study that if you have someone who's had a previous event, even though they had normal glucose tolerance, that you should treat the person with pioglitazone. There I have some hard evidence. But now, if I back it up even further, and I gave a talk on this, it's called the pre-diabetic state, okay? Because that's what you're dealing with. Normal glucose tolerance, high risk, insulin resistance, hyperinsulinemia, strong family history. Would you put the person on pioglitazone? You really have to know, this is probably not something that primary care docs are going to get involved with. This is something more that endocrinologists who are more familiar with the area would think. And my guess is, you know, since most people, even endocrinologists in the United States, don't use pioglitazone, it is probably unlikely that a primary care doc is going to use pioglitazone. I use it first-line therapy in all my patients.
So I'll push back a little bit in the sense that, you know, the person you just talked about is probably not going to see the endocrinologist. And so how are we going to intervene in this group, or do we wait for a trial?
You know, no one will do the trial because pioglitazone is generic, okay? And Takeda has moved out of the United States. And unfortunately, the proactive study, if the proactive study had turned out to be positive, okay, Takeda would be here and we would have had this study a long time ago. So now they're not here, so we're not going to have this study. And it is truly the only insulin sensitizing drug that we have. We have the risk study, that's it. And then we have what I believe is an understanding of the pathophysiology of the disease. That's what you have to make the decision on. Of course, in that person I'm talking about, you're going to look if there's any evidence of dyslipidemia or any evidence of hypertension. You're going to try to correct all these things because you're really worried about that person. You're going to try to get him to lose weight, you know. But still, I'm worried that the insulin resistance and hyperinsulinemia are playing a very important role here. So the decision for me to make is, yes, I would probably treat that person. The decision for an internal medicine doctor to make, I think, would be probably no, because I don't understand enough about it.
Great. Thank you so much. Appreciate that.
Sorry, I can't give you a definitive answer, but we don't have if we had a study, there would be a definitive answer.
No, I agree. I think the point I'm trying to make is internists do see a lot of these cases. Family medicine docs see a lot of these cases. They also follow families. And often they will, after 20 years, they'll have a parent who had these events say, Doc, will you take care of my son? He's now an adult, right? And theoretically, that's the group. Data or no data, I mean, on the other hand, what is the risk, right? So you think about the principle that it's just like masks, they don't hurt. So data or no data, we should use them in COVID. So should we split a 15 milligram pill and put people, the type of person you described, should an internist do that? Because we won't have trial and the person's never going to see an endocrinologist till it's too late. I think that's the point I'm trying to make.
It's a difficult problem. So you just have to be familiar with the area, and then you'll either come to the conclusion that I've come to, that they should be treated, or you'll say, I don't feel comfortable treating them. I don't know the area well enough, and you won't treat them. And also, glitazone has, you know, some stigmata that is attached to it. I don't want to get into a big discussion about that. Many more misconceptions about glitazone than any other drug, which is also heard it in the general community as well as even in the diabetes community.
Thank you.
Can I just ask a very similar question, very clinical one? I'm a cardiologist and I see patients whose angioplasty I have done and the family. I have patients spanning 2 or 3 generations even, where we have treated with angioplasty and bypass surgery. So some of these families, right now we are screening their young generation with lipid profile, in general body weight and clinical assessment, as well as lipoprotein little a. This is our typical evaluation protocol for young coronary artery disease patients and their families. Do you think we should add something like fasting plasma insulin level or HOMO-IR, or do we need to screen them in any other way when they are not diabetic, their GTT is normal? Do we need to add any other test?
Well, if you're screening them, I definitely would add the insulin level. And of course, you're getting a glucose. So, you know, HOMA-IR is not a bad index, okay, for this kind of screening. Now, what you do with the data, you know, we've just had this discussion. That's a little bit more difficult. So if you really believe that insulin resistance is contributing to the atherosclerosis, then you might consider treating the person with glitazone. But, you know, if they're children or young kids, that's a whole nother issue because there really no data with glitazone. Takeda never did these kind of studies. So again, it would be very nice to have these data and you follow these people up. Maybe what you'd see is that insulin resistance in this population is a strong predictor. I'm sure you will, because as I showed you with all those other studies, the ARIC study, the Botnia study, the Bruneck study, they all showed that insulin resistance predicts, at least in adults, who's going to have an MI or stroke 5 to 10 years later. But we haven't done anything about treating it.
As a cardiologist, when do I dabble with the treatment of patient? When do I stop that pioglitazone? After the event, LV is down. LV is, after an anterior MI, is 35 or thereabouts, not in overt heart failure, still doing well. And such a patient, he's on pioglitazone as well. because the
Yeah.
diabetologist has started it, impressed with your talk. So also I would start it after
Yeah.
I heard you. Now,
Well,
when
probably
do I stop it? Or just that I do not have the monies to get him onto an SGLT2 inhibitor. Do I
Right.
stop it? And when?
Well, what we know is from the the IRIS study, it works for upwards of 5 years, okay? Because that's what the study went on for. Now, what would happen after 5 years? There really are no studies following up after 5 years. The biggest issue I would say is in terms of side effects, what I would be worried about is in postmenopausal ladies, okay? There is an increased incidence of fractures in the long bones, usually related to trauma. It's not hips, it's not spine. So if you are going to treat a postmenopausal woman, then you are obligated to have bone mineral density, which you should be getting anyway. And if there's a decrease in bone mineral density, I actually wouldn't use the pioglitazone at all, okay? But in premenopausal women and in men, you don't have to worry so much about this fracture issue. So that would be my one concern about the pioglitazone. And of course, we don't know the dose, but in the IRIS study, the mean dose was 30 milligrams. And in fact, hopefully someday, Dr. Inzucci will publish the data where they give us the plot of dose of pioglitazone versus cardiovascular events. That data are not out there, but the mean dose was 30. So that means there's some people who were above 30, some people below 30, but we don't know how the dose relates to the reduction in cardiovascular events. And that would be very helpful information.
Okay, but I should not be concerned about the LV function, is it? I'm not talking about the postmenopausal woman. I'm talking about a patient who is on pioglitazone. The diabetologist has started it. When am I justified in stopping the pioglitazone after an event?
Yeah.
Which made his LV go down. He's not in overt heart failure yet.
This drug does not do anything bad to systolic function. You should read the paper that we published in Diabetes Care, okay? So if anything, systolic function is unchanged or improves, and diastolic function improves dramatically. You know, there's a lot of discussion now about heart failure with preserved ejection fraction. Nothing works there, okay? Why? That is, in my opinion, the metabolic syndrome. That is 30 or 40 years of obesity, diabetes, hypertension, inflammation, etc. To think that you're going to give a drug like an SGLT2 inhibitor that works in heart failure with reduced ejection fraction in 2 months, this is not going to happen in heart failure with preserved ejection fraction. But something like pioglitazone, which collectively reverses every component of the metabolic syndrome, actually might be a good drug. And in fact, what we showed is that diastolic dysfunction gets better. So if you have a person who's on the drug, you know, I wouldn't be using it in people with class 3, 4 heart failure. That's out of the question. But if they have, you know, an ejection fraction that's above 55, or they maybe have mild symptoms, the problem is pioglitazone works on the kidney to make you retain fluid. That's the problem. So as long as you're not retaining fluid, you're not putting the heart at risk. So in our patients, if we see fluid, you have 2 choices. First choice, put them on a diuretic. And distal acting diuretics work better than loop diuretics. If you cannot get rid of the fluid, you can lower the dose of pioglitazone. If you still cannot get rid of the edema, you should stop the pioglitazone, okay? We know what the problem is. It's fluid overload, okay? So don't go above 30. 15's better than 30, okay? And then if you got fluid, make sure you get rid of the fluid. And we have ways of getting rid of the fluid.
Okay.
Hi, Dr. DeFranco. If I may just ask a question. I'm Dr. Purvi from Mumbai, and I'm a diabetologist. So the kind of patients that Dr. Samir just described, you know, where he's screening the 2nd and 3rd generation for metabolic syndrome, do you think adding in an HSCRP or any other inflammatory biomarkers would help?
My guess is that the CRP is not going to be increased, okay? That's a guess, all right? Adding it in is pretty simple. You know, once you draw the blood, you can always add in. So it is an inflammatory marker. I do believe that inflammation is an integral part of atherosclerosis. It's also an integral part of diabetes. Since we don't have this information, I think it would be worthwhile adding in. If you're asking me, is it going to be abnormal? Now, this is just a guess. I would say probably not, because it's very early in the stage. But that's just a total guess. But there's nothing wrong with collecting the data.
Very, very stimulating discussion, disruptive discussion, and we're all charged up with that. Thank you. Thank you so much.
Ralph, there are questions from the audience. How can we use the data from a DAPA heart failure, and especially the one that are slowing the progression to type 2 diabetes? And then metformin first or SGLT2 first? And why VertiCV results are different? Too long, okay. I know. Short answer, because it's very late for them.
Yeah, I know. So first, for those of you, I think most people listening in know, I brought metformin to the United States in 1995. So I like metformin, but it's really number 4 on my list of good drugs. I would rate SGLT2 inhibitors above metformin. I would rate GLP-1 receptor agonists above metformin. I would rate pioglitazone above metformin. The data from DAPA Heart, I think, are very intriguing, okay? So it clearly shows that there's a dramatic effect. If you have heart failure with reduced ejection fraction, and I put you on dapagliflozin, there's a dramatic effect, the decrease, well, the 3 endpoints were hospitalization for heart failure, emergency room visits for heart failure, cardiovascular events. Each 3 of them are markedly decreased. So if you have someone with heart failure with reduced ejection fraction, they should be on dapagliflozin. Now, I know that they got approval, but quite frankly, and I know people have heard me talk, I think that, you know, the drugs, they all do the same thing. At least DAPA, Cana, and EMPA. Now, the other thing that Amalia points out is in DAPA Heart, they looked at emergence of new cases of diabetes. And there was a quite impressive reduction in new cases of diabetes, suggesting there's a protective effect here. There is no formal official study looking at treating people with prediabetes with dapagliflozin to see if we can prevent the progression to type 2 diabetes. We're actually doing that study right now. I'm doing it because I think it'll be positive, but I don't have the results for you. But the data from DAPA Heart, in my opinion, are quite impressive.
There is a question from Dr. Vinod Mittal from Delhi, and he's asked you, can we start pioglitazone in young adults who are more than 18 years and having prediabetes?
Well, I think the answer to that is yes, but you know, there really are no really good data in young. Well, first, there's nothing in kids at all. So remember, these are nuclear transcription factors. So in the prepubertal age, to me, I would never use them, okay? In kids who are 18, 20, 25, there really is very little information. Now, having said that, for those of you who have been following what's going on now in the pediatric field, there are very good data from Sylvia Arslavian in Pennsylvania, Sonia Caprio at Yale, Stephen Kahn, that complications are devastating in these people. And the ability to control these kids, these type 2 diabetic kids, is a huge problem. They don't respond to metformin. In fact, they respond very, very poorly. They don't respond to insulin. So we've had some discussion, Jane Lynch and myself, of taking that population. These kids are now adults, so they've had the disease a long term, but to treat them with the GLP-1 receptor agonist plus pioglitazone and SGLT2 inhibitor, because nothing works in these young kids. The standard therapy doesn't work, and they get devastating complications. And in that study, 3 of the kids have already had MIs. And so there's also an increased incidence of cardiovascular disease. So what we're doing does not work. So is it reasonable to start looking at other things like pioglitazone in this group? SGLT2 inhibitors, you know, yeah, absolutely. But, you know, there's a paucity of data in this population.
Thank you.
So the another question is, will metabolic syndrome association with body composition might help to address the prevention aspect?
Oh, absolutely. I mean, you know, and I think this goes back to what Bob Chilton said earlier. Give everybody semaglutide. You know, they lose 15% of their body weight. That's like, as Amalia said earlier, that's like bypass surgery. Everything gets better, you know, so no matter what you look at, whether it's diabetes, whether it's their blood pressure, their dyslipidemia, decreased incidence of cardiovascular disease, probably a decreased incidence of cancer, etc. So yeah, that's a fantastic treatment. And you also improve insulin sensitivity, although it's indirect.
There's another question from Dr. Yagnik, and he's asking you, any comment on why fenofibrate reduced retinopathy?
I don't know, but the effect is really, I would say, quite modest. And I think it was a surprising observation, quite frankly. And of course, the drug really has not gained much usage because none of us believe that triglycerides are playing a major role. I don't know, Bob Chilton is there. He might want to comment about treating triglycerides and, you know, fenofibrate, or maybe he has some insight into the retina and into the eye problem.
Yeah, I don't have a lot, but the actual fenofibrate trials were negative, but the crossover rate was 20% to statin, so it kind of washes out. I think the better treatment is to lose weight. That's the bottom line, you know, and it's all, to me, like Ralph said, it's insulin resistant driven. Go after the insulin resistance and do everything you can to improve it, because that is a cellular defect that is going to cause, in time, atherosclerosis really bad.
I don't know if anybody's listening in has some better insight about retinopathy and fenofibrates, they can chime in.
I have a comment, Ralph, about this,
I think
the
it's getting
atherosclerotic effect of pioglitazone atherosclerosis in pre-diabetic patients.
Yeah.
In the ACT NOW study, remember, we did look at the intima media thickness, and pioglitazone did decrease the intima media thickness.
Yeah.
And the other thing is the weight gain with pioglitazone is that it moves the fat out of the visceral fat to the subcutaneous, which is healthy fat. And also there's some studies showing that the more weight you gain, the more insulin sensitive you become. So that's just a comment.
Yeah, and I just amplify on that. So in this study that Devjit and I and Peter Reven did, there was a follow-up paper that we showed that if you look at carotid intermedial thickness, the benefit could not be explained by a decrease in any of the standard cardiovascular risk factors. And again, I think that's consistent with the, with the study that we've been talking about in the people who've had a previous stroke or a TIA, and showing the benefit of pioglitazone.
Okay. Any other question?
So for PCOS, this is Dr. Purvi again. So for PCOS, what would your choice of drug be? Metformin, pioglitazone, or exercise?
I think we lost our speaker.
I just shut my phone off, okay?
Okay.
It's the home phone. If my
thought
home
he's
phone
running
rings,
away.
it's somebody trying to sell something anyway. So PCOS. So I have to take you back 30 years, okay, to John Nestler. So it depends on why you're treating the person with PCOS. But if you would like the person now to become fertile, the best treatment for PCOS is clomiphene plus metformin, okay? Clomiphene plus pioglitazone also works. It was not quite as good as clomiphene plus metformin. And then you now run the risk, if the patient now becomes fertile, they're on pioglitazone, and pioglitazone is not approved for treatment of someone who is pregnant, okay? If you want now, if you have someone who has pre-diabetes or they have diabetes and you want to treat the diabetes and get rid of the insulin resistance, the best treatment would be pioglitazone. So it kind of depends on what are you after here. Are you trying to get the lady to become fertile, or are you trying to treat is sort of underlying prediabetes or diabetes.
Okay.
Any further question? So I let Rucha to conclude. I think this is the last speech of the day because it's very late for you in India.
Thank you so much, Dr. DeFranco. That was wonderful. Thank you, Dr. Chilton, Dr. Tripathi, Amalia, Dr. Sanjay Agarwal. I also think is Dr. Prafulla is still there. I see him. And everybody else who has joined and stayed with us. And the audience room is still packed. We had more than 2,000 delegates listening to this interaction. So it was wonderful. We end our first day of sessions for the cardiometabolic conclave, but we invite you back tomorrow in the morning at 11 o'clock. We have the research presentations from 11 to 12:30 happening in the Mahatama Gandhi Hall. We have selected 11 oral panelists for the finals. And then at 1:30, resume the main scientific sessions with a plenary talk by Dr. Roy Taylor, who will talk about the twin cycle hypothesis and reversal diabetes and the cardiometabolic syndrome. And after the whole day, tomorrow again, we see you back, Dr. DeFranco, but you don't have to do screen share, but you'll be chairing Dr. Steve Neeson's talk. And I think we had 2 CRP questions. So it'll be wonderful to actually hear right from Dr. Steve Neeson and have a good discussion again tomorrow night. So thank you again, everybody. And with this, we close the sessions for today. And I look forward to seeing all of you again tomorrow. Thank you so much. Thank you, everybody. Dr. Dani is just had to step out. I don't see him there. So I'll close the session today. Thank you.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.
Bye-bye. Thank you. Good night.
Thank you all.
And have a good rest of the weekend for some of you.